todos. Good morning, everyone. Vamos a empezar con la sesión de hoy.
Good morning. We're going to start with today's session, and so we're going to have a few short talks, and after that we're going to turn to the case studies. So, let's begin. The first speaker, Dr. Andalone, will explain how to introduce EOS-guided gallbladder drainage.
Thank you, everybody, and thank you, the organization, for the invitation also this year. It's always a pleasure to be here in Valladolid, the place that I consider the heart of European interventional EUS. And the first topic is not a technical topic, actually. I'm not going to speak deeply into technical advice for gallbladder drainage, either because it's not the topic and because the one that will come after me is Uzma Siddiqui, that is the best, so we are waiting for your presentation. We are speaking more about the general condition of our patients because we should be aware that every technical aspect, every interventional that we act on our patients should be focused on the patient itself, patient centricity. So we know pretty well that nowadays the age of our patient is rising. Here you can see that in Italy, as well as in Spain and in Europe, the mean age of our patient is higher than 80 years old. That means that day by day we are facing more and more with elderly patients. But maybe we should think that it's not only a matter of age, because even if you are 80 or more, you may be very fit as a patient. Probably we need to focus on the general condition of the patient, analyzing the presence of some frailty in his condition. Frailty patients are not related only to the age, but also to other conditions like cardiovascular condition, chronic pathology, the obesity, the presence of neoplasm, but also the therapy that we are taking. So not only comorbidity, but also what kind of therapy the patient is taking. And as we may know, look, this is the market of the global anticoagulants that is rising year by year. So again, day by day, we are facing more and more with elderly patients, very compromised patients, comorbidity, and very, very difficult to treat condition. We are lucky. We can analyze the frailty of the patient thanks to the presence of different score systems. We have the Karnowski one, we have the Charleston, we have the ASA score. Of course, each of them is good for something and less good for other things, but definitely for us it's quite a mess when we have to face such a condition. Recently, especially for the condition of acute cholecystitis in fragile patients, a new score came, that is the POSSUM score from the World Society of Emergency Surgery, that is very, very accurate in evaluating patients who will not benefit from a surgical approach. But to be honest, in our life, we need to think about our patients. For frail patients, our target should be how can I get the patient to his previous condition. Think about this elderly man. He is frail, but he has a nice life. He can have acute cholecystitis. How can we get him back to his previous condition after the pathway in the hospital? So when we have acute cholecystitis in fragile patients, we have to bear in mind that the director of the movie is still the surgeon. And the reason is because the early video laparoscopic cholecystectomy remain the gold standard for this condition. But since we are facing very complex patients, we may have a condition in which the patient is considered high risk for surgical approach. So I think that when we have such a patient that nobody wants to touch, nobody wants to see, we can start to call our gallbladder team. In each hospital, we should have this team working in an acute way, because acute cholecystitis is not like the pancreatic tumor that you can wait for the multidisciplinary approach on the Tuesday afternoon to discuss. You need to discuss quickly in that moment. So we need to have on board, of course, the surgeon that will be the director of the movie, the endoscopist, because we are now able to treat this condition as well, the radiologist, and even more important, the anesthesiologist, that at the end is the one that decides if the patient goes into the operating room or into the endoscopic room. So try to have your own in-hospital pathway already discussed before the condition came. You should start before at the table with your colleagues discussing how to get in this condition, how to cope with this condition, how to analyze the frailty of the patient. So very important to have internal pathway, very important to be able to grading the cholecystitis, and of course, very important to assess the frailty of that patient. So when you have acute cholecystitis, you have to check the frailty of the patient. If the patient is frail, you may have to consider how to drain the gallbladder in a non-surgical way. Basically, we are aiming to convert a septic condition in non-septic condition. We are lucky because in the past we were facing only one possibility, the percutaneous approach. But nowadays we have many other options, and EUS-guided gallbladder drainage is one of them. So considering the drainage of gallbladder, as alternative to surgery, we have either the percutaneous or the endoscopic. From the endoscopic point of view, we have the transpapillary or the transmural. Of course, the transmural is now also inside the revised Tokyo guidelines as an alternative in specific condition. But after the revised Tokyo guidelines, many other papers, many other experience on EUS-guided gallbladder drainage came, so that now we have also this possibility even in the ESG guidelines. Moreover, in the ESG guidelines, EUS-guided gallbladder drainage should be preferred over the percutaneous one when present in your hospital. And that is why, basically, technical and clinical success are the same, but EUS-guided gallbladder drainage has less adverse events, and even more important, it reduces the hospital stay, reduce the risk of reintervention and of readmission of such a complex patients. So very important to analyze the condition of the patient and probably also the anatomical aspect. I strongly suggest to have a CT scan done always in order to understand what are we facing. In this condition, we have a fragile patient, elderly, comorbidity, and we have also a particular condition of the gallbladder that is already perforated with an abscess. And this should not be considered as a contraindication for any kind of approach, but should be considered cautiously with your gallbladder team. So, cholecystitis grading, frailty status, and evaluate your resources, because maybe even in the same hospital, you are not having the same possibility depending on what and when you are facing. Because Monday morning, maybe you have everything, Saturday evening, maybe not. So try to get the best solution for that patient in that condition, in that moment. Percutaneous, transpapillary, don't forget about that. Both of them have very interesting positive mark. The percutaneous, you can find it basically everywhere, very easy to do, it's not cost, and high technical success. Of course, should not be considered for the long-term treatment of the patients. And what about the transpapillary? Yes, quite difficult sometimes. It offers the patient a risk connected to the ERCP, but in specific conditions like the concomitant gallbladder and common bile duct stones present could be a very interesting possibility. Because we have to bear in mind that we are facing a patient, not only a technical aspect. So if the patient has the concomitant presence of common bile duct stones and gallbladder stones, you may ask for a transpapillary approach. And again, it's very important to discuss this with your gallbladder team in order to understand if this patient then will be candidate for surgery. But one more thing, we should not consider one technique against the other. We should think about how to get the best solution for our patient. And this is something that I like it very much, the possibility of conversion from a percutaneous to a EOS-guided gallbladder drainage. And this is very important because if you have a patient on Saturday night in a place where you cannot have the EOS-guided gallbladder drainage, you can easily drain it with a percutaneous and send to a central hospital in a few days. This could be a nice idea also to build an outpatient pathway, not only an inpatient. Think about the possibility of raising a networking in order to have the patient send it after a percutaneous approach. The percutaneous approach will allow you to fill the gallbladder with contrast, with water, and to do a nice and easy EOS-guided gallbladder drainage. You can remove the percutaneous drainage soon after it, and the patient is done. What about a long-term period? Comparing EOS-guided gallbladder drainage with Lumina posimetal stent, with percutaneous? Well, very interesting data from the DRAG-1 study by Anthony Teo. We have less adverse events after 1 year and less recurrence of cholecystitis after 1 year. So, the EOS-guided approach could be considered for the long-term treatment of these patients. And what about the surgeon? We don't need surgeon anymore? Well, not at all. The surgeon should be your best friend. Basically, video laparoscopic cholecystectomy is still the gold standard. But again, for fragile patients, very interesting. Again, from Anthony Teo, this is a propensity matched score analysis comparing EOS-guided gallbladder drainage with LAMS and video laparoscopic cholecystectomy. After 1 year, the same technical success, the same clinical success, and more important, the same low recurrence of cholecystitis. So probably in such a situation, we may think also about EOS-guided gallbladder drainage in order to give the patient the possibility to come back quickly to his previous status. Last but not least, gallbladder could be a target also in other conditions, like the one that we have when we are not able to drain the bile duct in a distal malignant biliary obstruction, either transpapillary or transmural with a choledochoduodenostomy. It can happen. So gallbladder could be a nice target. And it's always important to know if the gallbladder is inside because, as we have shown in this recently published paper done by our group, IUS, we can have high technical success and, even more important, high clinical success with a drop in bilirubin. And I want to stress a little bit also about the opportunity of having the gallbladder also when you are training people, because gallbladder could be an easy way to go if you are not familiar with bile duct drainage. So, my friend, it's very important to identify the right patient for the right treatment. Classify, use your score, analyze the frailty condition. We have different possibilities for non-surgical gallbladder drainage. We should know all of them. We should know when they are present. We should know if in our hospital we have that, and we should decide before we face the condition, which one to apply in which patient. So multidisciplinary approach. And try to have your pathway already discussed. Of course, US-guided gallbladder drainage as a rescue could be a nice way to get rid from a problem when you are not able to drain. As far as the acute cholecystitis is concerned, we still need data comparing this procedure with videolaparoscopic cholecystectomy. So waiting for the next Viado Live to discuss about that. But definitely, I think the big difference in treating this patient is made by having your gallbladder team always ready in your hospital. Thank you very much.
Haremos las preguntas todas.
We will have the questions all at the end. Yes, Ramon? Yes.
Perfecto, sí. At the end of CDK presentation, yes? Yes? Or what's...
All right. Buenos dias, everyone. My name
Good morning. I'm Usma Siddiqui. I'm at the...
is giving me the opportunity to speak today, but I do not thank him for letting me go second after Dr. Androloni, because I do have a little bit of overlap with some of the data that he presented, but that just means I'll get through my talk quicker. And my goal is to go a little bit more in depth in terms of how to do the actual EUS-guided gallbladder drainage procedure. And you already heard about all of this: lap cholecystectomies, first-line treatment for acute cholecystitis, and then we have a few options for non-operable drainage. The percutaneous drain, as you know, has more reinterventions than EUS-guided gallbladder drainage with similar efficacy, so it's better. Compared to transpapillary cystic duct stents, oftentimes if you have an occluded cystic duct, you can't navigate a stent around it, and you get stent migration and recurrent cholecystitis. So here, EUS-guided gallbladder drainage has been shown to have higher technical and clinical success rates with less recurrent cholecystitis. Now, EUS-guided gallbladder drainage was first described in 2007 by Todd Barron, where he used double pigtail stents. But similar to pancreatic fluid collection drainage, the techniques and devices have evolved over the years to where we now use lumen-opposing metal stents, specifically cautery-enhanced LAM stents that was first described in 2014 by our surgical colleague in Hong Kong, Dr. Anthony Teo, who's probably published the most on this topic. And everyone, I'm sure, in the room who uses LAMs knows that the advantage that you have with these stents compared to typical stents that are used for ERCP biliary drainage are that now you have very short lengths with large diameter flanges that are really good at creating lumen apposition, prevent migration, and you have track maintenance, so you can easily go in and out with a standard endoscope in the larger caliber 15 and 20 millimeter stents for repeat interventions. And probably for those of us who use them, we like the easy deployment, especially with cautery-enhanced LAMs. You can do a freehand deployment where you don't need fluoroscopy, dilation, or guide wires. So everything can be done under EUS guidance, and it's a very easy procedure to do. And in the US, back in August, cautery-enhanced LAMs were FDA approved for gallbladder drainage, so I'm sure we're going to see increasing use of this technique in the US. But as mentioned multiple times earlier, you do need to have a multidisciplinary discussion with your surgeons, and we are reserving this technique mainly for non-surgical candidates. So I'll show a few videos in my talk, and we'll go over technique, the stent type, diameter, location of placement. Most of these decisions are going to be made on the endoscopist's preference over actual data. And this is just a video showing wire-guided technique. First you see puncture with a 19-gauge needle, then a wire is coiled inside the gallbladder, and then you'll see the LAMS cautery-assisted device being put into the gallbladder. Distal flange is deployed, and then we're going to deploy our proximal flange. So obviously before the procedure happens, there are a few considerations. You want to review imaging. I agree with Andrea that a CAT scan is helpful because you can see if you have a very distended gallbladder. And the goal is to have it as close to the GI tract as possible. Usually under EUS vision, you like to have it less than 10 millimeters from the GI tract wall, but I would say closer the better. So even if it's maybe, less than 5 millimeters, that's ideal. In terms of patient positioning, usually I'll do it left lateral, but if you're going to use fluoroscopy, supine is preferred because it's easier to interpret your fluoroscopy images. Always give IV antibiotics, but most of these patients are already going to be on it if they have acute cholecystitis. And at our center, the patients are typically intubated for all drainage procedures. In terms of technique, and again, I'm going to focus on LAMS placement, you can go non-cautery enhanced, but then you have to puncture with the needle, pass a wire, dilate, and then place your stent. And then cautery enhanced LAMS are obviously the most popular choice because of the ease of use. And you saw the needle puncture with wire technique versus now, usually I'll do it with a freehand technique without any wire guidance. The wire is obviously helpful for salvage maneuvers, so if for whatever reason there's an angulation or some concern that the puncture might be a little bit more complicated, it's probably better to put a wire. Otherwise, freehand is the usual way to go. For size of your LAMS, if there's no stones, you could go with a smaller caliber stent that's 10 millimeters. But if there's stones and you're going to go back and treat them, then I would usually put a 15 or 20 millimeter LAMS stent. People have looked at putting double pigtail stents through the LAMS, but to date, there's really no clear benefit to doing that. The thinking with putting these are that you're going to prevent occlusion of the stent and perhaps prevent migration, but the data doesn't show that. What about the reported adverse events in general? You can have bleeding. There can be, if you traverse a blood vessel, you can have delayed bleeding, or sometimes, especially with the larger 20 millimeter stents, we've seen ulceration and bleeding on the luminal side. Tissue overgrowth, stent misdeployment, where you get bile leak and peritonitis, perforation, stent migration, and stent occlusion, which leads to recurrent cholecystitis. But does the location of where you place the stent affect your outcomes? In the antrum, people like to put their stents because you're going into the body of the gallbladder, so you have a bigger target to hit. But that location is a little bit more prone to occlusion from food. And also, as you see in this picture, there are reports of severe tissue overgrowth. And also, there are a lot of contractile forces in the antrum. So you might get inward stent migration into the gallbladder. But an advantage here is if there's a complication or if the patient goes to cholecystectomy later, surgical access to the distal stomach is easier. But a lot of us like to put the stents preferentially in the duodenal bulb. Here you're going usually into the gallbladder neck, but the duodenum's a little bit more stable than the distal stomach for your stent deployment. But in theory, it might be harder for the surgeons to close that defect later if the patient goes to surgery. But the data shows It doesn't really matter where you put the stent. So for me, I just go wherever the wall of the gallbladder is closest to the GI tract. What about follow-up after you put the stents? In our center, most of these are done in advanced cancer patients, so I just leave the LAMs indefinitely. But otherwise, you can, after 3 to 4 weeks, once a tract is formed, you can go back in and clear the stones with some of your ERCP techniques, with baskets, lithotripsy, and clear the gallbladder of all stones. And you could consider leaving 1 or 2 pigtail stents after you remove the LAMs to prevent recurrent cholecystitis. But the problem here is there's really no standardized protocol at all on how we follow up these patients, and that's something that if we're going to start doing this more often, we need to hopefully figure out. But when do you want to think twice about putting in LAMs and doing a gallbladder drainage? Again, this was mentioned earlier, but if there's evidence on imaging that there's a perforated gallbladder or the patient already has biliary pancreatitis, do not do EUS guided drainage. Some relative contraindications that can make your procedure difficult are if the gallbladder is very distant from the GI lumen wall, you have a very small contracted gallbladder, intervening vessels, large volume ascites. You can do a paracentesis ahead of time and then do the drainage, but again, be careful. And if the patient's going to go to surgery later, you need to make sure your surgeons are on board with you doing this. So here's a video where I ignored everything I just told you and thought I will do this drainage. So you can see, first of all, this gallbladder is very small, very contracted, and very far from the GI tract wall. But I decided to go ahead and try. And I'm in the distal stomach here. The patient had a duodenal stent from advanced pancreatic cancer. I was able to get the distal flange into this contracted gallbladder. But then when I start trying to pull back to deploy the proximal flange, I struggle a lot and I cannot pull the gallbladder close to the GI tract wall. And as I'm doing that, there was so much tension that the LAMs just deployed on its own without me doing anything. But I was like, oh, it's a little bit in the stomach. I'll just gently bring the flange out. But then it was a little bit too much. And so you see there is a perforation there. So in this particular case, I'm not Manolo, so I did not go into the peritoneum and grab the gallbladder, but I used a Vesco and closed the defect in the stomach. I actually had a surgeon who said, I'll try to do a laparoscopic cholecystectomy on this patient, but he couldn't do it because the gallbladder was so involved with tumor and tacked down, so the patient got a percutaneous drain. But again, I think if you pay attention ahead of time, you can avoid this mistake. And then recently this year, under Cheyenne Arani, who also has published a lot on this topic, we published this article trying to provide some guidance on which patients can benefit from EUS-guided drainage. So again, if you think there's a gallbladder perforation or the patient can undergo sedation, then they should go for a percutaneous drain. If there's no perforation on imaging, patient can tolerate sedation, then you can go with your transpapillary stent, especially if there's a lot of ascites or you're already doing the ERCP for CVD stone removal, or the gallbladder is very distant from the GI tract wall, or the EUS-guided gallbladder drainage. And then again, if that fails, then you can go back to percutaneous. The issues to consider: if you can perform gallbladder drainage after percutaneous drain, you saw that we can, and then should we be performing this technique in surgically fit patients? So contrary to what Andrea said, I won't say in every case it's really easy to distend the gallbladder like you showed, especially with more time. After the patient's had the percutaneous drain, the gallbladder can get really fibrotic, contracted, and make it harder for you to puncture. And you have to be really careful that you don't overfill, because you can also cause a perforation from doing that itself. So you can do it, but more data is probably needed to standardize our technique. And then anecdotally, cholecystectomy after EUS-guided gallbladder, there's supposed to be significant adhesions, difficulty in repairing the GI tract at the site of the lambs when it's removed. So again, mainly inoperable candidates are the ones we're offering this to. But if the patient is going to go for cholecystectomy afterwards, maybe consider transgastric placement, because again, that's easier access for the surgeons, but we don't really know, again, which one is better based on available data. There was one study from Amy Tyberg and Michelle Cahela's group that was published earlier this year, and they looked at patients who did go for cholecystectomy after EUS guided drainage and percutaneous drainage. Most of their EUS guided stents were placed in the stomach, and they showed similar success rates and adverse events, but there was a higher rate of conversion to open cholecystectomies in the percutaneous group, and longer hospital stays and higher procedure time. So in this study, EUS-guided gallbladder drainage outperformed percutaneous drainage prior to cholecystectomy. Also, this question comes up again, will we need the surgeons anymore? But we don't have standardized protocols for our patient selection techniques and how we follow up. At least in the US, we do not have enough endosonographers to take on 1 million gallbladder removals that happen currently from the surgery side. But Anthony Teo shared some data with me where they're looking at patients who were potential cholecystectomy candidates, and they want follow-up for 3 years, and so far halfway through, only 2 have subsequently required cholecystectomy. But the question becomes, if you clear all the stones, they no longer are inflamed or infected, does the gallbladder need to be removed? The malignant biliary obstruction you saw, including that great study from Binda, and this is just a video showing an example of that. This patient had advanced pancreatic cancer, came from an outside hospital, had actually already had a surgical GJ because they had duodenal obstruction, and now had jaundice. So you can see the bile duct is very dilated, but the duodenal wall is infiltrated with tumor, and it's already about 15 millimeters thick. So I couldn't do direct bile duct puncture, but they had, a very nicely distended gallbladder. As long as it's over 3-4 centimeters, you have enough room. And my preferred diameter is a 15 millimeter cautery enhanced lambs, and this is just the freehand technique. And so this was placed in the antrum. And it is close to the pylorus, which I try to avoid doing that, but this patient already had the surgical GJ, so it didn't matter. So again, EUS-guided gallbladder drainage is definitely a viable option for acute cholecystitis patients that can't undergo surgery. We do need more data on operable candidates, especially where's the optimal stent location. We can also use it to treat malignant biliary obstruction. I would caution you that although there's all different types of techniques, and endoscopists have preferences on their stent sizes and location, universally though, you do need caution and would avoid situations where the gallbladder is perforated. Be very careful if there's large volume ascites after percutaneous drains, and if you have a very small contracted gallbladder. But I think now, especially with the FDA approval in the US, we're going to see more use of this technique, and we're going to continue to gather more data, but you're always going to need careful patient selection and a multidisciplinary discussion. So thank you.
Okay,
Next speaker.
no, ahora vamos a hacer las preguntas, ¿no?
So we're going to take questions for these 2 speakers first.
Sí, dos. Sí, questions. Yes.
Any questions for the speakers?
To both of you, how long can you leave the lambs in for? I mean, what's the experience with that?
Well, nice question, and I'm really interested about hearing her answer. In the meantime, I can tell you that as far as I'm concerned, if you treat the gallbladder for a fragile patient, acute cholecystitis in fragile patient, I put the lamps and I'm not going to prepare a removal for this patient unless the patient will have any kind of problems.
Same. I mean, again, if it's frail, advanced cancer, I'm just going to put the lambs and never go back. So
How long have they stayed in for? I mean, is there a 5-year?
Well, we do not have such a long time data. We are collecting them in our database with the IUS. I think in the next few months we will have some data about long term to see what's going on, but basically it seems feasible. To be honest, there are many other experts like Anthony and other one that provide the removal of the stent after 6 to 9 months. So at the moment, I think we need more robust
also,
data.
at least, you know, Axios is the only one FDA approved in the US. So technically on their, you know, informational device pamphlet, similar to with pancreas, it's about 60 days, I think. And I don't know for gallbladder, we were saying that it's 6 weeks. But they officially put a limit on it, but as we know with necrosectomy and things, we end up keeping them longer, so. And with USGJs, a lot of people just change them once a year. I mean, the concern maybe over time, you'll get some acid exposure, some breakdown of the coating. But I've had patients who've had these stents in and have to get scoped for whatever reason, and it's been over a year and the stents are fine.
So I think this is a hot topic that needs to be solved. Basically, there are different kind of patients. At the beginning, we were treating really the high-risk patients. So probably none of them will arrive at 5 years. But nowadays, we are pushing the bar, you know, so we are treating younger patients, maybe with previous neoplastic situation that may have a better quality of life, or elderly patients that we don't know to bring to the operating room. So probably we need more robust data. Basically, there is also another important thing to understand if we need to remove stones from the lamps or not when we do this treatment. Actually, I'm not doing this routinely, but I can see that from the data from Anthony Tio, maybe this could be a good solution in order to give more space for our patients.
And I guess the other thing, the discussion with your surgeon, is the patient non-operable today or ever? So that's something to tweak out as well, so, because that can change. But we need more standardized protocols for, I think, all of these things, because there are a lot of questions. But now more and more people want to do it, so I'm sure we'll get that soon. Thank you.
And what is your opinion about cholelithiasis without cholecystitis? No, in the case that you have to drainage the gallbladder, but without the presence of cholecystitis.
You mean in an elective way?
Yes,
This is a very nice and interesting question. You are stimulating me, actually, because again, let's start saying that video laparoscopic cholecystectomy is the gold standard. But probably we are moving towards a new era of possibility. So I would say, what do you do if a patient is 85 years old with previous cholecystitis, now is quite good, he goes to school to bring babies, he drives his car, he's able to perform everything. So what do you do in this case? Do you send him to the operating room for cholecystectomy, or maybe you can place a nice lamps for him? I'm going towards this direction, but I think it's too early to say it because, again, we need robust data.
Also, you know, what does the gallbladder look like? Is it distended? You know, these are all questions to make the procedure
Yeah,
safer.
come on, Utsma, you can do whatever you want with the gallbladder. Especially if it's not inflamed, you can distend with a needle. So we have a lot of trick anyway.
And the other thing that comes up, you know, eventually some patients come to the surgeon and say, do I really need my gallbladder removed at all? So I don't know if those kind of patients will seek you out and say, can you deal with my gallbladder non-surgically?
Let's say that from the patient perspective, we are receiving email asking us to take over the problem. So this could be also another very, very important topic to discuss.
I mean, we took over the bile duct from the surgeon, so, you know, is this going to be the next frontier?
Can I just ask one question about, like we're also trying to implement that in centers where they don't have EUS gallbladder drainage, they place a percutaneous drain and then send the patient over to us to internalize the drainage. But sometimes the patients are referred after 2 or 3 months, and we notice that the gallbladder doesn't want to extend anymore, it doesn't want to dilate. What in your opinion is the ideal timing to do this?
You have to refer it earlier. This is the opinion. And the problem is that we need to build a nice networking because we lack the networking. In my dream, there is the Monday morning session of conversion where all the places around me are sending me the percutaneous drainage that they have done during the previous week, so that I will have a room with 6 to 7 conversion, and this will be very nice also from the technical point of view to teach to other people, because you will know that on Monday morning you come to Anderloni rooms to do this. So also thinking about the future in order to give the opportunity to many other hospitals to do such an approach that is not only for the gallbladder, because we need, you know, experience with lungs. This could be also a good solution. So make a nice networking, make everybody aware about this possibility, and make the connection very easy for the doctor as well.
Agree, and this, you know, the sooner the better, but it's nice because this way everyone gets to do a procedure and you're not taking any business away from the interventional radiologist. At least in the US, they can be a little bit tricky.
So, Roy, I think the question you asked about the percutaneous, one thing that I found was you can ask the patient to clamp the percutaneous tube like 2 to 3 days in advance. So if you clamp it 2 to 3 days in advance, it distends a little bit, and if the cystic duct is plugged, then you can inject it and distend it, but if the cystic duct is open, then you can try transpapillary. So those some of the things that have helped me.
Okay. Thank you very much.
Thanks for waiting, Professor Samaracena. Will enlighten us about this easy procedure, but with so many traps in the way to perform the PPG. Please.
I'd like to thank Manolo for the kind invitation. This is definitely one of the most advanced endoscopy courses in the world, and really is a pleasure to speak to everyone this morning. My name is Jason Samaracena. I'm an interventional gastroenterologist at University of California, Irvine, and I've been charged with talking about endohepatology interventions, which to be implemented and how to succeed. Some of my disclosures. There's really been a growing number of endoscopic procedures that are pertinent to liver patients, particularly related to EUS, and we've termed this area of integration or overlap of endoscopic procedures within the practice of hepatology as endohepatology. In fact, this term was coined by my mentor, Kenneth Chang, back in 2012. And you know, we define this as the integration of endoscopy within the practice of hepatology, and I like to say this is actually just really making the liver cool for endoscopists. you know, there's a lot of different things that fall under the umbrella of endohepatology. And for the morning, I'm just going to talk about these 4 things, starting with the U.S. guided interventions for variceal bleeding. So, you know, a direct stick of gastric varices with glue, you know, is kind of the standard of care in the world. With this, there's, you know, a number of problems. This being one of them, you know, uncontrolled bleeding with poor visualization. And one of the things with EOS guided glue injection for gastric variceal bleeding, there's probably better assessment of the size, morphology. You're able to assess Doppler to evaluate flow. It does not really require any luminal visualization, and there's probably more accurate delivery of the glue. Disadvantages are there's the potential for systemic glue embolization, and to really mitigate this risk, we've developed a system where coil are used to serve as a scaffold for glue to reduce the risk of systemic embolization. These coils are really brought over from the interventional radiology world. They're made of soft platinum with synthetic fibers to promote clot formation. 0.018 coils are compatible with the 22 gauge EUS needle, and the 0.035 coils are compatible with the 19 gauge needle. There's nice videos available on how to kind of load the coils into the EUS FNA needle. A lot of this work is published by Dr. Marvin Yu. And in one of the largest and early series of gastric fundic varices and EUS guided coil embolization and glue by Dr. Binmoller, he did this in 152 patients, and really there was only a 3% rebleeding rate on follow-up. And you can see here under EUS, measurements can be made, and specific coil size can be chosen. In this case, a 20 millimeter coil was chosen prior to the application of 2 Cs of cyanoacrylate glue. One of the nice things is you can reassess after glue injection, and in this case, there was a repuncture and a placement of another 50 millimeter coil with a second glue application. This is the view after coils and glue, and a follow-up procedure 3 months later showed essentially complete obliteration of the varices, seen endoscopically as well as on EUS. One of the issues with glue, though, is it's messy, and there isn't really a commercially available kit for glue in the US. And Marvin Yu has done some work using something called Surgifoam, which is an absorbable gelatin sponge. It's a hemostatic device prepared from porcine skin gelatin. It's used routinely in surgery. It absorbs 45 times its weight of whole blood, and essentially it's an inert substance that doesn't lead to fibrosis or tissue reaction. And as you saw there in the video, you can cut up the different pieces and make it into a slurry. And so we're seeing actually maybe a transition from glue to gel foam in our unit as well. So the take-homes for EUS guided variceal and interventions, EUS may be better for assessment of size, morphology than just EGD. Using Doppler to evaluate flow doesn't require luminal visualization. The disadvantages, again, are the systemic glue embolization, but with the use of coils, we can mitigate that risk. Surgifoam may be better than glue, but one of the problems with this procedure right now is there's really no standardized training for this procedure. And with management of gastric varices, there really has to be a multidisciplinary discussion in your institution. And in our institution, we're really not doing too much of this really because our interventional radiologists feel extremely comfortable and managing these patients. And so every institution will be a little bit different with regards to that. Next, the EUS guided liver biopsy. I think we can all agree liver biopsy plays a pivotal role in the in directing the management of liver disease patients. Percutaneous liver biopsy used to be a procedure all gastroenterologists learned in the United States. Now it's no longer required and part of our curriculum. Most liver biopsies are performed by interventional radiology, usually via the internal jugular. And there is a 2.5% complication rate with IR-guided biopsies, and there's potential advantages with an US-guided liver biopsy approach. It's technically reproducible regardless of body habitus. It's possibly less painful, and the image-guided approach allows for avoidance of blood vessels and also potentially access to wide segments of liver parenchyma, and taking biopsies on the right side and the left side are also possible. And when you look at the minimal measurements, the threshold by which the liver societies sort of guide or judge a high-quality specimen, the AASLD looks at recommended length in the complete portal tracts, and a length of greater than 2 centimeters and complete portal tract number greater than 11 is what we're kind of aiming for. If you look at some of the initial work with the US guided liver biopsy by David Deal, this was a prospective multi-center study looking at 110 patients, and they used a 19-gauge straight needle with a stylet in initially and then out with full suction, 7 to 10 actuations with fanning, and their numbers were actually pretty good. A median aggregate length of 38 millimeters, median complete portal tracts of 14. This was a straight versus core needle animal study by Chris Thompson's group. With the advent of these core needles and FNB needles, this was a nice undertaking, 6 different needles, including 2 percutaneous 18-gauge needles, looking at various techniques, 1 versus 3 fanning passes, dry needle with varying suction, and they looked at complete portal tract and degree of fragmentation. This was in a human cadaveric model. So with 6 needles, 1 versus 3 fanning passes, dry needle with varying suction, there was actually 48 liver biopsies performed per needle, and the results showed that 3 fanning passes were better than 1 pass. In dry suction, there was really no significant difference between a slow pull, a 10 cc, 20 cc, or 30 cc suction. With regards to complete portal tracts and fragmentation, the shark core, the needle performed better than the others. With regards to suction, there's been some debate versus dry versus wet suction. This is another study looking at, by David Deal's group, 40 patients. Each patient had 3 successive passes, each with a different suction technique. This was a 19-gauge FNA needle. The first pass was a control pass, so it was dry. Second pass was a heparin flush, followed by an air flush and 20 cc's of suction. And the third pass was a heparin prime needle with 2 cc's of fluid in the syringe with 20 cc's of suction. And in this case, the wet suction performed better. We did a study comparing the efficacy of 2 second-generation 19-gauge FNB needles, the Francine and the fork-tip needles. This was a prospective repeated measure crossover study. We did US-guided liver biopsy with 1 pass and a single actuation method using 2 needles, and they were randomized to left versus right lobe to be biopsied and the needle sequence. So in our study, 44 liver biopsies were performed in 22 patients, and the complete portal tract number was higher in the Francine tip needle than the fork tip needle. And what we also learned was the right lobe appeared to yield higher number of complete portal tracts than the left lobe, and this was seen on both needles. So we've really seen sort of an evolution in the technique, and I think one thing we're doing now is what we're calling the new dynamic wet suction technique. And just to show you this video. So for the first pass, outside of the liver, we take off the syringe completely and then apply our first throw. We turn on the suction for about 2 seconds and close it. Now on our second pass, right before we do the throw, we open the stopcock, throw, close the stopcock, bring it back, and then we do the same thing for the third pass as well. So we open, throw, close, and then pull back. And just to kind of review that really quick, so the first pass, syringe off, throw. Syringe on, open, close, withdraw the needle back to about 1 centimeter from the capsule, open, throw, close, withdraw the needle 1 centimeter from the capsule, open, throw, close. And this small variation to the wet suction technique has made a tremendous difference in our ability to get samples. So this was what we presented at DDW this year, 31 patients over 12 months, technical success was 100%. The average fixed length now is 6.74 centimeters. The longest specimen we got was 16 centimeters. The average complete portal tract is about 23.8 per biopsy sample, and all the specimens were adequate for a diagnosis and staging fibrosis, and actually a large percentage of our patients actually had F4 fibrosis, so some of the hardest specimens to really achieve good staging. So I think the take-home for a US-guided liver biopsy, core needles versus straight, the newest core needles really appear to be superior, and technique really does matter. A single actuation may be enough, as we showed in our small study, but 3 is likely better. Fanning method is superior. Long excursions lead to more tissue, and this may be the reason why right liver may be actually better than left liver. Heparin primed needle with wet suction appears to be better than dry suction, and this new dynamic wet suction technique may be the best. So EUS-guided liver biopsies are clearly exceeding the minimum AASLD requirements, and we really need to start doing these correctly and getting the word out to our hepatologists. I just want to touch on a relatively new technology called EUS-guided shear wave technology. So vibration-controlled transient elastography, or FibroScan, uses shear wave elastography to estimate liver stiffness, and it's really a surrogate for hepatic fibrosis on liver biopsy. There are some limitations. It has a low positive predictive value. There's suboptimal performance in patients who are morbidly obese, and measurements are really only obtained over the right hepatic lobe. Now, EUS-guided shear wave elastography is performed during real-time visualization of the hepatic parenchyma. And the advantages are you get real-time visualization, allows the operator to really select an optimal spot for measurement. It can be performed in patients with morbid obesity or narrow intercostal spaces, and both the right and left hepatic lobes can be assessed with EUS shear wave as well as the spleen. And so we usually do about 10 measurements in one area of interest, in the left lobe, 10 in the right lobe, 10 in the spleen. On the neolocus, you get sort of this sort of summary. They'll give you kind of a median and mean, and we sort of take that as the measurement. So we looked at use of shear wave elastography and its correlation with hepatic fibrosis on liver biopsy. We looked at liver shear wave as well as spleen shear wave and the prediction of stage 3 or greater fibrosis. And so patients essentially had shear wave elastography performed in the same session, EUS-guided liver biopsy. We actually use the cutoffs that were previously reported in the literature based on MR elastography and other modalities. And what we found was EUS shear wave of the left lobe greater than 15, right lobe greater than 15, and a spleen greater than 26.3 was able to achieve a sensitivity of 80, specificity of 100, and a positive predictive value of 100. So I think, this is a new module on the latest EUS processes. It's real-time liver evaluation. Again, it can be performed in patients where FibroScan may not be optimal. It is very operator dependent. We're kind of formalizing a protocol right now amongst 3 other groups, but the initial data definitely is promising. I'd like to end with EUS-guided portosystemic pressure gradient measurement. The hepatic venous pressure gradient or portosystemic pressure gradient accurately reflects the degree of portal hypertension as the single best prognostic factor in liver disease. Current standard for a measurement is a interventional radiology procedure via transjugular approach. Some of the disadvantages with this are some consider this invasive. It uses ionizing radiation, and one of the biggest ones are It's an indirect measurement of the portal venous pressure. This has been looked at in the animal model over the last 20 years, Dr. Brugge, Dr. Kantsavoy, but most recently our group under the leadership of Dr. Chang came up with a novel EOS guided portal pressure gradient system using a 25 gauge FNA needle and a compact manometer. We looked at this in an animal model, and you can see here a fluoroscopic image of the EOS, a needle in the right hepatic vein of the pig with the interventional radiologist with his balloon catheter. And this is the endosonographic correlate to that. So we actually created a portal hypertension model in the pig, and we were able to compare EOS versus the standard transjugular approach, and there was an excellent correlation across a number of pressures. This is essentially the setup we used at that time: 25 gauge needle, some non-compressible tubing, and the compact manometer. And this is the heparinase saline, so the tubing is connected to the distal port of the manometer, while the heparinase saline is connected to the proximal port. And then the end of the tubing is then luer locked to the inlet of the 25 gauge needle. Pretty easy setup. You kind of level everything, zero it, and then you, during the pressure readings, the manometer is placed at the patient's mid-axillary line. So one of the reasons why this appears to be so safe is this is a transgastric, transhepatic, transparenchymal puncture of the hepatic vein as well as the portal vein. And here's a case, and you can see the EOS video of the needle puncturing the middle hepatic vein. We inject a few cc's of the heparinase saline. You'll see some bubbles on EOS, confirm good placement. At that point, the manometer pressure will increase, and then it will get lower and lower and lower till it will level out, usually after about 30 seconds or so with a reading. We then repeat the process 2 more times, another flush. We'll see the readings go up, come down, level. We'll record that, and we'll do it 1 more time. And then we'll take the needle out, and then we'll change position, and then target the left umbilical portal vein. And the same process. Inject a couple of cc's of heparinase saline. You'll see the bubbles. The pressure reading will go up. It'll come down, and we'll do that 2 more times. And so in this case, the portal venous pressure was 26, the hepatic venous pressure was 12, and the gradient was 14. So we did this initially in about 28 human subjects. There was 100% technical success with identifying and accessing the target vessels and obtaining those pressures. There was no complications. And what we were able to show was that patients with a high clinical suspicion for cirrhosis had higher pressures. Patients with varices had higher pressures. Patients with portal hypertensive gastropathy had higher pressures. We've since now done a much larger multi-center US trial looking at multiple factors with regards to portal pressure and other liver-related parameters. This got best of DDW a couple of years ago from the AASLD. You know, just to highlight a couple of points. One of the things that was very interesting was when we looked at EOS PPG and FibroScan agreement with liver histology, there were 39 patients who had concomitant PPG, FibroScan, and liver biopsy, and 19 patients with a PPG less than 5 or normal PPG was accurately characterized those patients with stage 0, 1, or 2 fibrosis, while the FibroScan was falsely elevated. When you looked at the agreement of EOS PPG with histology and elastography with histology, There was excellent agreement with portal pressure gradient measurements, but with FibroScan, there was a lot of false positives. The other interesting thing that came out of this, there were several patients that really had grade 3 and 4 fibrosis, but had no varices, no portal hypertensive gastropathy, no thrombocytopenia, and they had no other non-invasive markers of fibrosis, but the PPG was slightly elevated. And so this may tell us that PPG might be the most sensitive test for understanding if a patient has early fibrosis or cirrhosis. So for take-home points, EUS PPG provides direct measurement of both the hepatic and portal veins. HCPG is really not accurate in pre-sinusoidal portal hypertension, and I didn't get to show you this, but in NASH cirrhosis, HCPG may actually underestimate the portal venous pressure as well. I think this procedure is becoming more accessible and repeatable than HVPG, and maybe more accurate than current non-invasive markers of fibrosis. There's a commercially available device with a relatively short learning curve with formal training programs. Dr. Chang has trained over 300 with his Zoom training courses, and they're just fantastic, puts a lot of work into them. And anybody that's interested in learning should attend this course. So in final thoughts on endohepatology, I think EUS-based endohepatology procedures are really here to stay. There's growing acceptance amongst hepatologists worldwide for EUS-guided liver biopsies and EUS-guided portal systemic pressure gradient measurements. Again, more procedures are moving from IR to endoscopy. This is sort of net new business for the field, but how quickly they move to the endoscopy suite is based on local expertise and kind of local politics as well. Reimbursement for this procedure is coming soon, and happy to report, because of the advances in this kind of technology, there's really now new waves of liver research that are underway in NAFLD and drug therapy, thanks to this sort of one-stop shop endoscopic liver evaluation. Thanks very much.
Any questions? Yes, Professor Samaracena. There will be a change in the order. There is the turn of questions and answers, please. So I have 2 questions for you. First of all, regarding US-guided therapy, our group published its experience since 2007. We are, I wish to raise a note of question about the use of cyanoacrylate even when you deploy coils, because if you deploy several coils, we publish in endoscopy, and you inject a contrast, the contrast goes down to the gastrorenal shunt and up to the inferior vena cava. So you have to be very cautious to deploy, to inject cyanoacrylate, even in the case of previous coil deployment.
No, I think your comment is well taken, and it's exactly what our interventional radiologist at our group has informed us as well. I think there's theoretical risks to these procedures, and I think what we've learned from the endoscopic non-EOS experience as well as the EOS experience is that we're not seeing a ton of complications in clinical practice when this is being used. However, our interventional radiology colleagues have convinced us that this is not our space, and they have really come a long way in their technology and their understanding of the shunts, of the anatomy, and they've convinced us that they really are the experts in this particular procedure in this particular space. So we're not doing very many of these. So your comment is well taken. There is risk with even with coiling of potential embolization.
Excuse me. Thanks for the nice lecture. If you are able to do good, you give hysteracryl or the glue you have, and you make sure that you have thrombosed the vessels well. You check versus giving a coil. Is there any added advantage of the coil?
So,
You compare the two. You have your patient comes in an emergency room, you inject the glue, and you inject all of them, and you are sure that they are all hard. That compared to somebody who goes straight for a coil, is there any difference?
So to my knowledge, there hasn't been any kind of comparative trials looking at, no coiling versus coiling. I think the rationale for coiling is really sort of a logical rationale. But I think the risk of embolization is sort of the biggest concern. And I don't know if during the endoscopy or shortly after the endoscopy, you'd really have any clinical manifestations that you would be able to tell if embolization has occurred. And so I would say it seems to me that use of coil is going to be easier. Having said that, worldwide, most gastric varices are not treated with coils. And again, it seems like the risk and the prevalence of those complications are very, very low.
There are two published studies regarding this topic. They have 40% and 25% of asymptomatic glue embolism with US guide therapy, even when previous the coil deployment. So if you don't add Lipiodol and perform a CT scan further, the asymptomatic glue embolism you don't observe, but the risk exists.
Sorry, we have not enough time, and the discussion has been interesting, but we have to pass to the other colleagues.
The next talk will be from Miami by Dr. Andre on endoscopic necrosectomy. Welcome.
Good morning. I want to thank also the organizers of the course and Manolo for the invitation to this superb and outstanding course that I'm sure everybody here is enjoying as well, as much as actually as we are. So I was invited to talk about endoscopic necrosectomy, technique, evidence, and controversies. So as you can imagine, in 15 minutes, it's impossible to cover all of this information. But what I'm going to try to do is to go over the controversies that we think that nowadays we know the answer and what we should be doing. So these are my conflicts of interest. So I'm going to start by giving a little bit of an overview and trying to define the terminology of the condition that we're talking about. Frequently, when we review particular submissions to our journals, you start to realize that there's confusion still nowadays on what the different terminology means, and we'll go over that in a minute. Timing and preparation, when can we treat these patients effectively and safely, the tools, techniques that we have, so you can see how much room there is for improvement, particularly for the manufacturers of all of these toys. And of course, there's much more controversies that are impossible to cover. And I'm going to show you also some of the complications that I have personally saw, that I have seen, that I have had, and that some of my colleagues have had over time. I was lucky for the preparation of this talk. There's a very good recent review of endoscopic therapy for world of necrosis that I strongly recommend you see, you read, if you're embarking in this type of procedures. So the controversies that I thought were going to be more relevant to go about today are what you see here. What exactly means world of necrosis? What's the best timing to treat these patients? What's the type of imaging that we should be using? How do we quantify the amount of solid content of these collections? What's the best timing and what's the preparation for drainage that we need to do? What are the tools, the techniques? When to remove the lumina-posting metal stents. This is something that is super important. When to leave a plastic stent, and I hope that I'm going to make this clear today. and many others, for example, that I'm not going to be covering today, that are super important to remember, are diabetes and exocrine pancreatic insufficiency. I recently got a picture of what you see here in the lower right part of the picture. I don't know how well it's projecting, but that's a patient with severe steatorrhea a year after necrosectomy. So there's many publications already out in the literature that approximately 50% of patients that undergo a necrosectomy, direct endoscopic necrosectomies, will develop diabetes, will develop exocrine pancreatic insufficiency. So pay attention not only at the endoscopic part, but also at the patient as a whole and the patient's outcome. So I'm not going to go into definitions. I'm going to leave the presentation actually, so whoever wants it, I'll be happy to share it with you. But we need to make sure that we're talking about the same conditions. We have 3 different types of pancreatitis. Pancreatitis is defined as what you see here. Again, I'm not going to go into details, but we have 3 different types of pancreatitis. Acute, which is a patient that gets 1 episode and never again. Recurrent acute, it's a patient that gets 1 episode, completely goes back to normal, and then they get 2 or more. And chronic pancreatitis are those that have end-stage pancreatic disease. They have fibrosis, they have constant pain, they may have exocrine and or endocrine insufficiency. Any of these 3 different pancreatitis conditions may lead to severe necrotizing pancreatitis with walled-off necrosis. That is the topic of the presentation today. So in sake of time, let's go into what walled-off necrosis means. When you have pancreatitis, you have 2 different stages of the disease. You have an early stage, which is below or less than 4 weeks. Why 4 weeks? Because within the first 4 weeks, what you're going to see, it's something that it's not well organized. So if you have an acute fluid collection, which is what you see here on a CT scan with IV contrast, you see that the gland is enhancing beautifully, but you see a lot of fluid around the gland. Then you have acute necrotic collection, which again, you see IV contrast study, only the head and a little bit of the neck is isling up. Most of the body and tail are completely out. There's no capsule, there's absolutely nothing we can do. Controversial, by the way, but there's nothing we should be doing for this type of patients endoscopically. Then acute fluid collections over time may evolve into pseudocyst. And a pseudocyst, basically, it's a water-filled cavity. You see the beautiful cavity here. This is, this is begging us, to be drained. And then you have, in the other hand, walled-off necrosis, which is, again, a very organized, acute necrotic collection, approximately 4 weeks later, and you have a lot of necrotic debris. So here is one of the first controversies, and we'll go over that in a second. You see a CT scan, and you may be asking in your head, where is the necrosis? How do you know there's necrosis? And we'll go into that in just a second. Remember, that's a CT. So before we even talk about this, I think we need to give credit to people like Todd Barron, who had the first published paper on 11 patients. And what he did was to place a transmural 10 French stent and do a nasocystic irrigation until the collection was resolved. And this patient had approximately 50% necrosis in there. It worked, it had complications. We won't go over the details, but the point is that this was the first time that somebody went through the wall of the stomach to drain this type of collections. Then the first direct endoscopic necrosectomy was published by Dr. Shainford, and this is Lancet in the year 2000. This is our paper in 2011 with Tim Gardner, Todd, Marty Friedman, and others, that we published our experience of 104 patients, and this was before we were using this, before we were doing endoscopic guidance. This is way before we had luminopolsing metal stents. What we were doing at this time were patients mainly with bulges, which I'm going to show a couple of examples, and treating these patients what we call the old way. And I'll show you a case that I did actually a couple of months ago in Central America. At that time, again, without going into too much details, we did 104 patients. What I want to pay attention is that one of the patients had a severe bleeding that ended up going to interventional radiology. One patient died from air embolism. That patient was done with regular air, not with CO2. So that's a very strong take-home message to begin here. Always do these procedures with CO2. We had patients with pneumoperitoneum, perforations. We were able to treat all of them without the need of surgery. So again, going over the different controversies, again, what's Waldorf necrosis? I hope that I help answer during the first definition. You need to wait at least 4 weeks. You want to have a beautiful capsule. So it's an encapsulated collection of mixed liquid and solid content that it's usually peripancreatic and or pancreatic. All of these collections are going to be either pancreatic or peripancreatic, but in reality, most of them are mixed. And that means that it's affecting the pancreas itself and it's extending distally or proximally, but it's going over what the pancreas is. So going back to the image that I showed at the very beginning when we had all of the different types of fluid collections, when I showed you the pseudocyst and when I showed you Waldorf necrosis, this is another beautiful example of why CT scan, it's not a good way to look at necrosis. This is a patient with severe necrotizing pancreatitis, Waldorf necrosis. You have a 14-centimeter collection. Patient is very symptomatic. You don't know if you're going to go in to drain a pseudocyst that is going to take you 6-10 minutes versus Waldorf necrosis that may take you an hour and a half, etc. How do we answer Waldorf necrosis versus not? You need an MRI. These two patients are exactly the same patient. CT scan, no necrosis, no obvious necrosis. MRI, you can see that it's at least 50% necrotizing pancreatitis. With this, obviously, you have no radiation. You can assess for pancreatic ductal disruption. Very important. You can look at the vascular structures as well. But one of the limitations is that it's much more expensive test, and the patient needs to be in the machine much longer. So, controversy number 3, how much solid versus liquid component is needed to be called Waldorf necrosis? You may talk to different people, you'll get different answers, but in general, the magic number, and this is to keep it simple, it's 30%. 1/3 of the gland if you divide the gland into 3 different parts. Again, that's why MRI is so important and so helpful. Controversy number 4, what's the timing and preparation for drainage and debridement? Again, extremely important to see a capsule. This question has been answered by multiple studies, but the Pointer study, New England Journal, 2021. For time's sake, I'm not going to go into too much details, but this was a randomized control study comparing 24 hours since admission versus 4 weeks later. And the study what showed is that it favored late drainage. But a point that it's extremely important to take home is that 33% of the patients with delayed drainage improved just with antibiotics alone. So when you have these sick patients, of course you're starting antibiotics, but give them some time to decompress, give them some time to go back to their new normal. Frequently you're going to be able to be less invasive and require less procedures, and these patients are going to do better just by sitting tight and waiting to see how they do with antibiotics alone. So some of the tips, before we continue to talk about the different points, nowadays I would say that 100% of these cases, we're doing them EUS guided. Again, if in your facility you don't have this endoscopic availability, if you don't have the stents, it's fine if you're going to be doing a direct puncture, but you need to have a bulge. And again, I'm going to show you a case that I did last month in a life endoscopy course in Central America. If you have fluoroscopy at the beginning, it's nice to have it. I think that nobody uses this anymore. You get a beautiful view just with the endoscope, with the EUS, but if you want to use it, it's fine. Always intubate the patient. Some people say that they can do it without. I can tell you that when you puncture, when you deploy the stent, the amount of liquid that comes out, frequently it's impossible to suction it. And I can tell you that these patients can get very nasty aspiration pneumonia. So always intubate these patients. Also, when we're using a peroxide, frequently the amount of bubbles that they form, they go into the stomach, you may be in a difficult position, they may go all the way up to their mouth, nose. For those of you who have done it, you know what I'm talking about. So if you're going to be using a lot of peroxide, either you go to the stomach and suction, or make sure that the patient is intubated. Stop the use of proton pump inhibitors. There's the data here of large studies. Basically, the idea is that when you have some acid going into the cavity, it's going to help with the necroma to be more soft and easier to clean, easier to drain. So stop the PPI use if you can for these patients the day before that you're going to be doing the procedure. And after you do it, of course, try to make sure they're not taking a PPI. Use the luminous metal stents. Clear the cavity with diluted peroxide. Some people like to dilute it before they put it in. I usually put it in at 5%, and then I'm just flushing some water with it. Antibiotic use only if you have infected wall-off necrosis, and we'll go over that as well now. Antibiotics must be used when these patients have infected necrosis. Remember, you may have necrosis completely and absolutely sterile, but it can be infected. If it's infected, you give antibiotics. If it's sterile, do not give antibiotics. There's many case series showing that these patients can get C. difficile colitis very easy, so do not give antibiotics. The routine use of antibiotics is discouraged when they're not infected. So what are the tools and techniques for endoscopic therapy? We create a lumen, we create a cystgastrostomy. We're using nowadays lumen opposing metal stents. Depending on the part of the world that you live, you're going to be using Axios, Nagy, Spatz. They're all performing very well. There are certain differences. There are different publications on this. You do a direct puncture. And direct puncture, it's the other technique. That's when you have a large bulge in the stomach or in the duodenum. This is what we did in the old days. I am not recommending by any means to do this, but if you have the technique, you know the technique, you don't have US, and it's a semi-urgent procedure, you don't have anywhere to send it, go ahead and do it, that it's fine. What toys do we have? What tools do we have? I think we have the EndoRotor, that is a new kit in the blog. I'll show you some pictures, some videos. The over-the-scope grasper, that seems to be very good. I'll show the images. What I use in my own experience is a trapezoid basket and large capacity baskets. And I always use, when possible, and we can talk about that in the recess, is a double channel. I would pass my equipment through the 7 French working channel, and I'll use the 10 French to suction. And that's how I do it. Some people like to use the plastic caps in the tip of the scope. They seem to help. Again, there's no right or wrong. This is more like personal preferences. What you see here, it's a lumen opposing metal stent. This is an idea, of what we're doing. We're creating a conduit. Again, I don't have time to talk about everything, but here you can see very thick necroma. This necrosis can be very difficult to remove. Even here, you can see that despite placing the lumen opposing metal stent in an area that was that had a lot of fluid, when it collapses, the necrosis just sticks in front of you, and just to remove it, to gain access, can be very difficult. I always dilate the lumen opposing metal stent, and during the first deployment, I always try to go in and clean a little bit. I try to clean from the very tip in order to avoid dislodgement, but this is what you're seeing here. We're able to clean actually quite a bit in this patient, and you can see that at the end of the procedure, you started to see already the walls, and down here again, you start to see some retained necrosis, but you get the idea. So what about drainage of, using the lumen opposing metal stent? We don't have time to go over this. There's a zillion studies showing that it works, that it's technically very easy, that it significantly decreases also the length of stay, and it also, it doesn't actually, what I wanted to mention is that it doesn't affect the mortality. So that's something to keep in mind, and that also applies to any of the techniques. This is another example. Again, for the sake of time, I'm getting signals here to move, but this is a patient with wall-off necrosis, infected. As soon as we put the lumen opposing metal stent, you start to see that river of pus. Every time you get this, send some of the fluid for culture and sensitivity so you can direct treatment, again, when they're infected. Another patient with necrotizing pancreatitis, thick necroma. This is what you start to see as soon as you put a peroxide. If there's a little bit of bleeding, that there's usually is, some bleeding, this is going to be triple. And again, you can see these patients, the foam even coming out of their mouths. So when you do this, I tend to irrigate, then I go back to the stomach, clean, suction, and then I go back in and continue to clean and do my job. This is what you want to see at the end of a session. You want to see the beautiful walls of the inside. And then I always place 2 plastic stents inside of the lumen apposite metal stent. Remember these pictures. This is very, very important, and you'll see why in a second. This is another patient, of course, that came in with symptomatic walled-off necrosis. This is the case that I did last month. They didn't have lumen apposite metal stent. This patient was infected. You see a beautiful bulge. We go with a needle knife. We gain access. You can see the river, and the amount of fluid that's coming out. Dilated to 18, gain access, did a lot of the necrosectomy, and lucky for me, we got these beautiful pieces of dead pancreatic tissue that are super useful for a conference like this one. Then we leave a couple of double pigtails to assure that the lumen of the gastrostomy remains open, because if you need to go back in the future, you have access, you have a good dilated tract, you have easy access to the cavity. Again, I don't want to say that that's the way to do it. I strongly advise you to use endoscopic guidance. I had like 10 years without doing a direct puncture, but here you go. That's what we ended up doing. What about the equipment? You're going to use whatever you have available, personal preference, trapezoid, and large capacity graspers. I do not have experience with the endorotor. It's coming to my unit very, very soon. And what it is, it's a motorized, mechanical, non-thermal device that you can see here in the lower left. This is rotating. It has a very sharp a blade that, as it suctions, as you can see in this video that I got in the internet, it suctions, it cuts, and it significantly decreases the time. I'm seeing here in this particular video, very soft necrosis. I'm very curious to see if in the thick necrosis, it's going to perform as well. I hope that it does, because it's going to clearly, decrease the amount of time that we spend and the number of procedures that we do. And you can see in this video how beautiful it works, but I want to mention, clarify that this is what I call soft necrosis. So moving along, this is also another new kit in the block. This is an over-the-scope grasper. It looks beautiful. I have never used it, but my guess that a problem that we're going to have with this cap is that as soon as it gets in contact with pus, with dirt, it's going to be very difficult to visualize. So what we see here, that it looks crystal clear, may change the moment that you start the debridement. Again, I have no experience, but I can't wait to start to use it. So my last 2 controversies are super important. This one is, when do we remove the lumen apposite metal stent? And the FDA approval for this was 6 weeks. In reality, when you look at the published data in case series, we're starting to see, and we started to see already a couple of years ago, that after 3-4 weeks, we started to see a couple of patients with significant bleeding. I personally have a couple of them as well, but for the sake of time, I couldn't show the bleeding and how I treated them. But point being that nowadays, the strong recommendation is obtain a CT scan 3 or 4 weeks later, document collapse of the cavity, and soon after take it out. If it's not collapse, keep it in, continue to do what you have to do. If it is collapse, as soon as you can, take the lumen apposite metal stent out. If you can't, and what you see here under important, leave the double pigtail plastic stent that you just placed inside. And it's easy to say to leave it, but when you are pulling the lumen apposite metal stent, it can be very difficult to keep it in place. There's techniques, there's tricks, happy to talk about that later, but try to do that if you can, because patients like this, you see when the patient came and you see 4 weeks later completely collapsed, it looks beautiful. But when you try to take the lumen apposite metal stent out, frequently the plastic stent will come out together. So try to find a way to do it without dislodging the plastic stent, because over 50% of these patients have pancreatic ductal disruption, and they have a 40-50% recurrent rate depending where you read. So when you leave plastic stents, you're going to be avoiding the recurrent rate in a significant number of these patients. And I'm just leaving here recent publications so you can get the details. But point being, remove the luminopostine metal stent. Once it collapses, the contact of the metal against the cavity may lead to bleeding. Leave the plastic stent in place if you can. It's going to prevent reaccumulation. And to end, I just want to show a couple of complications when we're doing this. This is not a big complication, but here you can see a luminopostine metal stent, 2 plastic stents in the inside. The patient had severe edema in the duodenum because of the pancreatitis, unable to eat, unable to drink, very difficult. So we ended up placing a nasojejunal feeding tube to assure enteral feeding. I strongly discourage we strongly discourage the use of parenteral nutrition. Try to use the gut. If a patient calls you because they're having fevers, chills, have them come to the institution immediately. They are infected. Even if you give antibiotics, it won't work. You have to go back in. You have to take the stents out. You have to go back in, clean. In some cases, we leave a nasocystic flushing catheter. It's controversial. We don't know if you really need it or not. There's no studies, but only when you have an infected patient. Personally, I would be doing that. This is a patient in our GI lab that ended up having, the procedure went well. You get an x-ray, they have a transmural perforation. This was treated endoscopically and the patient did well. This is the same patient. You can see the stents in a CT scan in the peritoneum. Again, this patient was treated and the patient did well. And this is the last slide of my presentation. This is a very unusual plastic stent migration, distal migration, on a patient. I think it was like 2 years after I removed the luminopostine metal stent. I don't know what you people are thinking. I don't know what you see here. You see the pigtail, but what was very interesting is that this patient had it stuck in the anus, and the patient was so nervous of pulling it out, thinking that it was going to harm the pancreas, that ended up running to the GI lab so we could pull it out for him. Anyhow, to conclude, multidisciplinary approach, remember the type of collection, the treatment only for symptomatic patients. I forgot to mention that, and I'm sorry. You don't treat asymptomatic patients. Very likely they're going to reabsorb on their own. MRI is a way to go, at least at the beginning. EUS drainage, when available, that should be always done that way. Use CO2, remove the luminopostine metal stent in 3 to 4 weeks. Once it collapses, always try to leave the plastic stent in there. And for the Spanish-speaking people, we have this National Pancreas Foundation website with the name of Animaciones sobre Enfermedades Pancreáticas. It's complete. Can get access from your computer now, from your cell phones, and here we cover a vast number of topics related to the pancreas. And again, thank you so much for the invitation. Thank you. No, perfecto.
So, Dr. Gelruth, thank you very much for this excellent presentation. There's a lot to discuss about, but unfortunately, due to time limitations, we will also, I think, postpone the last presentation of the session, because first we have to start with the live procedures.
Pasamos a los casos, ¿no? Presentarás ahora, ¿no?
Sí.
Ramón, vale.
We are going to start with the first case, okay, and after that, Dr. Binay has to his presentation. So, okay. Okay, the next case is male, 79 years old, in June 2022, adenocarcinoma of the distal esophagus. In September 2022, chemotherapy and radiation therapy. In Feb 2023, total gastrectomy. In Feb 2023, leak anastomosis, surgical anastomotic descent in 25%, endoscopic therapy with double pigtail, 7 French 10 centimeters. Currently, acute clinical symptoms of abdominal pain, vomiting, and jaundice.
In the total bilirubin is almost 5, and cholestasis. Under US abdominal, acute cholecystitis, 12 millimeter stone in common hepatic duct with retrograde dilation of intrahepatic bile duct. What should be the next step? Enteroscopy-assisted GRCP, antegrade EUS-guided stone extraction and EUS gallbladder drainage, just antegrade EUS-guided stone extraction or transjejunal. Okay? We'll see. Por favor, pasamos ya a las...
We go over to the room now.
Audio.
Hello? Yes.
Hello.
Yeah, yes. We're seeing you and listening you. Yes,
Okay.
yes.
Can you hear me clearly?
Hello, everyone.
Hello.
Hello, hello.
Yes.
Yes.
Okay. So I want to introduce my team. The very tall guy we have from the Belgium, and the Mariana from the Buenos Aires, and also our team Mako and the Ko and the Fujisawa. So Japanese Juntendo team. We this team managed this case. So this case after the surgery. So then and CBD stone and simultaneous gallbladder stone and experienced cholangitis. So and Manolo said me. So the stone extraction by interventional procedure. So, and also this patient is not so good for the surgery, so unfit. So then Manolo asked to me, so after the stone extraction, gallbladder drainage simultaneously. So after that, they want to retrieve the gallbladder stone. So then we discussed about our strategy. So then in each firstly, puncture the intrahepatic bile duct. So, and papillary dilation and push out the stone. During our procedure, we will employ the double guide wire technique. So, puncture, 90 gauge, 025 insertion, and 035 additionally insert. And perform the stone extraction procedure along the 035. So this is our strategy. And we use Fuji new scope, named the 740. And also Arieta 850 FFN. So we are performing this equipment. And also we will use this one, puncture for the Olympus needle. This is a very flexible and relatively sharp, very good.
19 gauge?
19, yes, that's right. Yeah, already we attached the extension tube and the syringe. Yeah.
Is it pre-flushed with contrast or with saline?
Yes, saline, half saline. During the procedure, we will aspirate the bile juice. At that time, they use syringe, aspiration syringe. Okay. And also before procedure, so show me the guide wire. So this is auto-fire Vigiglyde angle 1. And we already marked at here. This portion is, if this portion come to the needle end, so guide wire go out soon. So it is very careful guide wire insertion. It is beneficial.
So that you know where you are.
Yeah, so it is yeah, our standard procedure for tips. So now we are checking the US image. So can you see the US image from the venue? How about it?
Yes. But the image is in a small window. Now it's better.
Okay, it's okay.
It's okay?
Yeah, it's okay.
Chichai. Okay, please diet marked. So, and this is gallbladder. So marked and please, the stone, big stone in the gallbladder, and so enlargement.
Still some wall thickening as well, as we can see.
Yes, that's right.
And there already the CBD stone was, I think. And we just scanned it.
Yeah, we want to. So.
There we are.
Okay,
Nice.
we can see the CBD stone here. So anatomy is a little bit different from the normal anatomy. So
We thought that was a total gastrectomy with esophageal anastomosis, but it seems like an atypical gastric pull-up, but we couldn't really see the papilla well. So that's why
Yeah.
we, after internal discussion, decided to go for EOS antegrade treatment.
yeah, so now we are searching the intrahepatic area. So please switch to the two screen. Yeah, okay. So we can see the B3. What is the B3? Okay, this is B3. So initially I checked B2. So because B2 is a very smoothly go to the CBD, but B2 not good dilation. So then we discussed about EOS image, and finally decided to puncture the B3, this area. So nicely dilated. So now I adjust the location.
So do you like a more of a hilar approach, close to the hilum, or a little bit more in the peripheral region of the...
Yeah, I want to puncture the near the hilum. So because puncture is easier. Sorry, now we are checking again. Oh, we cannot see.
So I think
Where? Maybe here.
that's nice.
That's nice.
It's a little bit of a distance, but there's a nice
Yeah.
dilation going on.
Yeah, okay.
And I think the other tip that we can give the audience is also to check the fluoroscopy to check how your scope angulation is, because we know from Takeshi's papers that it's a risk factor for failure.
Okay, pass it. And also we will use drill dilator. This one. No. Drill first. So this one is tip is a drill. Name is Torunus. Okay. So it is a very good weapon to dilate the puncture route.
It looks like a weapon.
Yeah. And already, so please attach it. So remove the cap attached to the dilator, which is also a very good point for the interventional EOS. Okay, pass me the needle. So Olympus needle, I love it. So formerly we use German sonotip. But it is easy to bend. So then recently we employed this one. So this needle is relatively flexible because of the coil sheath. So so I also adjusting the. Okay, please magnify this one.
Dr. Hiroyuki, what's your preferred patient position when you are doing this procedure?
So I love the prone. So in Japan, not a general anesthesia, only a sedation. So, but this time they're intubated and general anesthesia performed by anesthesiologist. So in Japan, big problem is shortage of the anesthesiologist. Okay, we can see the needle already. Already, so maybe too long.
And are we looking for a quick jab or a slow and direct movement? What do you do?
Oh, okay, yes, it is very important. So not quickly, so scope manipulation, very slow. So, and we carefully avoid vessels, but we see the not only Doppler image, but so B mode. Because B mode, if the B mode cannot detect vessels, but a Doppler still color, maybe safe for puncture. So it is from my experience. So now we are targeting the bile duct B3. So okay, puncture, starting the puncture, and carefully avoid.
You can clearly see that he's going slowly, checking, turning the scope.
Yeah, finally puncture the bile duct.
Nice. That last jab is often needed because it's a little bit harder.
Yes, show me proof, Bruno. Oh, don't work. Okay, please adjust for roll. So maybe you're this side. Okay, look, they're nicely angulated by a scope. Okay, inject contrast.
Nice.
Yeah, so I want to check the communication to the CBD. Maybe we can see the CBD now, and nicely, yes.
Yeah, nice.
We can see the stone. Yeah, okay. Okay, take a shot.
Yeah, a picture.
Yes, and we will insert guide wire. Marco, please. So, and this is only 1 cc. Insert a cell line. It is helpful to manipulate a guide wire. So only your contrast.
So it prevents it from becoming sticky.
Yes,
okay.
yes, that's right. And please go. Throw very quick.
So in the puncher you always go without the stylet?
Okay, from here.
Yeah.
So please show fluoro. So and gradually, so insert guide wire from now. Maybe please manipulate a wire carefully, and go to the CBD. Can you?
There we go.
Maybe. Oh, it's no. Maybe no.
You can see that the endoscopic technician is already torquing the wire a little bit to help us through. Quite important. Sometimes I also like to take over myself to manipulate a little bit.
Okay, thank you. So sometimes, so the fluoroscopic image is a little bit. How about this? How about this?
Nice.
It's okay. It's okay. It's okay. I want to go through the papilla. Don't push. But lowering, maybe go out. Oh, maybe go out. Yes, yes.
And you can see that we've exited the bile duct. And now it's curling up.
Okay.
Perfect.
Okay, perfect. Okay, the withdrawn wire. So Marco, help me. Okay, initially the needle out. Okay, pushing the needle out, and lock it. And rotation, and withdrawn needle. Withdrawn needle, and lock it. Please show me the fluoro. Oh, here. Okay. So now the guide wire locked. So and so fluoro off, please. So don't use a fluoro because the guide wire locked by elevator function. So it is very beneficial for the reduction of the radiation exposure amount. Okay, next step is puncture tract dilation. It is one of the difficult steps in interventional EUS. But recently we can perform with this very good device named Tornus. I'm not sure what meaning, but it is a very good dilation device.
We can see that's already pre-inserted in
Yes,
the cap.
yeah, cap is here, and okay, insert and attach. Okay, go. Support me. Okay, so this is a very smooth procedure. Thank you very much for the support us.
And what we can see is that Hiro is constantly checking the EUS image
Yep.
as well, that we have that we stay in the same trajectory.
Yeah. Okay, and I want to adjust.
Looking for the guide wire.
So maybe so we can see the guide wire here.
Yeah, perfect.
Yeah. Okay, she's a Frollo. So checking the upper area. Okay, okay. I will go out the Tornus and please rotate. So gradually advance the Tornus, go into the bile duct.
And do we have to do anything with the guide wire? Do we have to tension it, or does the Tornus do the work?
So you can see there's also a very good Tornus working in a EUS image. So but difficult to pass the tortuous area. So and I want to switch to the balloon dilation. So balloon dilation also we use very small tip equipment named the REN, R-E-N. So this is a REN. This is also made by a Japanese company, Kaneka. But this is available in some Asian countries, Japan, Taiwan, and Korea, and Thai. I'm not sure. Maybe soon.
You're making us very jealous with all these nice tools.
Yeah. So we are very happy. Can use many dedicated devices. Okay, withdrawn. So withdrawn the opposite. So counter. Counter clock? No.
Counterclockwise.
So the opposite lowering.
So you are always using this device instead of the cystotome?
No cystotome recently.
No cystotome.
Yeah, very few case. It is a very tough case. We use cystotome. Okay, can I? Okay, lock it.
You can use
Yes.
cystotomes, but in the European situation, you can use a cystotome. Also, rigid dilators are possible, but it's often quite hard. And if you're in this position, it's really hard to push yourself in. So I wouldn't advise it in this case.
And then the liver goes a little bit.
Yeah, it goes away and you lose your
Goes away
position.
as soon as you get the cystotome.
Yeah.
So you have to be really short. Yeah.
So last year we used cystotome only one time or two times. So most of the cases that we use Tornus and also a very sensitive dilator named ES dilator from Xeon company. So and also look ちょっと戻して。So tip is a very small gap between a catheter and a guide wire. Also, very insertion ability is very good. Okay, go. Okay.
So if you are using a cystotome, what is the preferred size of cystotome?
Cystotome, if we use a very thin one, let's 4 French,
Yeah,
4 French,
Yeah, so
or 5 French.
the smaller the better.
Yeah, so it is also a Japanese dedicated one. So basically we use Endoflex 6.5,
Exactly.
but recently we have the smaller one.
But in case you use the cystotome, then you have to dilate or with a balloon or just?
It depends on
So-
what you want
so,
to do. If you want to
we-
do a stent placement, 6
So
French is
we
okay.
employ the two-step dilation. One step bougie or cautery. Second strip is a balloon. It is helpful to insert many devices smoothly. Okay.
What size of balloon, please?
Balloon, 4 millimeter.
4 millimeters.
Yes. Okay. Show me Frulo. I will insert a lens.
It's nice to know that if you've used a 6-strength cystotome, you do not need to use any balloon dilation with a jewel bore, for example.
Yeah.
You don't have to use it.
So maybe この辺か?
Depends on what you want to do.
Yes, and what device you can use.
More? Okay. でどの辺まで下げればいい？ちょっと俺見てなかったんだ。Maybe so.
Would you like a little bit more in zoom?
Yeah.
A little bit more zoom?
Okay. Oh,
Yeah.
very good. Thank you. So we are not sure the puncture area. Maybe here? Okay, the dilation, please. So the 4 millimeter balloon, the volume is very small. Then, so carefully aspirate the air. Okay. So a little bit pushing, and okay, let's switch to the
You use a little bit of contrast in the balloon
contrast.
as well?
Yes, half dilution, dilution. Okay, please dilate.
Nice.
Maybe nice.
And do you do the entire track?
Yes.
Or,
Yeah. Okay, and so we want to switch to the next step. Next step is okay. Oh, the alignment. 抜けた？まだ抜けてないよ。抜いて？抜いて？抜けてないよ。It's okay. Okay, the here. Okay, it is a dilate gastric wall and liver parenchyma. Okay, more. Okay, good. Yes. And the next step is the insertion of the double lumen catheter. So show me the floor, please. So we will withdraw the balloon catheter. Okay, and the guide wire lock it. Okay, flow off.
what's the advantage of having the two guide wires in place?
So this type of the procedure, the scope stability very poor. Also pushing ability very poor. So then we will insert 035 guide wire. So additionally. So it is also a very good double lumen catheter, very thin tip, and also acceptable insert 035. 025 and 035. Then the name is uneven catheter, this one. So, okay, going to? Yes. So, initially we will insert this catheter into the bile duct and then aspirate the bile juice. So to reduce the peritonitis risk. So then go to the duodenum and insert 035 guide wire. Okay, more. Yes.
So the nurse is putting a little bit of traction on the wire to help assist you in advancing the catheter?
Yes. And okay. いくよ。でこっちがまずはそうだ引くんだね。Okay. Okay. Please give me a flow. Okay. I will insert catheter, the double lumen. Okay. Please assist me. So a little bit. Okay. Okay. いくよ。
The nurse will help you here.
Yeah.
Perfect. Nice.
Okay, we want to see the bile duct, common bile duct, with no magnification. So,
Sin magnification.
Okay, thank you. No.
No.
A little bit less zoom. Less zoom. Okay.
Sorry, Dr. Yasama, we have to move on to a next room that they wanted to show us.
Okay.
Okay, we'll see you back.
So, small Okay, it's okay. Tita?
Okay, let's move to the other room. The next case is, if you remember yesterday, the lady with 66 years old, admitted for weight loss and vomiting and hyporexia, gastric outlet obstruction, with perivascular mesenteric retroperitoneal regional lymphadenopathy, metastatic lymphadenopathy in hepatic hilum, and yesterday we performed an EUSGE and failure after failed EUSBD and ERCP. What should be the next step? Refer to a more experienced center, try to ERCP through SEMS place yesterday, or wait for the duodenal SEMS and anchor and the bile duct to dilate, or retry. Okay, let's see. Por favor, pasamos a la sala 1, por favor.
Hello? Do you hear us?
Yes, good.
Yes, okay.
Can you hear me?
Yes, yes, yes.
Hello. Good morning. I'm Moon from the sky, actually. So, actually from the Seoul, Korea. Nice to meet you. And let me introduce our team for today's procedure. I and Dr. Vanilla and Dr. Lee, Yunna Lee from the Seoul, and our amazing team here, camera on here, and our beautiful, world best, very skillful, fantastic local team here. And 3, 2, 1. Hola! Hola! So for this case, this already did the case presentation. Patient had the gastric outlet obstruction and also biliary obstruction by the seeding of a gastric tumor, underlying pathology is gastric tumor. So yesterday, our team successfully did the 2 GOO relief management, like gastrojejunostomy with axios, and the second one for conventional duodenal uncovered metastent. And for the fluoroscopy, you can see the nicely expanded axios, and we need more time, but the duodenal stent is a little bit expanded. So the purpose of this case is relieving of jaundice. But many options for this patient. But for today, we would like trying to insertion the duodenoscope through the duodenal metal stent, and then find the ampulla, and we can make a cannulation. But the problem, this morning patient did a tumor bleeding. So in stomach, there were a lot of clots inside the stomach. So barely can see the opening of the duodenal metal stent. So that's the reason why we are having some trick. You can see the guide wire all throughout the duodenal stent, and now guide wire is on the deep portion of jejunum, like for gastrojejunostomy. And also we inserted balloon catheter for stone retrieval balloon catheter, a biggest one, 20 millimeter.
20 millimeter, yeah.
Now we would like to perform balloon-assisted insertion of duodenoscope, because now without that kind of accessories, we cannot insert duodenoscope through that kind of long duodenal metal stent. Okay, could you make a balloon? So now you can see the balloon overlapping the contrast on column and the biggest.
Yeah, maybe you can add some air. To the syringe.
Okay.
Yeah,
so balloon is here, and with the assistant the balloon catheter, we would like the insertion of the scope over the balloon, and with the resistance of the balloon, and let's try insertion.
I've added some extra air just to have. I've added some extra air to the balloon, so you have a bit more anchoring.
Okay. Yeah. Pushing. Now, one operator is keeping balloon,
Now scope is inside of the duodenal scope. Duodenal stent here. 보기가 쉽지 않는데, 그래? This is the best way to insertion of the scope inside of the kind of long. With the time, maybe if duodenal stent is fully expanded and using small version of duodenal scope like JFV, you can make another possibility of success. Now they don't have a small version of duodenal scope. Now I'm using therapeutic duodenal scope. It's a little bit thicker.
Dr. Moon, maybe some pressure in the abdomen is good for this or not?
Not, because there is no looping on the fundus. So maybe it's not so helpful. More?
Yeah. It seems to have engaged inside the stenosis. Yeah. Nice.
Dr. Moon, we have
Very,
to
very
move
nice.
on to the other room.
No, 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 1 minute.
Just 1 minute, yeah.
We can reach the
Yeah. Very
papilla
nice.
here with
that is the
our
papilla.
amazing team. Sure, and more deeper pushing is better. Anyway, we make a success the passing duodenal scope through the kind of long duodenal stent. So
Very
with
nice.
this is another trick to make this kind of procedure. Okay, you can move to another room, and then we can find the papilla. See you soon.
Okay. We'll change to the other room.
Are you with us again?
Hello, hello again. Can you hear me?
Can you hear you?
Yeah.
But now can you see you?
Okay. So now we are insert two guide wires. So O25 and O35. So please separate it. Okay. So O35, what type of wire? This one? A jag wire. So very hard one. And O35 から.
Why do you have two guide wires inside? What's the advantage?
So because after insertion of the two guide wires, scope stability is very good. Also pushing ability is very poor. Then we want to employ the very hard wire. So and we decided to dilate papilla with a 12 millimeter catheter. This is CRE.
And so while you were in the other room, we also needed a catheter to guide ourselves through the diverticulum. So that's a tip as well, that you can use the tip of the diagnostic catheter to get you through into the duodenum.
Okay. Okay, please give me a full roll. I will insert a balloon catheter. So along the O35. So it is a little bit smoother than O25. So maybe around here. So but maybe here is very good.
Perfect.
Perfect. Okay, please direct.
So this was a 12 millimeter CRE balloon.
Yes,
Yeah.
it is enough to push out the stones.
Can you repeat the diameter of the balloon?
12.
12 CRE.
We use the bile duct diameter to guide us a little bit in the diameter.
Yes. Sure, and we now, Dr. Marco, the dilator. Yes, okay, go. Go. Put all the please. Already. Okay, no. Is that all? Okay, with deflation and a little bit so one more time, a little bit upper area. We want to so please around here.
You can also see that a lot of guide wire was used, and it also improves your stability. So
Yes,
if you have a couple
yes.
of loopings, you improve your insertability.
Yes, yeah, very good. Okay, deflate. Okay, the withdrawn this scope, this catheter, it's okay? Yeah, yeah. Okay, okay, go. And I keep the guide wire. Oh, stone, go up.
The stone is going down.
Yeah. Okay. Okay, lock it. Yes. So, and
So
also-
you always dilate just a couple of seconds. Doesn't matter what.
So the
what minutes.
very few minutes, we perform the dilation. So just after the disappearance of the waste.
Waste.
Yes, we will stop the dilation.
Dilation.
And we already published our data about 24 or 8 with this type of the stone extraction. So pancreatitis very few, almost nothing. And we performed RCT, comparing the interventional ES versus double barrel ERCP, assisted ERCP. So we already finished. Now we are analyzing. We will submit our abstract for the next DD double.
Nice.
So we want select as the oral.
Procedure time will be better, I think.
Yes.
Yeah.
Okay, show me Bruno. Okay, we insert a retriever barrel by Boston. Olympus, March 3B. You can see the barrel catheter.
Yeah, there it comes.
Yes.
Going down a little bit.
Yeah, but maybe a stone is the top of the CBD.
Yeah.
Yeah. Okay, from here to direct slightly. So you can see the stone gradually move to the.
Yes, we are seeing it.
ちょっとしっかりガイドワイヤー誰かやって。
We're going to pull the guide wire a little bit to facilitate the integrate pushing.
Yes. So require the two assistants.
You want the second one?
Guide wire and barrel manipulation. Okay.
The balloon is 912.
So pushing ability is not so good. So then we gradually deflate balloon, and also scope stability is not so good now. So then I will.
Se llama the balloon is 912.
Sorry.
The balloon is 912. The diameter of the
barrel size.
yes.
Barrel size is 20. So up to 20. OK いくよ。ちょっとねきつくてね押せないんだよ。So OK there pushing ability is not so good, but we try to push out. Oh, pack up here. ちょっともう少しじゃなくてあれ入れてくれる？具合剤。
Now systems are helping with traction on the wire, but I guess
Yeah. So and also
segment 3 makes it difficult. Segment 3.
そうガイドワイヤーどこ行ってんの？ダメだ。So this is a difficult step now.
Maybe if you dilate a little bit more.
So then this type of the procedure. What stone is here? Okay, maybe out. Okay, one more time. 戻すよ。
I don't see it anymore.
And contrast index, please. Contrast. Is there any stone? Okay, one more time. We will.
Another passage.
Yes. Oh,
There
here.
it is. There it is.
Here. 小さくして。いかないんだ。Sorry, so I want to see the scope. Yeah, maybe this. So this catheter, no good now.
And do you think that we're pushing it up in the cystic duct? Because you see the cystic duct originating there.
Yeah, ちょっと待ってね。ちょっと小さめにしながら。Maybe push out. 出た One more? We have one more.
Let's make sure that it's out.
Okay, じゃあ戻すよ。And
I think there is in.
contrast?
I think there is in.
This, yeah.
One more? Okay.
Yeah, definitely.
じゃあ軽く膨らまして、もうそれじゃいかない。いくよ。So pushing ability is not so good. So and もっとガイドワイヤーしっかり。もうガイドワイヤー次第だ、もう全然いかないわ。So at that time we employed more tough wire. So ガイドワイヤーどっか行っちゃってるよお前、ほら。OK。じゃあそこでもうちょっと膨らまして軽くね。
If it is a bigger stone and it can't come out with the balloon, what would be your next strategy?
I think in this case, because we have so much guide wire in the small bowel, I think you can still attempt the rendezvous. But again, the anatomy is a little bit strange here. So, but it's still something you could consider with a USP scope or going in with a pediatric colonoscope.
Yeah.
Dr. Isayama, now we go to the other room that I think that they are prepared for the cannulation.
But I think it looks good. I don't think I see any more stone, but we'll see you.
Hello?
Hello. Hello, welcome back. Now moderators, can you hear me?
Yes, perfectly.
For the next room, we tried to find the ampulla, now tried, and you can see the floral, and you can see the scope position. Now, we cannot make a shoulder position, and just pushing the scope, and we found the pancreatic duct like this. Can you see that? Do you agree? This is pancreatic duct. So we are trying to double guide. Can I have a dry gauze? More? We are trying to double guide wire cannulation because now very top scope position. Now elevator is not functioned. So not functioned because very top position of scope, and just trying to biliary cannulation over the pancreatic guide wire. For this patient, and now I use the. I cannot make. Okay, perfect. Very not perfect. Very difficult to insert. So we use this one. We use the 025 guide wire for pancreatic cannulation. And this is Olympus sphincterotom. Could you lift up the teeth?
Tensa.
More.
Yeah, the problem, of course, is that here the position is not a standard position.
Yeah.
So,
Do you prefer this than uppercut?
Pardon?
Yes.
yeah, they asked if you usually prefer
no.
double guide wire than pre-cut, but probably this is due to the fact that you cannulated the Wirsung duct, and so you, what do you think?
I think I'll try to, maybe it's very difficult to making a safe pre-cut because now T-box position is very difficult.
But probably also ESG guidelines and
guide wire?
says that if you have a guide wire inside the pancreatic duct or opacification
Pancreatic duct, no,
on the pancreatic duct,
Yeah.
probably double guide wire
Could you lift up the tip a little
should
bit
be
more? And guide wire?
okay. The guide wire still wants to go in the pancreatic duct.
Yeah, we need the more left side. Oh, pancreatic duct. This way is better. Okay, could you prepare pancreatic stent? 5 centimeter. Yeah.
And
Single
pigtail. Yeah.
Yes.
5 French, 5 centimeters.
5 French. Yeah.
Perfect. And don't you consider to do a transpancreatic septotomy, transpancreatic sphincterotomy? Do you like that or
Yeah,
not?
it's another option.
How long do you try that maneuver before you give up?
Okay, can I?
Yeah, let's see, because this seems...
Oh, pancreatic duct, right? Pancreatic duct. Okay. Keep going, guide wire.
Maybe...
Okay, pancreatic duct. Usually 15 minutes.
Trying to go to the left for 15 minutes?
15 minutes in my institute.
Okay.
Again, pancreatic duct. Guide wire. Pancreatic duct.
Maybe we can try bending a bit more.
Yeah, bending a little bit. We should go to the left side of the guide wire. But to try it, the scope position is...
yeah.
Okay, could you prepare pancreatic stent?
Yeah, it's ready.
To here?
No, pigtail. Yeah, single pigtail pancreatic.
Again, pancreatic duct, right? Okay. Could you give more guide wire? Could you show the guide wire a little bit, yeah, a little bit.
Okay.
In this case, you prefer to put a stent in pancreatic duct?
Yes, and to make some space after removal of guide wire or pancreatic duct. Now, the elevator is not working.
And in this case, no, uppercut from pancreatic duct, it will be a good option.
Lift more.
Yeah. Yeah, the options here, of course, were double guide wire techniques, but this is if this is not working, either transpancreatic sphincterotomy or pre-cut over the pancreatic stent. So now Dr. Moon has asked for a 5 French, 5 centimeter single pigtail pancreatic stent, so you want to secure the pancreatic duct.
Okay, good.
And we want, we also usually use a single pigtail pancreatic stent because that favors spontaneous migration because we do not want to come back and remove the pancreatic stent. It just had to stand there for overnight and just to secure.
One option is you already told me pancreatic septicectomy, but
yeah, that would be another option.
Is not working.
Okay.
Very barely. So maybe.
Okay, Dr. Moon, now we change to the other room.
Okay,
or a little more.
Welcome.
Okay.
The site of the puncture is a
Hello.
problem after that?
Oh, exactly. Okay.
Dr. Isayama, yeah,
Yes,
we're with you.
Please see our fluoroscopic image. Okay, now we insert a double pigtail. The tip is in a common bile duct. Please make a double pigtail in a bile duct. O35. Now we insert double pigtail along the O35, not out to 5, because the pushability is very good. And if we fail to place the stent, insert the stents, auto 5 remaining. It is a safe way. So it is a safety wire. So double wire system. もうちょっと Okay. Now we are できたできたかね So now can you see the tip of the wire?
Can we have one magnification more?
Navigation more.
Yeah.
Maybe so making the pigtail here. Yeah, very nicely. Okay, from now we will we want to see the endoscopic image.
So we're putting it in the bile duct and in the stomach. Would you also consider putting it through the papilla, through the liver and the stomach, or is it
So
just
now,
okay?
okay, we can see the. Oh, そこにいるよね. So we can see the stent. Very easy. So now it is a very long stent.
And it's almost going through the papilla, so that's great. And that's the marker already. So you're putting
Okay,
back on the scope?
with the guide wire. あ、まだか、こっか。Okay.
Nice, beautiful.
Okay, successfully placed the stent. So, and the next step is a gallbladder drainage.
But we'll let you go to the other room first.
Okay. Okay.
See you.
See you.
Thank
See
you.
you soon.
Thank you very much.
Thank you.
Nice, well done.
Thank you.
Yeah. Dr. Moon, we are with you another time.
Okay, so we placed a single pigtail stent in the pancreatic duct.
Okay. And it will be?
So what do you want now? Again,
Cannulation
sphincterotome.
again? Cannulation again?
Yeah. With a straight tip Visiglide again.
Yes.
Okay.
Clever cut.
Recta. We are learning some Spanish word today.
So will you try to cannulate or will you go to pre-cut right away?
Again. Yeah, right. Guide wire, please. Okay, there is so many resistance insertion, even the kind of catheter.
Yeah.
Like this, very, very difficult to showing.
Okay.
And let me try again. This way. Guide wire?
Okay, can we have a bit of guide wire? Oh, okay. Go this way.
Okay.
Yeah, there's some blood coming from.
In order to prevent the loss of the endoscopic view,
Guide wire?
do you consider it to perform a precut now?
Now the scope position is very unstable, so we should. It's not a usual ERCP position. Guide wire?
Let's see. That's
No. Keep going. Just more free. Just more free.
okay.
Just
Probably
a
this
free.
should be submucosal.
No.
Tira?
Okay. Remove. No insertion.
Yeah.
Resistance.
Yeah.
Okay. Remove it. Okay. Let's try again. Okay. A little lift up. Yeah. Good. Guide wire? Guide wire a little bit. Yeah. Okay. Guide wire. Keep going.
Resistance.
Oh.
Yeah,
Okay, how about this?
yeah.
How about this?
Let's see here.
Resistance. Now? Still? Okay. A little bit guide wire. Okay, again? No. Guide wire.
Now we will change
Okay,
to
okay.
the other room, Dr. Moon,
Okay.
because I
Okay.
think that the other case,
Okay.
it's not closed.
Guide wire.
He wanted to do
Yes,
something more.
yes. Sorry, we managed it.
Sorry,
Just
1 minute.
just 1 minute more.
Yes, we see you.
I love you so much.
Okay.
Could you push the sphincter inside? Oh, very tough. Okay, contrast. Contrast, no?
Oh, it's going
Okay.
mostly outside.
More push. Push the. Push the.
We are
Oh,
we are
okay, okay.
with you, Professor Mon.
Contrast. Now, yeah, we can make it.
Okay.
Oh, okay. I agree. Do you agree?
Yeah, it's in the cystic probably
it's
now.
no problem. But there is very diffuse stricture on
Yeah.
this CBD.
Yeah.
Okay. So could you show the more proximal liver position?
Okay, and a bit higher.
Yeah. And yes. Guide wire. And sphincterotomy. And can I?
Okay. So the problem is that.
No problem. You can make it.
Yeah, of course.
Yeah.
Of course.
Sphincterotomy. Okay. Now. Can I? Okay. Yellow puddle. Yeah. Yeah. Okay. Do you lift up? Yeah.
Nice.
Very gently because the scope position is not so good. Okay, perfect. And again, guide wire. Could you
Tira?
pull back the guide wire to the CBD?
More.
A bit more.
More. Yeah. Going, okay.
Now empuja.
So what is the reason you're performing a sphincterotomy at this point?
I think he performed the sphincterotomy because there was difficulty
Just to secure, yeah. Okay, could you change it to the wire, angled one? Angled one. Just to secure the opening of pancreatic duct, the biliary duct. Change. And could you lift down the tip? Now we don't need to lift up the tip. Yeah. Okay.
Yeah.
Change to angled one.
Dr.
Now,
Moon,
still we are on camera. You can see there now stricture is mainly distal CBD, very unusual. Usually stomach cancer-induced biliary stricture near perihylum by the extrinsic compression of metastatic lymph node. But now the stricture is almost a distal CBD, like a diffuse stricture, almost looks like a pancreatic cancer. Maybe extrinsic compression of the
Dr. Moon, we change to the other room, okay?
Okay, no problem. Inside.
Sorry?
Double pigtail inside.
Yeah.
Shorter one.
Yeah.
Hello.
There's a big stone.
Hello, Dr. Isayama. We are with you.
Hello.
Okay, hello.
Sorry,
Hello again.
we are enjoying a conversation. Sorry, this is you can see the endoscopic view. So we can see
Yes.
the stent. So insertion through the duodenal valve the wall. And we want to drain the gallbladder. So now we are searching gallbladder. So this one. And so searching the good place for the axios.
So there's post-surgical anatomy is completely different because of probably partial gastric pull-up. That's why our entry point for the hepatico-gastrostomy area is in the bulb.
Yeah.
This is also a perfect position for the gallbladder drainage.
So maybe this area is almost good. So we want to avoid puncture this vessel. So how to avoid it?
To explain to the audience, now you wanted to drain the gallbladder.
So how we want to drain the gallbladder. So we already saw was that there was a big stone there.
Big
So
stones,
that's the reason that we already went for the 15 millimeters. But we're probably also going to place a coaxial pigtail to prevent any dysfunction because it's such a large stone.
So it is the aim of this procedure is not only a drainage, the making the create a root. So and to remove the stone. So it is also a ESCL, endosonographically created root.
So a nice tip to get those vessels out of the way is also to already extend your heart axials a little bit and try to manipulate the vessels a little bit with the tip.
So maybe here is safer.
Dr. Isayama, what is the size of the axios that you have used?
15 we
15.
employ, yeah.
And also if you're planning on doing a re-intervention with stone clearance, 15 is a lot easier because you can go in easily with the gastroscope.
Maybe here is okay.
Yeah.
So I want to search the more good one. So the so how about here?
Nice. Yeah. You can see that he's extending the device a little bit and then you can manipulate those vessels already as well a little bit.
So we want to avoid puncture of the vessel, but not easy. So more pushing. Maybe good. Maybe good to avoid the.
Perfect.
So maybe this here is a vessel. Okay, the crystal attached there.
So we already changed to the hot axial settings. You're using
Yes,
a pure cutting
yes.
mode.
And there is no paprika. Okay. Okay, I try to insert.
Nice.
Okay, nicely in.
You didn't see a big smoke sign, but you can see that the catheter
Fit off.
is in already.
Yes. So I want to direct a wrench.
Nice. Distal flange is being deployed.
Okay.
We will now retract the distal flange to get a little bit of
Yeah.
tenting action,
Thank you for explanation.
and then the proximal flange.
Okay, final intra-channel.
And we'll switch to the endoscopic view.
Yes. Okay, maybe naturally
Nice.
in.
So what do you want to do? Do you want to go in with a catheter, or do we use the device of the Odexis to put the wire in?
Yes, yeah, but we want to switch the this one to the catheter. And give me a plastic cap.
So what's the plan? Are you planning to go in and look at the
Yeah,
stone?
so I will insert double pigtail inside.
So in general, if there's still significant life expectancy, in general we tend to go in and make sure that the bladder is empty and then place double pigtails. But I think there's no good data to really urge us to do one of both approaches. But this is how I do it. Do you do a planned re-intervention, Hiro?
Yeah, intervention. Maybe after the 1 or 2 weeks, maybe I insert a scope or spyglass going to from this year.
So Roy, how long do you wait after placement for re-intervention?
Yes, today. No, too long procedure.
Usually we wait about 3 to 4 weeks, right? Then you have a mature
For
fistula.
me the
spread.
same, yeah.
Okay, please adjust for all. Maybe small one is better. Small one, please.
Normal.
Small.
Little bit less
No, not top.
Okay. Okay, good. Okay, the reason the catheter, okay? これオースリファイルまあさ、WTL 入れるんだろう、オースリファイルだろう、まあいいよ。いつも違うことしちゃいかん。Okay, now we are locking the guide wire by your scope elevator. So I will insert a double pigtail. How long?
Dr. Isayama, we have to say goodbye, to go to the other room, and then to close this session. Okay, thank you very much.
And it's done. Thank you.
Thank you.
Thank you. Thank you, everybody.
Well done. Well done.
Thank you. Okay.
Are you with us?
Yes, Dr. Moon? Yes.
So as you can see, Dr. Moon was able to advance the guide wire in the common bile duct. There was a dilated cystic duct as well, and probably there is an infiltration by the tumor on the orifice of the cystic duct. So he has chosen an uncovered self-expandable metal stent. It's an 8 millimeter wide, 6 centimeter long metal stent. Because of course he doesn't want to impair the cystic duct, even if literature doesn't suggest any difference between uncovered and covered SEMS.
Stop.
Very
nice explanation by Dr. Vaniller. So now I'm deploying the stent. Keep going. Just in case, I would like to put more duodenal side, conventional
Nice.
stent, and and remove our delivery system. Now we make a success biliary stenting. Now the stricture is too tight. Slowly.
Very, very tight
Okay,
stricture,
now?
yeah.
Okay, go.
And you can
Okay,
see
any-
bile coming, yeah.
Okay, So it was very difficult procedures, but we could make biliary drainage also for patients, to our patient. And you can see the nicely drained the bile juice from the duct. So I want to leave some pancreatic stent because there was some stricture on pancreatic duct.
Yeah.
Maybe another tumor infiltration on pancreatic duct.
Probably, yeah,
So
the same tumor is
everything,
infiltrating
yeah,
both sides.
Could you take a photo for this one?
So
for endoscopic view and also fluoro?
Dr.
So
Moon,
you can see the bile is very easily flowing, a large bore diameter of metal stand. And so you made yesterday patient did the GO relieving by pour and for the axials, and the second the duodenal stand. It was very difficult, but we could make biliary drainage through the duodenal stand. So you can see that now patient is very okay. So we can finish our procedure. Perfect our team.
Congratulations.
excuse me, Dr. Moon.
Yeah.
In case the duodenal stent had gone up to the level of the ampulla, or do you have some tricks of bypassing it and and cannulate the CBD?
We can try, but for that kind of one, now we can use rhythm shaking is important to minimize the duodenal moving. So, and we can try, but now almost all cases can be done by US guided biliary drainage.
Mean by ERCP?
Yeah.
That's what I'm asking.
Okay, everything is fine. Okay, thank you.
Okay, thank you very much.
Thank you.
Now we have to close this session. Now go to a breakfast.
Tricky, but
And the last
really
talk
nice.
that we
Congratulations.
didn't do now, we will do after the breakfast. Okay, so thank you very much for your attention. Conference. Y a petición de, bueno, dar las gracias sobre todo a Boston y a Manolo por estar aquí. Y a petición de Uzma hemos dicho de preguntar a ver cuántos de los que estáis aquí estáis aprendiendo a hacer técnicas de CPRE y condoscopia, que sois, ¿no? Trainees, que se llama, ¿no? En inglés. No sé si... ¿Cuántos de vosotros os consideráis que estáis aprendiendo?
I said, don't be afraid.
Afraid, ya sí, que no tengáis miedo de...
No, we are. But I forgot to, I guess we didn't introduce ourselves. I'm Uzma Siddiqui. I'm director of our therapeutic endoscopy unit at the University of Chicago and also direct our advanced endoscopy fellowship.
Hi, I'm Prableen Chahal. I'm at Cleveland Clinic, Ohio. I'm the Director of Advanced Endoscopy Training. My main focus is pancreaticobiliary endoscopy. I've been in practice for 15 years. And thank you so much.
Sí. Oh, vale, bueno, pues sí. ¿Y quiénes de aquí o hacen eco, por ejemplo, y no hacen CPRE? ¿Solo eco? I'm asking all the person US. Yes. ¿Y CPRE? Vale. ¿Y eco y CPRE? ¿Y los que no habéis levantado la mano? ¿Qué hacéis? No, bueno, no, pero que sean hombres y mujeres, es igual. ¿No? Y dentro de la ecoterapéutica, que os consideráis que hagáis todo tipo de la ecoterapéutica actual. Therapeutic endoscopic ultrasound. I'm asking about therapeutic endoscopic ultrasound.
Yeah, sure. Yeah, but they can ask questions.
Can I? Levant.
Que entre los asistentes hay gastroenterólogos generales, médicos en formación, también hay gente que no son médicos, pero que están interesados en la endoscopia biliopancreática, a lo mejor trabajan para compañías que tienen productos. O sea, que pueda haber gente que no ha levantado la mano no porque no te quiera hacer caso, sino porque, por ejemplo, Francisco no hace coendoscopia, no hace CPR, pero sabe mucho. Pero
Josep también doy fe, Josep también.
Bueno. O Víctor, que está aquí a mi lado. Entonces, bueno, so
I just heard Francisco knows a lot, even though he doesn't scope.
Yeah, you're
Okay.
getting better in Spanish. It's amazing. Yeah. So you've gone beyond abra la boca.
A little bit.
That's
We're all here to learn. So.
No, what I've just said is the questions. People didn't raise their hands because some are just general gastroenterologists, so not doing pancreaticobiliary endoscopy. There are people working for companies, most of them with interest in interventional US. So we all have an interest, but not necessarily means that we perform the procedures ourselves. So anyhow, if we manage to get this started, it's going to be...
I think they can ask questions meanwhile. Any questions related to interventional US, pancreaticobiliary endoscopy, mentoring, training, we are here.
I guess one of the topics, and I know our colleague Janine Van Hooft gave a talk at UEG this week on, is it important to learn EUS and ERCP together? Yes or no? And I had to give a testimonial, and I said, absolutely, I think you should try to learn them together because they're very complementary, similar skill sets. So, you know, I think they feed off each other. So when you're learning those skills, it helps with become better at both procedures. And, you know, you just get a more full picture of the pancreaticobiliary anatomy and have more therapeutic options.
Yes, no, I think I absolutely agree because there are so many procedures we do that requires knowledge of both the skill sets. Especially if you're doing ERCP, you know, what are the chances that you're going to fail the cannulation, right? If you've been doing this for a while, your cannulation rate should be in high 90s, but when you're starting on, it's about in the 80s. So you don't want to be frustrated that now you have to refer the case to your colleague who can salvage it with the endoscopic ultrasound. I mean, I think there's the divide between ERCP and EUS has virtually disappeared. I think they are so entwined together. It's I personally, I'm glad I learned both, and I hope. I mean, I don't know what's the practice here. I mean, can you just learn ERCP and practice? I know Ramon is doing EUS and ERCP both, but you guys have an option of learning one or the other.
Changing, I can't see if anybody raised their hands behind me, but this is changing in Spain as well. So not so long ago, it was either US or ERCP. More and more, I think it doesn't necessarily mean that everybody has to do both EUS and ERCP. Like not every colonoscopy does dissection or resection, advanced techniques. So I think there's many more EUS procedures for pancreatic cysts, subepithelial lesions, and whereas interventional EUS is a tiny fraction of an EUS practice. So I would say it's the opposite. You cannot do ERCP without EUS, whereas EUS is perfectly sustainable as a practice without ERCP. So it depends. I know in the United States, the therapeutic endoscopist, because maybe of your healthcare system, has to do everything, like POEM, bariatric procedures, big polyps or ESD, third space, ERCP, EUS, Barrett's. We in Spain are relatively fortunate that our healthcare is different, so we work more as department or team. So within a large department, like there are people focusing on just smaller areas. But having said that, I agree with you that if you are young. You still have many years of endoscopy practice ahead of you. It would be suboptimal to perform ERCP without EUS kills. On the other hand, there are, as I said, so many EUS procedures, even therapeutic, like RFA, hemostasis, that the volume probably justifies that some endosonographers will not be doing interventional procedures and still have plenty of patients. But I don't know, you're very serious. I don't know if you're disagreeing.
No, I think it just boils down to an individual, right? What gives them happiness and contentment? If they're happy doing, like submucosal lesion staging, cancer staging, tumor staging with the US, that's okay. But I think if they're looking to do interventional stuff, especially ERCP, or if they're looking to do interventional stuff in EUS, so many accessories that we use, long wire system exchangeable, so it's good to have a knowledge of both to be good at it.
Yes, absolutely. Bueno, como estamos en fase así de rodaje, menos mal que esto nos está pasando hoy y no mañana.
Es para qué servimos las mujeres, como siempre, ¿eh?
Hombre, somos hombres algunos también. Esto. Que, no sé, cualquiera que quiera decir algo puede levantar la mano. Por ejemplo, estoy viendo al doctor Raúl Torres. ¿Qué estás pensando, Raúl? Tú haces ecoendoscopia y no haces CPR, ¿no, Raúl? ¿Y eres feliz así, haciendo ecoendoscopia sin hacer CPR? Sí. Sí.
Hombre, yo en mi charla ya lo comentaba esto, pero yo lo que sí que creo es que los que aprenden a hacer CPR actualmente han de aprender econdoscopia al mismo tiempo, y esto lo veo impepinable, ¿no? Yo no enseñaré a nadie para que se forme en mi centro a hacer CPR sin econdoscopia. Ahora, al revés, uno puede hacer econdoscopia y no hacer ni intervencionismo ni hacer CPR. Pero de la otra branca, como decimos, de la otra rama, no. O sea, si haces CPR, para mí has de hacer econdoscopia actualmente, cuando aprendas. Otra cosa, la gente que ya ha aprendido, ¿no?, CPR, porque yo creo que lo que ella dice, yo creo que no tendremos que firmar un consentimiento de CPR o de econdoscopia a un paciente antes de una prueba, sino de drenaje biliar. Y ya veremos cómo lo drenamos, ¿no? Pero es mi opinión. That for me is mandatory first. If you wanted to do ERCP, also you have to learn to perform EUS. For me, yes, for me it's mandatory nowadays to learn the two techniques at the same time.
Yeah.
Sí.
Yo quería preguntar, porque lo de la CPR y la econdoscopia en los hospitales, en los centros grandes, donde a veces se puede coordinar para hacer las mismas pruebas, pero hay otros hospitales más pequeños que necesitan una sala de rayos, que la comparten con otros servicios, solo la utilizan, tienen que utilizar, eso es lo que veo que pasa, ¿no?, que solo pueden utilizar la sala de rayos 1 o 2 veces a la semana, que meten todos los casos de CPR, y eso impide a veces que haya un crecimiento, ¿no?, de conjugar la CPR y la econdoscopia en la misma sala para hacer procedimientos, ¿no? Pues, por ejemplo, para maximizar el tiempo de esa sala que tienen, y eso es lo que sucede, ¿no? O sea que yo creo que también para hacer las dos cosas y combinarlas también tiene que ser muy importante la logística y cómo lo tengas en el hospital, ¿no? Bueno, no sé.
Sí, es un tema importante, pero claro, yo, por ejemplo, no me imagino ahora de hacer una CPR sin tener el eco. O sea, para mí es impensable, tanto porque la hago antes para verificar si realmente sabe hacer la CPR, como por si no puedo canular, ¿no? O depende que pueda salir, no sé, yo es que como lo veo tan absolutamente unido, y a lo mejor esto se ha de cambiar la mentalidad, ¿sabes?
Bueno,
porque
si tienes una sala que es para ecodiagnóstica, ¿no?, solo tienes un eco, ¿no? O sea, a veces, por ejemplo, es un tema de logística, y tienes luego la sala de rayos y tienes citados los de rayos, tienes el eco que se está utilizando, o sea que también tienes que tener una capacidad, un número de econdoscopios, un número o sea que eso te plantea si para llegar a ese punto tienes que tener un número de pacientes necesario para poder hacer eso así, ¿no? Bueno, no sé, por decir, o meter un poco de polémica o de eso, ¿no?
Pero bueno, hacer, por ejemplo, sí que es verdad que en sitios yo creo que con poco volumen tampoco se tienen que hacer según qué cosas. Esto también,
Eso es
eso es una
interesante,
cosa,
¿no? También hablar.
eso es una cosa clara, ¿no? Entonces, si no puedes, pues lo derivas a otro centro que no tenga más volumen y sepa más, sobre todo por un tema de complicaciones asociadas. Pero para hacer una diagnóstica, ¿no? Antes de hacer una CPR o algo, eso creo que te saca poco tiempo y es logísticamente,
Sí,
¿no?
sí.
Muy bien, bueno, pues una cualidad femenina es que somos capaces de cambiar las cosas, de ser elásticas y de hacer una alternativa. Entonces vamos a cambiar de nuevo el orden de las charlas porque la doctora Chahal me comenta que su charla es muy interactiva, de preguntas al público, que apenas necesitaba soporte con diapositivas. Entonces, por favor, doctora Chahal, when you want, please.
Thank you so much. You know, I thought, so Manolo asked me to talk about effective mentoring, lessons learned. That was the topic that was given to me. But I changed the title to Effective Mentoring, Lessons Still Learning. I think all of us are lifelong learners, even though I've been in practice for 15 years. I've had the honor and privilege of mentoring more than 40, 45 trainees. Every trainee that we take on, it's something that you learn about yourself and about the individual that you're mentoring. And I see people here in the audience, Jose Ramon, Manolo, you guys have been mentoring for years and years, and a few of your mentees are here in the audience. And I would like to ask you also a question as to what you thought and what your experience has been in mentoring the trainees, and what do you consider that relationship? Is it a collaboration or is it a lifelong relationship? I think when we talk about mentors, there are a few words that are used interchangeably: mentor, advisor, coach, support. So he or she is someone who's knowledgeable, with resources, who can create connections for you, who teaches you, who advises you, who coaches you, who supports you, who promotes you, who empowers you. And you know, over the years when I've had the privilege of mentor trainees, most of the times it ends up being a lifelong collaboration. You know, for me, they become a family. And personally, I feel like, you know, not to sound patronizing, they are like my children. I'm responsible for their success. If for some reason, by definition, somebody say they are not good or they failed, it's not their failure, I feel like it's my failure. I was not able to do my job and get them to the point where they will be successful. But at the same time, I do believe this is more of a give and take relationship. There are so many mentees that I can recall over the years. Somehow they manage to get more out of you. So if somebody is taking few steps towards you, you take double more towards them. So mentee also has to do their job. You know, they have to be aware, they have to put in the hard work, they have to be available, they have to meet the deadlines, and be passionate, eager to learn. So first and foremost, when I'm talking to a potential mentee, I try to understand what are their goals and objectives. You know, sometimes they just reach out to you because they want their CV to look better, because they want to apply for fellowship. That's okay. I mean, that's more like a short-term collaboration they're looking for. They're looking for quick case report, case series, because they're applying. And that would be the end of the collaboration. I'm not sure if I would really call that as a mentorship, apart from just teaching them how to create videos and how to write a manuscript. You are not really in charge of their career. You're not in charge of their professional and personal growth. But if their goal is more beyond the CV, they are looking to learn from you, from your experience, from your successes, from your failures, what they should do in order to have a career better than yours. I think the goal of every mentor should be that the mentee is more successful than them. I think that is individually, I think, our biggest legacy that we are going to leave behind. Not the papers we publish, but people we train who will go on to train others. So, you know, when I look at the list of what are some of the characteristics of mentor and mentee, some of the things that I would have discussed is, you know, you are there to offer your support, open doors for them, impart your knowledge, challenge them, create a relationship of mutual trust and respect. I think that is paramount. You should also know your limitations. I think if you are in your early phases of career, you are not a sound investigator, or you do not have connections that can open the door for your mentee. I think both of you are a little bit learning at that initial stages. So it's very important to let the mentee know what are the things that you will be able to help a person. But later on in the stage, when you're more established, your investigative skills are more sound, you can absolutely make phenomenal impact on a trainee's life. I mean, some of the things that I learned, growing up with my mentors, you learn from that. You also learn what not to do, not what to do, but also what not to do based on your experience. And then every mentee-mentor relationship teaches you more. It's important to have commitment. I think, I have an open door policy. They can email me, they can text me. You make yourself available to them. You're not like, well, don't call me over the weekend, don't text me over the weekend. I think it's important that, as I said, they are like your kids. You make yourself available, give them the time. And both of you are actually learning at the same time. Early on, if you don't have sound investigative skills, you learn. You try to improve your skills so you can be better for your trainee. Try to identify ideas, give each other feedback. I'm quite transparent in feedback. Sometimes it backfires. It also depends upon the person you're giving the feedback to. Sometimes some people, they don't take feedback really well, especially if it's quite transparent. They may become defensive. That's okay. But for me, my goal, my values are, I'm gonna do my job as a mentor, because sometimes people, they don't tell you the right thing, and you wish somebody had told me. That this is what you're doing wrong, this is how you write an email, this is how you communicate. So I think it's important that your mentee knows you and you are quite transparent in communicating with them. As far as mentee is concerned, as I mentioned, they need to show up with their socks pulled up. That's how they're gonna get most out from you. It's not a spoon-feeding relationship. They need to show engagement, they need to show passion, they need to do the hard work, they need to be inquisitive. Oftentimes a mentee will show up in the endoscopy unit and say, hey, what about this idea, what about this idea? And that's how you end up working on so many fantastic things. They should be comfortable to share their concerns. If something is not going right, the relation should be such that they are not intimidated. They are comfortable telling you, hey, this is not working, this is working, these are my concerns, this is how I see things progressing. 1 year, 2 year, 5 years down the road, is this something, you can help with and whatnot? So it should be an open communication without a sense of that they're getting intimidated. So I know I've been going on a monologue here, but I would like to hear what Manolo and Jose Ramon and other people in the audience, Uzma, panel here.
Very interesting. So many of the things you said relate. But I wanted to ask you, just to put your mentee-mentor relationship, what is your typical mentee? You're talking about someone who enters a GI fellowship after 3 years of clinical education in internal medicine, right? So the commitment is for 3 years, let's say, initially, and it is for someone who's already been, trained or educated in the basics of practice, clinical practice. And also, I understand in your system, they choose you and you get to choose them. You have like interviews, like an application process with deadlines. So it's more or less like marriage, when there was marriage back in the days. So it's something, there's freedom on both sides. And then what is the content of that, contract or agreement is both for clinical training, like learning how to do gastroscopy, colonoscopy, or ERCP, or how to connect with other faculty, because your mentee is not just your own child. No, there's is like a set of parents,
Yeah.
and it's like a hippie style. No? There are
Yeah.
other, IBD, liver,
Yeah.
so they have to learn a bunch of other things. And then the fourth question, or the fourth issue, is it normal in your system, which is very different from ours? So I think that in the United States, probably the mentor-mentee relationship is something much more important. It's part of the system. For us, it's not as clearly defined. So, but what when things go wrong? Is it normal if you don't, for whatever reason, you don't connect with someone, or you feel your mentee is not, or you're not helping him or her? Does it happen that somebody has to change in the middle of their training? So those are my questions or comments.
Yeah.
For us, we get different levels, from internal medicine residents to GI fellows to advanced fellows to junior faculty, who are all going to want different levels of support. Like with the internal medicine resident, it's just a case report, versus the advanced endoscopy fellow, we are with them every single day for a year. And that relationship is very strong because we have to teach them how to do procedures, plus research, plus career advice. So I think it just depends on what level. You guys don't do interviews for your fellows, and they're just told you're coming here? Nobody has a choice in that? Okay. Not that those interviews are foolproof, because you can have 45 children, but only 20 are your favorites. So the other 20 may not have perhaps been as successful. But I think and what you were talking about, when a relationship maybe doesn't work out, how do you handle that? Because I do think it's a two-way street, and I have had mentees just show up in my office and tell me how to be internationally famous. Literally that question, and it's like, come on, you're clearly missing the point, and you can try your best, and I agree, I saw it initially as my failure, but at a certain point, it's not all on you for someone else's career success and how they carry themselves in life. So I think trying to establish boundaries up front and expectations, I'm like you, I'm very transparent at the beginning of the year. I'll say these are our goals. We're going to meet every 2 to 4 weeks and review how you're doing procedure-wise, how you're doing research-wise, how you're doing in communicating with our staff, and how you are in a team environment. And if some people aren't living up to that, what ends up happening is your mentor is going to pull back, and I know myself, I'm not going to give you as much of my time and attention because you're not giving me equal amounts. So you have to kind of recognize that not all of them are going to work out.
Yeah. No, I think I agree with you on everything. We have different levels, as Manolo was asking, starting from medical school. Some are there just for a week or 10 days. Another is more of a lifelong. Especially the advanced trainee that you train, they call you frequently, seeking advice. And do I call my mentors that trained me so many years ago? Yes, I do that from time to time. Hey, how would you approach that? Just a couple days ago, I did a gallbladder drainage. I had to go through the antrum. I never do that, but I couldn't access it. And the patient came back 10 days later, the stent had partially migrated out. And then fortunately, there was a tract. I put in a double pigtail. This is the first case where I put in 2 double pigtails, both migrated inside the gallbladder. So, and then I called, Todd. I'm like, hey, have you seen this before? So, this is what I mean by this is more of a lifelong relationship that you carve out. And yes, there have been scenarios where, you're giving an honest, transparent feedback. You see there are some challenges in terms of communication, either with the peers and whatnot. And the feedback you're getting from the other faculty is not positive about the mentee. And you do your best to transparently communicate that with you, but they hold it against you. But what I've realized over the year is, I think that's probably, a little bit of immaturity in some trainees at that phase. And I've seen those people as they go on over the years, they come back because they appreciate what you were trying to do, what your intent was. So sooner or later, they do realize that you meant well, your intent was good, and they come back and, So, but, yes, you're right. Everybody is different, so all we can do is try to do our best as teachers.
I was going to say, and maybe you could comment on this as well, sometimes I do feel that the female trainees feel a lot, they feel like they can unload on you as their mentor because you're a woman in a more kind of direct, aggressive manner than they would to a male.
Yeah.
And again, I don't know if it's just familiarity, maybe a lack of respect, but sometimes I notice the women are much harder on me as the attending than and the things they say to me compared to what they would say to a male leader. I feel like there's a level of comfort they have in doing.
Conference. Y a petición de, dar las gracias sobre todo a Boston y a Manolo por estar aquí. Y a petición de Uzma hemos dicho de preguntar a ver cuántos de los que estáis aquí estáis aprendiendo a hacer técnicas de CPRE y condoscopia, que sois, ¿no? Trainees, que se llama, ¿no? En inglés. No sé si... ¿Cuántos de vosotros? ¿Os consideráis que estáis aprendiendo?
I said, don't be afraid.
Afraid, ya sí, que no tengáis miedo de...
No, we are. But I forgot to, I guess we didn't introduce ourselves. I'm Uzma Siddiqui. I'm director of our therapeutic endoscopy unit at the University of Chicago and also direct our advanced endoscopy fellowship.
Hi, I'm Prableen Chahal. I'm at Cleveland Clinic, Ohio. I'm the director of advanced endoscopy training. My main focus is pancreaticobiliary endoscopy. I've been in practice for 15 years. And thank you so much.
Sí. Oh, vale, bueno, pues sí. ¿Y quiénes de aquí o hacen eco, por ejemplo, y no hacen CPRE? ¿Solo eco? I'm asking only the person in the US. Yes. ¿Y CPRE? Vale. ¿Y eco y CPRE? ¿Y los que no habéis levantado la mano? ¿Qué hacéis? No, bueno, no, pero que sean hombres y mujeres, es igual. ¿No? Y dentro de la ecoterapéutica, que os consideráis que hagáis todo tipo de la ecoterapéutica actual. Therapeutic endoscopic ultrasound. I'm asking you therapeutic endoscopic ultrasound.
Yeah, sure. Yeah, they can ask questions.
Can I? Levant.
Que entre los asistentes hay gastroenterólogos generales, médicos en formación. También hay gente que no son médicos, pero que están interesados en la endoscopia biliopancreática. A lo mejor trabajan para compañías que tienen productos. O sea, que puede haber gente que no ha levantado la mano no porque no te quiera hacer caso, sino porque, por ejemplo, Francisco no hace endoscopia. No hace CPR, pero sabe mucho.
Sí,
pero
Josep también doy fe, Josep también.
Bueno. O Víctor, que está aquí a mi lado. Entonces, bueno, so we just...
I just heard Francisco knows a lot, even though he doesn't scope.
Yeah, you're getting better in Spanish. It's amazing. So you've gone beyond abra la boca?
A little bit. We're all here to learn, so...
No, what I've just said is... the questions, people didn't raise their hands because some are just general gastroenterologists, so not doing pancreaticobiliary endoscopy. And there are people working for companies, most of them with interest in interventional US. So we all have an interest, but not necessarily means that we perform the procedures ourselves. So anyhow, if we manage to get these
Bueno, vamos a empezar porque vamos ya un poco tardes. The next speaker will be the last speaker of the section number 4. His name is Vinay, a ver si digo bien el apellido, Chandrasekhar from Mayo Clinic, Rochester. Please, Vinay, you have 15 minutes to give us this talk about US guided pancreatic duct interventions.
Okay. All right, should I give everyone a
Id
minute?
entrando, por favor, sin hacer ruido, que vamos a empezar la charla. Gracias. Después de esta charla pasaremos a las salas. After this lecture, we'll come back to the endoscopy rooms, and then we'll begin with the last lectures.
Okay.
Please, Vinay.
All right, I'd like to thank course organizers, especially Manolo, for inviting me to this excellent course. I was tasked with giving a talk on EUS-guided pancreatic duct drainage, and specifically to talk about the indications, choice of approach, and follow-up strategies. So I have no relevant disclosures pertaining to this. Now, EUS pancreatic duct drainage has been described more than 20 years ago. It was first described in 2002, first with a EUS-guided transduodenal rendezvous approach. Shortly thereafter, there was a report of EUS pancreaticogastrostomy was described. I will say, and I want to say it up front, and I'll say it again, that EUS pancreatic duct drainage remains one of the most technically challenging procedures, especially for interventional EUS. And if you look at the literature on historical data and centers that have published on this, high-volume centers, when they're publishing their data, they publish 2 to 4 cases per year. Now, granted, we're doing more and more interventional cases, so that number may be higher, but I just want to put that in the frame of context that if you're doing 10 EUS pancreatic duct drainage procedures a year, that's a high-volume center. Now, we're going to talk about indications first, and as this video plays, this shows an example of a prime example of a patient who may benefit from EUS-guided pancreatic duct drainage. This is someone with chronic calcific pancreatitis, upstream main pancreatic duct dilation, has pain, has a large stone disease burden in the head of the pancreas. So indications are typically in native anatomy are after first trying ERCP, now ERP in particular. ERP is the preferred approach, especially if it's feasible. And EUS duct rendezvous should be reserved for those cases when ERP is not feasible. Often due to a large stone burden or large stones in the head of the pancreas, so you can't get deep access into the pancreatic duct, or in cases of disconnected pancreatic duct syndrome where you cannot access the segment that's completely disconnected. Now, in surgically altered anatomy or inaccessible main pancreatic duct, the indications are the same for standard anatomy, but in addition, we often see pancreatico-jejunal anastomotic strictures, and then other standard indications like we talked about, stenosis and leak. What are the contraindications to EUS-guided pancreatic duct drainage? Well, inability to visualize the main pancreatic duct or lack of main pancreatic duct dilation are the 2 most common ones not to perform EUS pancreatic duct rendezvous or duct drainage. However, you usually know that ahead of time. You usually know that with the dedicated CT scan or preferably an MRI, MRCP, and you can tell that this patient's maybe not a candidate for this type of approach ahead of time and not bring them into the endoscopy unit. Well, when you're in the endoscopy unit and performing the EUS, what are the things that are technical challenges for not performing the EUS pancreatic duct drainage? Well, if there's intervening vessels at the puncture site, there's a long distance between the bowel lumen and the main pancreatic duct, or there's multiple main pancreatic duct strictures, so multiple segmental strictures. Patient factors, again, that you know ahead of time, usually hemodynamic instability or coagulopathy, thrombocytopenia, where you're at risk for bleeding with a puncture via EUS. So now we're going to move on to the approach. And so, the approach is varied. And if you ask the experts and the people in this room who I think are bona fide experts, everyone has a little bit different a way that they do this. Something that I saw in a recent review that I thought was very interesting is very similar to what we think in bile duct drainage. If you're doing a rendezvous approach, you want the runway to be as small as possible. So you have a small runway here. You can see puncture is close to the site. You can get the wire in, then you grab the wire and then do your rendezvous. In those that you want primary pancreatic duct drainage with a stent into the pancreatic duct or through the pancreatic duct, you tend to puncture a little bit more upstream from the orifice. What about patient preparation? And you've seen this in live cases. Some people like supine, some people like prone, both are fine. Prophylactic antibiotics are often administered for EUS-guided pancreatic duct drainage when you're puncturing. And then also, you want to hold antithrombotic and antiplatelet agents to make sure that you reduce the risk of bleeding. Now, we just discussed a little bit about the approaches, but I want to go into more detail. EUS-guided rendezvous in standard anatomy is the preferred approach. Well, why is that? Well, in the described literature, the rendezvous approach has the higher rates of success, lower adverse events, and the stent is placed within the normal anatomical plane. So you're placing it through the major papilla into the main pancreatic duct. Now, as an alternate, or in those with surgically altered anatomy, EUS-guided transmural drainage may be your only option. And for this, you have two options. In surgically altered anatomy, it's EUS-guided pancreaticogastrostomy, or in those with failed ERCP, you can consider EUS pancreaticoduodenostomy. So EUS rendezvous is, again, as I mentioned, typically utilized when the papilla is still accessible. On full transparency, this is a patient that we had already had access, and what we're doing is now we're trying to do a rendezvous. So what you're seeing, I've started this video with a balloon, coiling the wire into the small bowel, and then grabbing the wire. So you advance that wire into the small bowel, try to grasp it or cannulate alongside the wire. Then what I do is, if I'm going over the wire, what we've seen today is not to go through that tract. So you've punctured it. So what you do is you pull that wire once you've accessed the main pancreatic duct, advance your catheter into the main pancreatic duct, then use a different wire or take the same wire out and put it back in through the catheter, and then slowly advance it. I like to use an angled small guide wire that is not very stiff. That way it doesn't go through the side branches, and then you use that to then cannulate and put a stent into the main pancreatic duct. And you can see that here. Oftentimes these procedures take a little bit of patience. The pancreatic parenchyma is often very difficult to puncture, especially in patients with chronic calcific pancreatitis. You see a lot of fibrotic parenchyma. And so that's why I think these are very difficult procedures. Now, transmural drainage is where we're actually intending to not do a rendezvous approach, but either drain directly into the pancreatic duct, or to do something called a ring drainage, where you put a stent that goes from the stomach into the pancreas into the small bowel, either jejunum or duodenum. So I like to do that when feasible. That's called a ring drainage, and that's because I think that if you can cross the anastomosis or the native pancreatic orifice, it's very nice to do that. Here you can see we're puncturing actually quite low, but we were able to get a wire into the pancreatic duct, then get it into the in this case small bowel, and then what I did is dilate the tract, then dilate the distal anastomosis stricture, and then we place the stent across here. So these are very, very, very difficult procedures. The pancreas is fibrotic. Sometimes your scope position, you can see you struggle with it sometimes. Very difficult to advance the stent through tough parenchyma, and difficult to cross the anastomotic strictures. But when they're successful, they go very, very, very well. So what are the challenges? I alluded to this before. I was looking for a video. I actually have a video where I punctured the pancreatic duct and the needle broke. It was so hard, the pancreas. Some of these patients with chronic pancreatitis can be very fibrotic. The unstable scope position may result in poor transmission of force, as you've seen in some of those videos. Difficult wire advancement, the angle of the wire in the main pancreatic duct. As you've seen in this course, there's a risk of wire shearing, so you really want to puncture not in a perpendicular, but a little bit tangential, so that you can advance that wire into the direction that you'd like to go. And then you have the added challenge of trying to negotiate strictures or stones. Calcific stones in the main pancreatic duct are very hard, as you all know, so to even get a guide wire sometimes is very challenging. Well, what about the Spanish experience? So there was a very nice study that was published in 2012, that looked at 19 centers with limited EUS cholangiopancreatography. And what they looked at is what's the experience with EUS pancreas duct versus EUS biliary cholangiography. And what they found was that technical success with the pancreatic access was much lower, 57.9% versus 68.9%, and the adverse event rate was higher. And the main reason for failure with the EUS-guided pancreatic interventions was due to failed manipulation of the guide wire. I think as people become more comfortable with manipulating guide wires and ERCP and challenging, that becomes a little bit easier. There's a lot of technical variations. People have described anti-migratory fully covered SEMs, double guide wire technique. So once you get access, then you saw it today actually describe where they actually then put a second wire through to stabilize and help with passing the stents and devices across when you have two guide wires. We actually published a study last year on cross-platform devices, so using angioplasty balloon catheters that IR or cardiology use in the vessels. So these are very slim profile, 3 to 4 millimeter balloon dilators that go over only an 0 and 8 wire. So the wire's a little bit not as stiff, but they're very nice to puncture and to dilate. And then as you've seen highlighted in countries such as Japan and Asia, they have these ultra-tapered mechanical dilators, only 2.5 French, that makes puncturing the dilation site much easier to then get your accessories and stents across. Well, what about follow-up? Follow-up is not standardized. We've heard this again with gallbladder drainage. Follow-up is very, very much differs from individual to individual and center to center. Published data of long-term follow-up from our center, we had published back in 2013 that 70% of patients with more than 1 year follow-up had complete symptom resolution when they had EUS-guided pancreatic duct interventions. And in this series, stents were removed after a median of 4 months in 23 patients, and then recurrence of symptoms occurred in about 13%. So you do see recurrence in these patients, which is why some people like to leave these stents in much longer, or they do an elective stent exchange. My personal bias is to do an elective stent exchange in 4 to 6 months, pull the stent out, and then you address what you need to do. If there's a stone blocking it, then you may consider doing a pancreatoscopy, doing AHL, lithotripsy. If there's a stricture, then gradually dilating that stricture and treating it like a main pancreatic duct stricture. In a multi-center prospective study of 80 patients, including 66 with malignancy, 36 with surgically altered anatomy, you can see technical success was higher in this. Clinical success is 80%. But I think I need to underscore that the adverse event rates are very high for this procedure. 20% immediate adverse events, of which 80% of those are considered major. Leak, pancreas duct leak, which can result in bad pancreatitis, necrotizing pancreatitis, pancreatic fluid collections. So yes, there is a high success rate, but you have to be ready for potential complications with these procedures. And then, in a systematic review, 20 cases, again, this highlights adverse events 25%, serious adverse events of 5%. Then when you look at comparative data, EUS-guided versus ERCP-guided in surgically altered anatomy, pancreatic jejunectomy stenosis, EUS had a higher rate of pancreatic duct opacification, higher cannulation, successful stent placement, and higher clinical success. Most people do not like doing double balloon or long balloon enteroscopy after to do a Roux-en-Y and then place a pancreatic duct stent. Most people would prefer an EUS-guided approach, but again, there are high risks of adverse events. But what about training? I think this is a very interesting study. Now, it's only one endoscopist, 56 cases, but the mean procedural time was 80 minutes. And to achieve that, it took at least 27 cases to reach that 80-minute range. So 80 minutes to do pancreatic duct drainage. But then what they saw is that individual required 40 procedures before they saw a plateau in their time for pancreatic duct drainage. So if you do the math, if you're a high volume person doing 8 to 10 a year, that's 5 years of you're still learning on the learning curve before you're actually getting really good. So takeaways, EUS pancreatic duct drainage is a valuable technique when the main pancreatic duct cannot be cannulated. Rendezvous is preferred to transmural drainage in native anatomy. There's significant risks associated with adverse events. Even with experienced operators, it's a long learning curve, and we need more better dedicated devices for EUS pancreatic duct drainage. And with that, I'd like to thank you, welcome you to Mayo Clinic if you want to come in the winter.
Thank you very much. You spent only 12 minutes giving this talk, so we can ask you some questions. Questions from the audience or from here, moderators? If not, I wanted to ask you about the ring drainage, no? I mean, I think it was reported from Mayo or Top Baron, the ring drainage.
Yeah, that's
realize because it's more physiological than you combine, no? The transmural drainage with transpapillary drainage.
Yeah.
And not that the pancreatic joist can go to the gastric cavity and the papillary.
Or into the duodenal, small bowel. So ring drainage, I think I was always worried. So ring drainage again is when you have basically a loop of stent in the stomach. The stent goes into the pancreas, then it goes into the small bowel. I was always worried about causing occlusion, or maybe if you leave the stent in for a long period of time, you'd develop pancreatic sludge, pancreatic lithiasis in the upstream segment that you're potentially blocking. I've had patients who've had ring drainage. I tell them to come back in 6 months. They feel great. They've never felt that. They don't come back. They don't follow up. I think ring drainage is like, as you mentioned, physiologically it makes sense because the pancreatic juice is preferentially draining towards the small bowel, but can also come up back into the stomach as well. And I find that these patients have 2 exit pathways. So if for some reason the stent gets clogged on one end, you still have another area where the pancreas juice can drain to. So these patients do well.
But it's very demanding, no? Sometimes, to convert, no, the transmural drainage to
you
need to do rendezvous across.
Yeah, so you have to puncture. You have to get across. My first time, I remember with Mark Topazian when he was doing these, I used to try to cannulate alongside, and you have to not be scared. Once you have the tract, your tract is mature. You have to pull that stent out, so you lose access, and then you have to get a guide wire back in. So in those cases, it can be somewhat tricky. I've converted some ring drainages to then internal drainage from below if it's native papilla. So, I mean, I think there's a lot of opportunities. Again, not much data out there, and it's very, very difficult. It's great when it works, very difficult to cross some pancreatic duct strictures when you're puncturing in the body and the strictures in the head of the pancreas. Sometimes very difficult.
Yeah, in some cases I have used the spyglass to perform it, but it's very demanding.
Yeah, so what you do in that case is just establish access. Then you can always come back at another time through that tract, dilate it up, and you can use cholangioscopy or pancreatoscopy.
Okay, thank you. What other experts think about this technique?
The other thing I'll say is if you have, don't forget about other non-endoscopic techniques. If you have ESWL with the urologists use for kidney stones, you know, ESWL, if you use that, those are non-endoscopic techniques that can be adjuncts to help. The case that I show with the indication with the big stone burden at the head, I was prepared to do an EUS-guided puncture, and I sent the patient for ESWL and said, let me just give it one more shot with ERCP, and we got across with ERCP. So again, I say make sure you don't attempt EUS-guided drainage until you've exhausted all of your ERCP abilities.
I would like to talk, you talk about 6 months of follow-up in your patient as soon as you reach the pancreatic gastroscopy fistula. I wonder how long you stay the stent in place, or you exchange the stent, or you leave alone, or whatever?
Yeah, so again, I think it's individual. If you ask everyone here, they have a different preference with how they do that. Some people would change it 3 months, some people say 6 months, some people say 1 year, some people say just whenever the patient calls to say they're having pain again, come back on demand. I don't think we know the answer to that. I just pick, if it's a ring drainage, I pick 6 months. If it's not, then I bring them back sooner because I want to maybe even upsize the stent. So a lot of the technical factors, are you getting a 5 French stent in, a 7 French stent in? That'll impact your follow-up interval.
Given that the technique and the pancreas are so complicated, have you developed any predictors of success? Are there any parameters where you would say, let's go for it, the drainage, or don't do it?
Yeah, it's a good question. I mean, I think there are some parameters of success. Now, again, you're not going to have robust data. So I personally think that the more dilated the main pancreatic duct is, the more likelihood that you will be able to isolate it and get a stent into that. Okay, that's number one. Number two is, these are technical factors when you're actually in the procedure, your scope stability. So if you feel like you're in a very stable position and you can transmit your force much easier, your chance of success is going to be much higher. In those cases where you're struggling to find the pancreatic duct and you keep falling back, I mean, we've all experienced those cases. Those, I think, are going to be the cases where you're more likely to fail. I think also, as I've seen, I personally believe if you're working a little bit close, but not too close to the stricture, or you have a little more leverage. If you're too far away in the tail, you don't have much of that force that you can transmit making that loop and then going across to the head. So if you have a very tough stenosis, if you're able to transmit that force, I think that helps quite a bit. And I also think, don't forget about your accessory tools. If it's a stone, you have other things that you can think about to help you. No, endoscopy may not be the only way to treat this.
Great. And now I know in the audience there will be several ones that will be starting or are doing this procedure, but they don't want to be in the 40 cases group. With your experience, they want to have a learning curve of or 10 or 20. So what do you recommend? Which to get faster?
Yeah.
And the wire problem is a big one. Are there any specific wires that you would say no or yes?
Okay, so I think there's a very good point. Number one, I think you need to be very good with ERCP, wire manipulation. Okay? So if you're learning this, you should be really good with wire manipulation and getting across angles and tight strictures. Number two, I would say if you're starting off with EUS guided bile duct rendezvous, bile duct drainage, learn how the scope behaves, how you advance, how you dilate across the tract before you tackle a pancreas case by yourself. I would say in that fashion.
Okay, thank you very much.
Question?
No.
No, Ramon is
perfect.
coming that we have to move to the endoscopy room, so thank you, Vinay.
Okay, next case, very interesting. They are waiting for us. Okay. Good. It's a female, 79 years old, with a hostile abdomen. Nephrectomy due to renal TB in 1999, left inguinal hernia, low anterior resection due to a rectal adenocarcinoma, total gastrectomy and Roux-en-Y due to a perforation, and peritonitis due to a peptic ulcer disease in 15. Biliary colic in December 2021, and cholestasis, and abdominal US, cholelithiasis, dilation of the bile duct, and prepapillary cholelithiasis. In use guide enterostomy for access to papilla, we could see that ampulla cannulation was not achieved, but an ampullar adenoma was found and resected. Transenteric cholangiography did not show CVD dilation or cholelithiasis, and subsequent MRI confirmed the findings, and patient was discharged. Currently, in September, recurrence of biliary colic in CT scan, cholelithiasis, no dilation of CVD nor cholelithiasis, and working EE lamps. Lab test was okay, and her surgeons rules out cholecystectomy and proposes EUS-guided gallbladder drainage. Por favor, pasamos a la sala.
And now go over to the operating room. Yes, hello, fine. Todos.
Next case with a very big team, a fantastic team, leading by Dr. Siddiqui, Dr. Anderloni, and the rest of the effective, Dr. Perez, anesthesiologist, and the nurses, Monica and Lorena. Dr. Siddiqui has inserted.
Okay, and don't forget Marina.
Sorry,
Another
Marina.
therapeutic endoscopist. Okay.
He's following here, so.
All right, so, obviously everything in Valladolid is never straightforward. This is a gallbladder drainage case, but we have to make our way through the Axios. It was placed, I think they told you back in April, so we know the tract should be pretty mature at this point, and it was maybe about 55 centimeters from the initial anastomosis, and we are using a 180 therapeutic EUS Olympus scope, and we have the
UM2
EUM2, yes.
here.
And Dr. Androloni is going to be my expert on setting that up. So normally, even if I do the cases freehand, I do like to have the patient on the fluoroscopy table just in case the stent misdeploys or I need to pass a wire or salvage the procedure. So the patient is left lateral, intubated, and on the fluoroscopy table. I don't know if you can make out our scope and where the axio stent is, but now we're going to just try to tip into it. And this was a 20 millimeter.
So first of all, Uzma, we can see that the hot axios is still there, nicely placed, and this is very important also to know that it can stay in place for several months.
Yes. We did confirm, though, at least in the U.S., officially it's supposed to be only 60 days, but we do keep it in longer.
Yes.
But it's 20 or 15
I
millimeter,
thought it
the
was
lens?
20, but it
20.
wasn't.
2010,
Yeah.
2010.
You do see it gets a lot of biofilm on it, but now we're just trying to tip up. So, Andrea, do you have a lot of tips on doing gallbladder?
Oh,
in
yes,
this situation?
actually,
In this situation?
actually, this is something before the gallbladder. So, entering in such a difficult angle with an EUS scope is very difficult. We have to bear in mind that when we see endoscopically, we have the tip of the ultrasound scope that is further in. So sometimes it's better to come back a little bit, doing up, even if you don't see endoscopically, and follow it radiologically.
That is what I was trying to do, go
Yeah.
up. Worst case, we could pull it and go through, but then it may be hard to find the opening a little bit because it was set up on an angle.
Yeah.
So,
And
let's
of
try.
course, the EUS scope is not as flexible as a standard scope or a duodenoscope. But I have the impression that we are not gaining the access with the
No.
EUS probe. What do you think, Uzma?
I agree. Oh, well, now it's out.
Now, okay.
Oh, no, sorry. I thought I must have pushed it forward a little bit into the limb.
I think
So-
we have moved it inside.
Maybe
And
if-
here the X-ray could help us understanding.
I think it did move forward a little bit
Yes.
into the limb, but that's okay. We can at least still look on EUS.
Yes.
It was around 60 centimeters, which is where the scope is.
Okay. Okay. But to me, is this.
So it did get pushed forward a little bit.
Oh,
Okay.
that's good.
Yep, there you can see actually on endoscopic view. It did get pushed forward a little bit.
Yes.
But again, that's the beauty of having a mature track at this point.
So what is now your intention? To take it out and go for the gallbladder? To just leave it?
No, I was going to see if I could identify the gallbladder proximal and still stent it and then
Yes,
pull
and then,
that out.
yes.
Ideally. But
So-
if not, then I'll just,
You will remove the lamps later.
that's
No,
what
no.
I was thinking, assuming I can see the gallbladder proximal to it, which I was told it was around 60 centimeters. So we're just going to rotate.
So with the gallbladder, especially in altered anatomy, we do not have any specific area to drive us. This is
Correct.
just like, when you are searching gold. You need to try, you need to check.
Yep.
The other interesting thing is that since the hot axios has been placed a lot of time ago,
Now
we
you got
don't
it,
have
no?
any kind of problem with his removal.
So we did find the gallbladder.
In order to be sure, you are checking for the stones inside,
Yep.
but we like also to do this in order to be sure that this is not a vessel.
Correct. And also that there aren't going to be any vessels
Yeah.
in our tract.
So with the EOM2 from Olympus, we can use the Doppler or this nice high flow that reduce some aliasing phenomenon. Okay.
Got it. Now, it would be nice if we could measure the distance, although it's right up against the small bowel wall, so I
Yeah.
don't think we have to measure it.
But I like your way of thinking.
I try to do the same thing on every case, just so you don't
This is
forget
to
a step.
make everything reproducible.
Correct.
And this is very important. So less than 1 centimeter.
Perfect.
So I like that.
Then the other thing, since we do have fluoro here, you know, you can check the tip of your scope. Are we severely angulated? Because that can sometimes affect your axios deployment or get a misdeployment. But it looks pretty straight
Yeah.
at this point. It looks big enough, I think, to fit our stent. The other axios stent is a little bit more distal, so hopefully we'll be able to grab it and pull it out without disrupting the new one.
Yeah. Usually, what is your thought about the lens for a gallbladder? Do you usually use a specific dimension, specific
I
diameter?
usually do 15. That's
15.
my go-to. I think 20 just in general is a little bit more more stiff when you deploy it.
Yeah.
So I like 15. You could argue if there's no stones and you're not going to go back in, you could just go with a 10
A 10,
to
yes.
decompress it. In this case, I don't know if there would be any plans to go back and deal with these stones. She has biliary colic symptoms, so maybe just decompressing her gallbladder would be enough. But I was planning to go with a 15.
I agree. And we have to bear in mind that the catheter of the 15 is 10 French 0.7. That means that it will be very difficult to push when you are in such an angled position like Uzma showed you.
Yes.
But of course, we are going to lubricate the catheter, and then Uzma will show us some tricks for reducing the friction.
Now, we talked about earlier in the talks, you know, that you can go with a needle puncture, put a wire to have backup, or you can go freehand where you don't have a wire, or you can puncture freely and have a guide wire already preloaded into the Axios to go for it. But this looks pretty straightforward. So again, if it's pretty straightforward, I usually go freehand.
Although I never said it looks
I know.
straightforward, I totally agree with you. So let's go freehand,
And then we were also
wireless, and fluoroless.
agreed. The less steps, the better.
Yes. So probably, if she's going to feel some resistance, she has to release the tip of the scope a little bit, and that's it.
And now we're locked.
Do you recommend to use a preloaded guide wire for your first cases?
In the beginning, yes. Actually, that's not a bad idea, and I did use a guide wire in the beginning. So I think for a lot of people, if it gives you that sense of security. The only thing, again, except for a pseudocyst, you know, where it's really stuck to the GI tract wall, every time you puncture, you risk pushing things away. So whether it's small bowel, gallbladder, so less, I think, is better, but it does offer you that safety net.
I think, Uzma, you touch the real important thing here, because sometimes we think that something is helping us,
Yeah.
but if we do not know exactly how to use it, it can be really, really bad. So the guide wire is one of our best friend, but especially in interventional IUS, you need to know that if you are not doing traction, it
Correct.
can
Push
push
away.
everything away. So
Correct.
very, very nice.
Now,
Okay.
well, we could connect it, or after I get in, but
Is there
we were also discussing just before we started the various Irby settings, and there's a little bit of difference between the Spaniards and the Americans, because we usually put it on, this is the Irby Vio 3, AutoCut Effect 5, but here they use 3.6, but we put it on 5, because again, for this purpose, you just want max power output and quick cutting into it. We didn't see any vessels, so we should be
So, just to be sure, we are going to apply again the Doppler in order to check, so that you can be easily find the position. And
Is there another question from the audience or recommendation? No.
Okay. So I know this audience is very knowledgeable about Axios, and so, but just to review again, we're going to unlock the bottom of the catheter, and then I'm just going to push up
Do you like the Doppler to be?
No, I was going to say turn it off, please.
Okay, me too, me too.
Okay, so we're just going to get, you want to just make your target as big as possible, so that when you go in, you have as much room as you can.
So we can also, if you don't mind,
go ahead.
take here the measurement that I usually suggest you to check, especially at the beginning of your career. In order to check, I say, if you are at least 3 centimeters, you are safe. Look, Uzma, you can do your first axios easily now.
Thank you. No,
Okay.
that's a good point. Again, although if it was smaller and you just wanted drainage, maybe you would consider using a smaller caliber axios. But,
That's clever.
But that is something, if you're going to do 10 or above, then you want to make sure you have at least 3 centimeters. And so now we're right up against it.
Very important also not to have too much air between your scope and your target in order to do everything under direct visualization. And you saw here the blush sign. That is the sign that tell you that you are in, and I like the technique of Uzma that push the stent as much as she can in order to be even more sure.
Yes, I try to go...
Sorry, Uzma, I have to do this.
This is Italian method.
Okay.
But so I do like to push it down as far as possible, because then I know I'll have room when I deploy the distal flange. Make sure you lock it again, because that's how the misdeployments happen. We unhooked our cautery, and then now we're going to take off our safety tab, and then we're going to unlock, and we're going to deploy our distal flange.
Nice and easy.
Now, everyone talks about when you pull back the axios, you want to see the flange deform into a Hershey kiss or American football shape.
Yeah.
But the other thing you can look for is the catheter, I don't know what fancy name you can call it, but the stick inside, you see that starts out kind of towards the right side of the flange, but then as you pull back, you want to get it close to that left side of the flange.
Clear.
But not all the way touching. So it's kind of 2 methods to know, okay, I have enough pulled back on the stent. So you're just going to pull back. You see it in the middle, the catheter?
Yeah.
And then it's going to just tip up a little bit.
Oh, you are showing this technique. So you want this one to be closer to this one. Very nice.
So, and now I think this is good enough. You don't need it to touch. That might be a little too far, but I think we're good right now. Agreed?
Of course.
Okay, all right. Okay, and then now,
So how do you know that you are ready to deploy?
because of those 2 things, I deformed the flange shape. It looks like a Hershey kiss. Plus this inner catheter has moved up towards that top flange.
Okay.
So these are 2 factors. So now we're going to deploy under EUS guidance. Make sure you lock the bottom. That's key too. And so now we are going to deploy inside the scope.
So Uzma, this is the moment where everyone gets a little bit anxious.
Yes, I'm very anxious right now too.
So you have deployed all the stent inside the channel, and then with this gentle touch.
Yes, I know it. I
manage.
sometimes do it a little aggressively, my female hand. So, but you want to make sure you're going to have to pull the scope back a little, and you just want to make sure that you're not bringing the stent with you. So sometimes you do have to just kind of push it a little bit.
But you're repeating again the step number 1.
Correct.
Yeah.
Now we're unlocked on the bottom, and we are just kind of pulling this
But
back.
you need to pull back the scope
Yep.
a little bit.
That's what we're doing. And then we can also, if you want, we can double check on fluoro,
Very nice.
and it looks good.
And Dr. Siddiqui or Dr. Anderloni, when distal flanges take time to open, what do you recommend? Pass a little bit, wait, or something?
You mean like in the setting of if you have severe walled-off necrosis?
Or no,
a lot
or
of debris and that flange
due to
doesn't
the
open?
the own axios take time to open the distal flange.
It should open unless there are a lot of solid contacts in your collection.
Yeah, this could happen either in that occasion or if you have the gallbladder full with stones as well.
Yeah.
Or sometimes because you have a big tension on your system. If you have a big tension because the scope is banded, angulated, you need to wait a little bit in order to let the power of your movement to be transmitted to the end.
But usually, to prevent that, just try to make sure the tip of the scope is straight and that you're not as angulated. But usually the scenario is going to be something is inside the collection solid. And sometimes you can't open it all the way, and it's going to just have to take time. But those are even more nerve-wracking because it's very hard to see that you've opened it up completely.
So be patient, my friend.
Yes, let's say that. So now we deployed this. We were talking about pigtails. The data doesn't say that it necessarily helps. We're definitely not in the stomach here. So, and this position, you know, is not super easy. So I'm not going to put a pigtail.
Neither do I. I sometimes inflate air in order to see the vitality of the gallbladder, especially in case of acute cholecystitis. Not in this case, of course. So I think, Uzma, you did great, as usual.
No. So but now we're going to just take, I don't know, a grasper, and we're going to pull this up. And this is nice because we won't touch our new one, which is good.
Hopefully.
Meanwhile, could you explain us some rescue techniques in case of misdeployments, or lamps misdeployments?
Oh, good question. I think it depends on what the scenario is. Are you talking gallbladder? Are you talking EUS, gastroenterostomy, or a pancreatic collection? In a pancreatic collection, it's no problem. If you deploy everything into the collection, or even, I guess, into the gallbladder completely, usually that's why I use the 15 also, because then I'll just put a 20, and then I can pull out the stent that's deployed inside. If it's a pseudocyst, all you have to do is and you pull it all the way out, I just repuncture and put a new one, because it's going to close, and it's going to go through the path of least resistance.
So what I was going to ask you
wire, but
is now we are going to remove the 20 millimeter.
Or should I just put it back in place?
I was wondering, what is your plan?
Well, this case is unique, so I just don't know. They do have some gallstones. I don't know if anyone's going to come back or want to know, but the fistula, I don't know. It was in since April, so we're talking, 5 months, 5-6 months. Will it stay open because it's small bowel versus stomach?
I don't know. I don't know.
But
So
we could try to just put it right back in place. So
there are different techniques to do this. You can do it just now directly while you are withdrawing.
Or an upper scope.
Yeah, I would like to do
let's
the
do
upper
that.
scope in
I
order to
agree.
show. But we can take it out.
No, I was just going to pull it back into position.
Okay.
You want to completely.
We can also remove it
and
and
reload.
put inside the channel of
We
the
could
upper
do that.
scope
We could do that.
with the
too.
technique. What do you think?
We could go either way.
Well, you will do whatever you want.
Well, let me see the grasp
Yeah.
one more time. Then we'll just see. If it doesn't fit nicely, then we'll pull it out and we'll go with the upper.
Fantastic.
Yeah.
Okay, Dr. Monkemuller has one question for you.
Hi, Usma and Andrea.
Oh, hello.
Wonderful demonstration, and I hope that the Valladolid Live puts it on display on how to perfectly place in Axios through the gallbladder.
Thank you. Appreciate it.
Some questions.
Yes.
What are the indications for direct endoscopic gallbladder visualization? Are there any times where you would like to go in, inspect, clean, remove debris, or do you ever do it? And number two is, we expect this drainage to stay there a very long time, and I saw a big stone, and this patient has been producing stones forever.
Yes.
Would you like to place a double pigtail inside in this specific case, or when do you use drainage, if at all?
So we were just saying for double pigtails, I don't place them necessarily unless there are a lot of stones. It's in the antrum near the pylorus. I'm worried about occlusion. But the truth is, those sometimes migrate anyway, so then it doesn't really add much. So I'm not doing as many pigtails as I used to. This location, we don't think pigtail is worth it. And then it depends on the patient. You can come back after at least 4 weeks once you have a mature fistula track and deal with the stones. Okay, open. But that's the question for this particular patient. Close. I don't know 100% what their plan will be in terms of follow-up for this patient.
So I want you now to look at Uzma movement. She's pushing a little bit forward the stent in order to have a better view endoscopically, to analyze where the fistula is. Look at this.
Which is right here.
And she will gently pull back, trying to reposition the stent. And if it works, we can go and have a coffee. If it doesn't work, we have the plan B.
Correct, yes.
I think that one of the things that we bring home after Valladolid is that in your life it's always better to have plan A, plan B, and if you are in Valladolid, you have also plan C, D, E, F.
Well, I was,
It's not necessary.
no, and I was going to grab it, yeah. I just wanted to get a little bit. Open? Oh, you don't. Okay, open? 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 Okay, close? I was going to say the main takeaway is that if you have 5 endoscopists in the room, everyone has a different opinion sometimes, but we are agreeing today, so, okay, open?
Is this a standard grasping forceps?
Close.
It's a crocodile or?
Open? Close?
What is the pitch?
Yes,
the,
yes,
the
it's
pitch
a
forceps?
crocodile.
What is
Crocodile.
its name? Its name?
Open?
Its name?
Andrea,
What is the
Open?
I think plan B could be going with another endoscope, for example, forward viewing endoscope to remove the foreign body, or going with an endoscope and an over tube, or going with an endoscope and the cap on top of the endoscope. Sometimes when we're doing extreme interventions, we are focusing on our extreme endoscope, which is the US, but it's always good to move a step back.
Well, there is a specific technique that has been described in the past by Alessandro Fugazza, which I was working until 1 year and a half ago, that was explaining how you can repositioning instead of replacing this kind of stent. You can withdraw it outside the patient and try to charge it, to load it inside the channel of your frontal scope. And then you will repositioning. But now, I think Manolo wants to go to the other room. I think that Uzma did a great job, and I think she will manage definitely to finish it quickly. So whenever you want, just give the line to the other room.
I don't know if we are ready to go to
Yes,
number,
we
to
are.
move to number, room
Yes,
number
we are.
2, Ramon? No?
We can just even
We
go
have
with
to cut the
There's no therapeutic scope at all?
Hola, ¿qué tal? ¿Nos oís? ¿Charlie?
Sí, sí, os oímos perfectamente.
Vale.
We are on air now, if you want to say something.
Well, are we now? Hi, hola, hola. So, but I'm very now nervous because this case is a very challenging case.
Can you explain now, Charlie, what's going on here?
Yeah, in English or in Spanish?
In English.
In English, okay. As probably you have heard already, it's a very difficult case, and actually we are all very happy in the room, and as you can see, we don't only have Dr. Agura, there's also Politon and Kunda here to try to help with the case. It's actually a patient that already had a cancer and has a partial gastrectomy, and now and also an Roux-en-Y surgery, and now it seems that he has a previous CT scan that was saying that he has maybe stones in the bile duct, but actually we are completely sure that it's a neoplasia.
Have you not received the presentation of the case? Because they have the images and they have some PowerPoint. Yeah. Okay.
Yes. So now the idea is that we have to drain that bile duct the patient already has an external drainage, but he is with pain and it's not a good solution.
Doctor Warner,
Yes.
sí, tenemos la presentación aquí, nos das 2 minutos y lo hago.
Okay.
Vale.
Hazla.
Because
Okay, the case is a little bit complicated. It's a male, 81 years old, left hepatectomy due to a hydatid cyst. In January 2023, gastric outlet obstruction due to adenocarcinoma in the antrum and cholecystectomy with partial gastrectomy with Roux-en-Y reconstruction, cholecystectomy, choledocotomy, and cholecystectomy extraction. The histology shows was adenocarcinoma. The classification of TMM is a T4A and 3B. In August, he presented cholangitis and liver abscess. PTBD with internal external drainage, internal extreme in the duodenum, feeling defects in probably relation with cholecystectomy. Medically was discharged and PTBD is in place. Blood test is abnormal liver function test and bilirubin 2.5. What should be the next step? Use guided antegrade intervention, endoscopic ultrasound directed transected ERCP, enteroscopy assisted ERCP with sphincterotomy and stone removal, or leave in internal external drain as patient is asymptomatic. Okay. ¿Estamos con vosotros, sala 1?
We're with you in room 1.
Otra vez en directo.
Yes.
Oh. Now in the liver. I don't know if you can see the X-ray screen.
Can you explain us again? We are
Because
watching
very
now the
far, so
fluoroscopic
we
and
cannot,
US view.
because of this HPD.
So we were really struggling also if it was a good idea to make a direct drainage from the remnant stomach, or whether to do an enteroenterostomy, to do a ERCP through the enterostomy. The problem for the direct drainage, as you can see, is that we are very far away from the hepatic duct. So we have seen it clearly in the US that we have a neoplastic mass. So the problem is not stones in the bile duct, really, right?
Yeah, right. Some more injection?
Yes.
Okay.
Are there comments, questions from the audience?
So now we're injecting to see if we can see any loop close to the scope. As you can see, the patient has also ascites that can be...
¿Podéis mejorar el micro de Mariano? Que se oye muy bajo.
Can you hear me now? Okay. Can you hear me now?
Casi no se oye, Mariano.
Yeah, very... So, what should I do? ¿Sabes ahora?
Dr. Ogura, can you explain us what you're thinking about, what your endoscopic approach indicates?
Yes, because very hard to detect the HPD, so we now US position, can you see the intestine? So we do the USGJ, and then we change the duodenoscope. We try to standard ERCP through the GJ.
Okay, we have a very nice view of the fluoroscopic image.
Yeah, I think it's the only option here, no? Because it's clear that the direct hepatic access is not possible, but I don't know if we can have a better window for the intestinal loop.
Like this.
The other room is waiting for, they want to show us how to
Okay, perfect.
how to remove a lamp. So please wait
Yes, yes.
only 4
Yeah,
minutes
yeah.
and we'll come
Yeah.
back.
Okay, perfect.
Pasamos a la otra sala, room 2.
We go over now to room 2. Hola.
Ya os vemos. Please, Dr. Anderloni, Dr. Siddiqui, explain us.
Please explain the new technique to recolocate the
so
axis.
what UTSMA is going to do is to...
We have 4 minutes. Yep.
4 minutes?
Yeah.
So we can have also a coffee.
Yeah.
So what UTSMA is doing is to reposition the previous axios instead of replacing. Reposition means that UTSMA took the 20 millimeters axial out from the patient.
The same axios.
And we preloaded the axios inside the operative channel of an operative gastroscope. So now we have our gastroscope with the metallic lumen-opposing metal stent inside the channel. And we will push it away outside with the
distant
with the
Grasping forceps.
that we have used previously. So we are not opening new devices, just to be clear with Manolo.
So it's a standard gastroscope.
This is
No, we have therapeutic gastroscope.
A therapeutic scope.
Yes.
Correct.
Yeah.
Therapeutic
And here we
make
go.
it easy.
Okay.
So it's very important to check the position, to go
Past it.
on the other side, and to open the first flange.
Okay.
As soon as you will open the first flange, you will come back. Is it okay for you? Okay.
Would you prefer something else? Okay. Which one? Okay. So we're just passing down some forceps just to
Yeah.
push the stent out. But it's a nice way to save your stent because they're not
Yes.
cheap.
And this is also green endoscopy, guys. That now is very important.
Andrea,
Yeah.
so essentially you are following the manufacturer's instructions. They don't say it's non-reusable, but it's repositionable.
Yes, actually, maybe we are not following exactly the manufacturer's instruction just now, but this is for the patients, you know?
And I had another suggestion. Instead of using the endoscopic ultrasound, could you reposition the stent using a therapeutic gastroscope with forward view?
That's what we're using.
This is the therapeutic.
This
Okay,
is
perfect.
such a good idea that we are
We already did it.
exactly doing this.
I see now.
They changed the scope.
We did explain.
Oh, yeah. Quite
All
well.
right, so now I can
It's
feel
okay.
that we're right at the edge.
Okay, it's
on
very
top of the
important
stent.
also to have the X-ray evaluation because it helps you. Very
I
nice.
don't know if we can zoom in a little bit or no.
But look at now endoscopically, the first flange is gently coming out while UTSMA is gently pushing. You will see the first flange opening. And this is the first time for you to see endoscopically.
You clean a little bit the lamps now, and
Okay, now, as Andrea said, we have to move
Yes.
back and do a little dance, but
Yes,
again,
you
we're
are
just
almost
right
there. Very nice.
And
UTSMA.
then we just want to make sure we're on the other side. Similar technique to when we use cold axios for post-surgical strictures or pyloric or duodenal strictures.
Very nice, nice and easy. Under control. UTSMA is always under control, either in EUS, in endoscopy, or X-ray. Okay, I think it's okay.
Yeah.
Very nice.
Okay.
And that's it.
Oops, no picture.
UTSMA.
All right, thank you.
Actually, come back to the first image that you have done. So, very, very nice. The circle is closed.
Thank you very much.
Very easy and very smart. Yes.
Thank you. Team effort. Great team in Valladolid. So thank you for having me.
Thank you, Utsman.
Thank you.
Really enjoyed the case.
We move to the other room. Thank you.
After the guide
Hola, Charlie, Mariano, ya estamos otra vez.
Hello, Charlie, Mariano, we are here again. Hello.
Okay.
So we can see the small bowel on the fluoroscopic view, the US image.
So now the discussion is whether only injection. In that group, if that's a good orientation for the RCPR. So we're going to inject contrast with a 19-gauge needle and maybe put a wire through it and
below?
see like how the
No,
would be for performing the RCPR.
Okay.
And this is the best window.
So please explain us which needle are you using now?
We are now using an Olympus 19-gauge needle.
Are you listening me? Charlie, no sé si nos oís. Sí.
Yeah, you are not hearing us? Mariano was talking.
Okay, we are asking about the needle.
Yes, we are using an Olympus 19-gauge needle. Have you heard Mariano, his explanation before or not? ¿Habéis oído a Mariano lo que está explicando?
Now we cannot.
Hemos oído, ¿eh?
No, pues Mariano, repite.
I don't think we have heard that because you don't have the microphone on properly. That's the problem.
¿Escuchas?
Sí.
You don't hear Mariano, I think. Mariano was saying that we were discussing the best option. Now we have been able to find at this and the problem that we are thinking now is if we can put an Axios there, is we will have a good orientation to make an ERCP afterwards. And to try to confirm the direction of the Axios, now Dr. Agu is going to make a punction with a 19-gauge needle, and we will inject some contrast.
¿Me escucháis ahora?
Hola Mariano, ¿se te oye? Sí, un poco ahora. A ver, habla. No. Se te oye, te he cortado, se te oye mal.
¿Y a ver ahora? ¿Ahora mejor?
Ahora mejor.
Vale, perfecto. Okay, so Charlie just explained now, Dr. Agura, the puncture of the loop, and we're going to check by injecting contrast, like how the.
Que te suban un poco el volumen, Mariano.
Okay. Is it better now?
Yeah.
Okay, thank you. So now we're going to inject contrast through this loop and see how the position would be if we place an Axios. We do the gastroenterostomy. This is the best position we've found after injecting a lot of contrast because there's many factors that might not help much, like ascites and the wall of the stomach is infiltrated in some parts as well because it was positive margins from the surgery, so it's kind of like a challenging case. Now I don't know if you can see the contrast being injected in the loop.
Okay, I think this site may be suitable after USGJ, so we try to deploy the lumen-opposite Merosten at this site. Okay?
Okay.
Okay, do we all agree, yeah?
Do we all agree?
Okay, free hand
Do you agree?
Okay, please insert
Yes, now we have
water.
Okay, now we connected the percutaneous drain to a water pump, and we are trying to inject and to dilate all the loops behind the stomach to get a better approach.
What do you think about the position? Maybe the target is too much perpendicular now?
Yeah, we were talking about that before, but actually now I think it's the moment that we've seen the loop a little bit less perpendicular than in other situations. Actually, now infiltrating some water.
Charlie, hay mucho ruido de fondo y se oye.
There is a lot of noise in the OR. It's hard to understand what you're saying.
You were saying there's a lot of noise.
Yeah.
And they are not hearing us. So I think you were saying before that we have a very perpendicular position, which is not the best to deploy a 20 millimeters axios. But actually, this is the best position that we have found. And now, really injecting more water, really the loop is getting bigger, and it may be a good place to deploy it.
Yes.
Buscapin is a...
Yes, we already put twice. Yeah, we already put twice Buscapin.
Okay.
Sí, por favor. Gracias.
Comment from the audience.
Bueno, ahora tampoco hay tanto movimiento. Okay,
Está bien, ahora está bien.
Está pues. Bueno, las cosas.
¿Alguna pregunta en la sala?
Are there any questions from the audience, please?
Now, 0.35 guide wire through the axis stent, and it's going to be a 20 millimeters axis stent.
I don't know the others in the room, but when we usually do the gastroenterostomy or enteroenterostomy, many times we usually have a preloaded guide wire, but usually we don't advance the guide wire until the axios stent is deployed. Advancing, so you enter the loop, but if you advance the guide wire immediately before deploying the stent, you might move the wall of the loop away, and it's not. It's better to avoid it. So I guess this will be the way we will try to do it.
Any comment from here?
They're now flushing the
I think
axis.
Dr. Munkemuller is thinking about the enteroscope.
I don't know if it is possible to perform a transparietal cholangioscopy in order to be more closer and more easier in front of the papilla. I don't know. Well, in front of the anastomosis.
We have performed the.
They already did it
at the beginning.
Yeah, we already did it in the beginning, and it's very far away.
That's when we saw that it was not possible to drain immediately to perform an integrate procedure because it's very far away because the patient has the right hepatectomy, the left hepatectomy, sorry.
Any comments from the audience? You have here in the first line Dr. Fabri, Dr. Vanella. Any comments about these challenging procedures? No? Una mano a fondo, por favor.
There's a hand at the back, please. We're using the microphone, please.
There are a question from the audience. Okay.
It cannot be a good idea use a balloon through the percutaneous access and inflate it to collapse and then like a EPAS, but through the percutaneous way. Do you understand?
Not very much. Can you explain it?
Yes. If you go with in the percutaneous access,
yeah.
it's enough. It has enough diameter. Go with a balloon and dilate, and then like a EPAS, but with the percutaneous access. I don't know, to have a very big loop with water. Do you? I don't know.
Sí, lo entiendo.
Sí, acceder percutáneamente con un balón, hincharlo y luego rellenar el asa, ¿no? Como un EPAS para tener
un balón cerré.
Un cerré con un agujero antes de, ¿no? Y que le puedas echar. No sé, en esto.
That's a great idea. Actually, here the objective is to get to the papilla or to the anastomosis, and you need to fill the loop with water. either by puncturing endoscopically or also by applying some saline percutaneously, as you mentioned. I think that's a very, very good idea. We were discussing here with Miguel that, of course, EUS is a great option here to create an axis and then let another endoscope go through the axis, but one can go to the anastomosis also percutaneously. There are ultra short cholangioscopes that allow you to do a percutaneous approach. And also, Juan was mentioning that I was thinking of enteroscope, of course. You go with an enteroscope in the balloon from the mouth to the anastomosis, and you could do the work too. So there are many options in this case, so for the audience to know.
No, it's true. Now we are, no, the target has improved. Maybe the, no?
Yeah, we have Dr. Kunda here would like to make a comment
No,
as well.
not so perpendicular now, no?
Yeah, I think that if you appreciate images, you can see we need to be very careful about ascites. You know, we have mobile, small bowel, which is not even distended properly, and obviously all these comments about cholangioscopy and using percutaneous approach are very legitimate, and we may really need to consider it for the safety of this patient who has this disseminated malignancy and advanced recurrent malignancy. And also, we can raise for the discussion or matter of opinion, just use simple radiologically guided antegrade insertion of stent transpapillary. We have external internal drainage in place, so how much we even need cholangioscope for further evaluation?
Contact made in 20 cc and also saline injection, please.
Hey Rusty, it's Ryan. Can you hear me?
Yeah.
Yes, I can hear you.
Are you concerned at all about using that percutaneous drain with this much volume of fluid? Because that drain also has side holes within the liver. And so typically when we use a drain to inflate downstream bowel, we have interventional radiology swap it out to a drainage tube with only side holes on the pigtail to avoid the risk of blowing out the intrahepatics. Is that a concern?
Can you hear me, Ryan?
Yes.
Okay, sorry. I needed to take off the microphone. Obviously, that's excellent comment, and we have to be careful. You know, we don't have any occlusion of bowel below, and we can see that we don't have any backflow of contrast later on. But if there is like any compression or narrowing, I would be certainly concerned. It doesn't entirely answer what your question is, but in this particular case, I'm satisfied how it goes under circumstances. But yes, you have to be careful. For me, it's like not much blowout, but it's more risk of further infection, especially if patient is infected, if there is sepsis, which you can trigger by this overflowing through the PTC.
Can I injection please?
Thank you very much, Dr. Kunda. Do you think that the tip of the needle is inside the bowel? No?
No, the needle is already out. It was only to visualize and verify lumen in among all those ascites which was there. And now what you can see, that's the tip of Axios stent, Axios delivery device. So needle is already out, and we have preloaded guide wire in 20 times 10 millimeter hot Axios luminapose in metal stent.
Yeah, from the audience, Dr. Vanella is suggesting using the get wire.
We have preloaded guide wire, but we do not want to go into this bubble just with the wire. we discuss also this option, and it's due to the mobility and instability of the bowel and the amount of ascites. I do not know if you have appreciated and seen before how much ascites we have around.
No, it's a very difficult case and challenging procedure.
Do you ever use a glucagon or hyoscine to decrease peristalsis, or do you risk using these anti-peristaltic agents that the bowel becomes too floppy?
So what do you think?
I don't know, we are, at least in Spain, I think that we are all using Buscapen. So
Yeah, we use glucagon as well every now and then, and I don't think it affects that much, but we normally use Buscapen, yeah. Unless there's a clear contraindication.
yeah, I think that we only use glucagon when there's a contraindication for Buscapen, really.
What about the line size? Do you prefer here 15 than 20? Because maybe 20 is more risky. You need
Yeah, but
long-
probably the 15 millimeters then will maybe difficult the entrance of the ERCP scope. Sure, you can enter the ERCP scope through the 15 millimeters, but also it's you have more probabilities of dislodgement with a smaller stent.
Yellow? The yellow one.
Yeah.
Okay. Can I go?
Yeah.
Okay.
So the settings are pure cut, 150.
It's 120 and 4.
Okay, you're in.
And then we insert the guide wire.
Yeah.
Oh.
So you are.
Yeah, it's better not to
Introducing the guide.
Okay.
Okay.
Yeah.
We have a nice image of the fluoroscopic view.
Okay, we.
The US image is worse. No, we don't know
Okay.
where is the bowel, but
Now is intestine. We are. Okay. Okay, completely inserted.
Okay, you can see now that he has inserted more the axios.
Yes.
I don't know. Gag wire, no, get a loop, but they looks like it's inside, but.
We are saying that there's a problem that we are seeing the ascites.
Yeah, there's ascites and it's been pulled away, and we're hesitating whether it should be deployed or not in this moment, in this position.
But I think it's very deep now because I think finally it
Could be great now if you could
Yeah, now it looks
installate
better.
a contrast on contrast, but
it's deep, but we have
cannot.
moved the limb away, but maybe for the first
Maybe this is.
lab.
Oh. Really?
Ahora en el fondo.
Just slowly over the wire with a small contraction, and we just slowly advance.
I think that this is now. Go well.
¿Se está preparando paso 2, Charlie? No.
Estamos moviendo la guía porque we are not completely sure that
Yeah.
that the axios is inside enough the.
Yeah, it's deep enough inside the bowel. Here's Paul Giron.
Yes, we're exactly having the discussion. You can see ascites, and so we know that the bowel can float in the ascites. So the introduction of the wire can in some cases provide safety, but it can also push the bowel away. So at this distance, it can be challenging to know how far in to the bowel the Axios is. As you deploy it, it comes back. So the possibility is that the wire can be in the bowel, but you could deploy the Axios outside the bowel. Because what we're looking at on the screen is not the bowel itself, it's probably ascites.
Thank you, Ryan. You are right. Charlie, Mariano, si queréis comentar lo que está diciendo Manolo a Augura.
Well, Manolo is saying that, of course, we know the Axios, when you deploy the distal flange, it's gonna pull back, like it pulls back. It doesn't deploy forward. So we are concerned we're not deep enough, and whenever he deploys the distal flange, it's gonna pull it out from the wall. I don't know your thoughts in the audience.
Yes, so we remove the Axios.
Yeah, we remove Axios, leaving the wire.
Okay. So okay, so now we have decided that we are going to remove the Axios, but we will leave the wire inside. Because probably we are going to put another type of stent.
Okay.
See now that the image is. No,
So
we
you decided to remove
ascites now, and so probably we were.
And leave the guide wire.
Yes, but the problem is that we are not completely sure whether the guide wire is in the bowel. In the X-ray image, it seems it's inside the limb, but it could also be somewhere in the ascites. So.
Un cistotomo de 6 hinchado en el capuchón.
So Manolo, you wanna make a comment of?
So now maybe the image here. Now we can see the wire.
Wire is not bowel.
No, bowel.
And it seems that the wire is inside the limb. Yes.
It's in the limb. You see with contrast, but we're going to put the cystotome and inject more contrast to make sure. Okay?
¿Le podéis acercar un micro a Manolo, si acaso, cuando habla?
So we have the problem of ascites and the problem of the wire pushing the bowel loop a little bit away. So this is not good for Axios, because even if the tip of the Axios catheter was inside the bowel lumen, it is not deep into the bowel lumen. So when we release the distal flange, it's going to come up. It's going to come out. So what we're doing is trying to salvage this with a cystotome over the wire, balloon dilate the access over the wire, and then depending on the resistance, when we have the wire and cystotome, you don't, no, it's in the peritoneum, right?
I think it's inside the bowel. I think it gets inside there. I think it gets inside there.
Okay.
But it's not straight. You know, it's.
Yeah, it's pushing. It's pushing. Yeah.
And it's not forward. It's lateral. I think so. That's.
Now you have 1 centimeter almost to the.
And then we have ascites in between the small bowel and the access site, and the cystotome is pushing away. So at this stage, we are still in time to clip the proximal hole and avoid access, or as he's trying to do to align the bowel, try to make cystotome entry, which is very difficult because, as Paul said, it's floating in the ascites.
Okay.
So it's a tight decision to make now.
The guide wire is now in the intestine, I think so. Yes.
Yeah, the problem is it is floating in ascites, and the
real decision, you can burn here and enter the bowel, but then it may be very difficult to put something into the bowel to pull it back.
Yes, in this situation, we can all device remove, so not so complication is not occur.
So we were saying here that if we now burn to access the limb, probably
so
it will be
we
very
must not
difficult to
into
put
that.
an stent afterwards.
You do think?
Manolo, coméntanos si queréis que pasemos a ponencias o seguimos con vosotros.
So in addition, PTCD plays into the intestine. So I think small bowel is this is the tip of the caster, right? And then this is the bowel out here.
One
intestine.
possibility would be to
But we can.
with the
Okay.
Okay.
Yeah, it's. So, tenemos dos opciones, o abandonar y cerrar.
We have two options, abandon or close, not knowing whether we've been able to perforate the small bowel, or increase our bed, dilate with the cystotome and then with a balloon, and salvage with a stent, with a covered duodenal stent. That's what we are analyzing. It's a difficult decision because the guide wire is clearly in the small bowel. Clearly there is ascites, and clearly an axios is not enough. But what should we do? Should we stop or should we try to salvage? What is your perception, Dr. Ogura, at this stage?
Injured. You only injured, I mean, there was only a burn on the proximal gastrointestinal wall.
Yes, because.
Rogamos utilicen el micro, por favor.
But intestine is escaping into the away like this.
So, Dr. Ogura thinks that because when he pushes the thin.
Vamos a ver. No, el cistotomo, el tema es que tiene que meterse en el intestino delgado, pero si no pasa en la pared del intestino delgado. Bueno, el tema es asegurarse de que la pared del intestino delgado no esté rota, sino que solamente haya sido empujado. Y esto favorecería una decisión conservadora de, digamos, retirarnos y cerrar. Pero el doctor Funda está en desacuerdo. Entonces, ¿tú qué harías? Yo estoy en desacuerdo, respetuosamente. Porque hemos colocado... no nos llega el sonido correctamente. Lamentamos mucho no poder traducirles. Gracias.
And only we didn't push the wires through the needle. We did it with the hot axios, so we have a hole we have a thermic injury on a small bowel. So we cannot cannulate it with a cystotome, but still we have to take in account how big is that thermic injury on a small bowel. And in the presence of ascites, in the presence of this manipulation, and given, I think this is not an injury we can leave behind. That's my personal opinion on this.
What would your approach be? So you disagree, so you think that we burned the small bowel injury, and how would you fix this now? How would you try to fix?
I think now we have wire where we are sure or pretty sure that it's in the lumen of small bowel. We have cystotome which is ready to deploy and use. I would complete it, and we should try to approximate small bowel towards the stomach.
And how would you?
We can do it. We can do it with a stomach, with a balloon. We can approximate it, retract it. We shift to forward viewing scope, and we deploy another Axios with a forward viewing scope, which you also proposed before. I think it's a very smart idea.
So I have made no. I have made this problem before where I push the bowel away. So the Axios, the amount you can push it out is limited by the fact that it's attached to the scope and the length of it. But if you change the scope and use a forward viewing scope, it's possible to push the Axios 10 or 15 centimeters. You can push the Axios completely out and capture the bowel, open the bowel, open the flange inside the bowel, and then pull it back.
I don't know, Joan, if you understood, I may translate into Spanish, because even for the translators, this is going to be a very difficult job.
Sí, no, soy yo bajito.
Yeah, that's the other thing. I'll yell, like Spanish style. Lo que dice el doctor Gayton es que, ya que tenemos la guía,
Dr. Gayton is saying is since the guide wire is already there, we can put it in, we can push it in, we can introduce a cytosome with the echo endoscope, push the guide wire inside the small bowel, exchange the echo endoscope for a gastroscope, a therapeutic gastroscope, and the Axios catheter, the distance that the Axios will be able to travel is much longer. So even if we are limited with the echo endoscope, since the gastroscope is shorter, we can displace the Axios gastroscope much further, and we can be sure that we can get into the loop and bring the bowel towards the stomach.
Muy bien, pues esperamos, Manolo.
Okay, we can wait, Manolo. So we shouldn't give the floor to our speakers. What time should the presentations begin? They should have begun at 1 o'clock. Yeah, you can start with the presentations and then we can come back. You are the chair, Joan, so you are the boss here.
It's lectures. We'll come back when Manolo ask us to come back to the endoscopy room. So the next lecture, can you present Mariano?
Yes. Please welcome to Thomas Hook from Prague, Czech Republic. Can we switch for the...
Would it make sense to just use the internal external percutaneous drain, advance it, connect to gravity, and take a conservative approach? Because the small bowel will be drained through the external drain, and we take a conservative approach.
That would be the most conservative approach, I would think. And we were discussing with Miguel that if we go to our basics, like in ERCP, whenever you are pushing a wire into any of the ducts and you have some resistance and you do more force against that resistance, generally there is going to be some laceration of the intima or other spaces, and we are thinking that here, if we start using more force using the therapeutic gastroscope, there could be success, but great chance of more damage. So as you correctly say, this is a moment to do some step backs and go to plan B, C, D, like Andrea says, like drainage percutaneously would be a good one, because we have high chances that the small bowel with the muscle, that it seals, especially if there is some suction, some vacuum suction on the other side. Yeah, great, very good point. Do you agree, Juan?
Thank you. Yes, of course. So please, Thomas.
Manolo, for his invitation. I feel sort of embarrassed to step in at this moment when we were watching this, I think the most interesting part of the workshop. So please interrupt me anytime they are ready to show us what comes next. So my task is to talk about what can be done to make ERCP safer in the era before LAMS. So it is a relevant question since ERCP is a frequently performed procedure. Roughly 1.5 million cases will be performed a year, and it is the most it is the procedure associated with most adverse events from all standard procedures. This is the list of most common complications. I'll briefly talk about bleeding, very briefly about cholangitis, and then spend the rest of the talk on acute pancreatitis. So with bleeding, I think it's quite straightforward. The incidence of bleeding is roughly 2% of all ERCPs, and 25% of them, it'll be severe bleeding requiring more than 5 transfusions. It will, in most cases, come from sphincterotomy. There are certain risk factors that are known that we should take into consideration when we do ERCP, and of course manage anticoagulation in our patients. There's a few things you can do to reduce bleeding. I think this doesn't really need to be shown. I think there is, everyone uses now blended mode to do sphincterotomy, which is clearly associated with a reduced risk of bleeding. When you have a patient with a small stone and risk factors for bleeding, you can, instead of doing sphincterotomy, do a small balloon papillary dilation, which is clearly associated with a reduced risk of bleeding. There is a debate on for how long you should inflate your balloon to reduce the risk of pancreatitis, which may be increased. When it comes to cholangitis, again, there are some risk factors associated with cholangitis, like mainly incomplete biliary drainage, and therefore in these situations when there are the risk factors present, we give our patients prophylactic antibiotics, and that is in case of incomplete drainage, cholangioscopy, doing ERCP in patients with immunosuppression, and in PSC patients. When it comes to these delayed cholangitis arising from stent occlusion, we generally exchange stents in 3-month intervals. So now we move to acute pancreatitis, which is the most frequent adverse event of ERCP, occurring in between 3 to 8 or 10%, but there are many reports that some of them we'll see later in the talk that report the incidence of pancreatitis up to 20%. Fortunately, most patients will have mild acute pancreatitis, and the mortality rate from this complication is quite low. It's classified the same way as other pancreatitis of other origin. This is the risk factors for acute pancreatitis when it comes to patient-related factors, and some of these factors we call definitive, and some we call likely, and there's also some risk factors associated with the procedure, like difficult cannulation, pancreatic guide wire passage, or pancreatic injection, obviously. So the knowledge of these factors will help us stratify our patients and take certain measures to prevent pancreatitis. Not all the papillas are created equal, as we know, and there is an interesting study was done a few years back by this group, and that is they attempted to stratify patients according to the type of the papilla and in respect to the difficulty of cannulation, and similarly to the difficulty in cannulation, there were differences in the risk of pancreatitis, with the type 2 small papilla having the highest risk of cannulation failure and also pancreatitis. Back to the procedure-related factors, we know that we should use wire when we cannulate to increase our chances to succeed and also to reduce the risk of pancreatitis. But it doesn't mean that using wire is completely safe. Once we enter the pancreatic duct, immediately the risk goes high, and it's highest when we also opacify the duct. There is a definition for difficult cannulation that uses the rule of 5. So if you spend more than 5 minutes or more of 5 attempts of cannulating, or at least one PD cannulation, your cannulation becomes difficult per definition and requires certain measures we'll discuss later, and you should move to more advanced technique, either double wire cannulation or pre-cut to increase your chances of cannulating and decrease the chance of pancreatitis. There is a debate on whether sphincterotomy increases the chance of pancreatitis. We know from, I think, all the available evidence that it does increase the chance of bleeding. You see these two meta-analyses, but in the first one it actually prevented the occurrence of pancreatitis. In the other meta-analysis there was no difference. However, when we look at the recommendation from ESGE, it says that it's now recommended to do sphincterotomy prior to placing stents. There is a debate also whether there's one recent randomized study that actually showed, it's from the Takao Itoi group from Tokyo, that used plastic stents, and they showed that patients with sphincterotomy prior to placing stents had a lower incidence of pancreatitis. And there is a debate whether metal stents increase the chance of pancreatitis, and in this comparison that I'm showing, it was the fully covered stents that were used for benign biliary strictures that increased incidence of pancreatitis compared to plastic stents. Pancreatic stenting is definitely a measure that decreases the rate of pancreatitis significantly. You see this decrease from 25% to 12% in this study. However, no other prophylactic measures were used. However, it should be used only when we easily can access the pancreatic duct, usually inadvertently, because attempts to drain, cannulate the duct just for the stenting itself is associated with an increased risk of pancreatitis. And there are, of course, some disadvantages of using pancreatic stents, like the need of extraction, and some of it may be in the future answered by the use of biodegradable stents. There's a few now data will be shown on the pharmacological prophylaxis. So there have been many randomized trials and many meta-analyses showing that the use of rectal non-steroidal anti-inflammatory drugs is associated with a reduced risk of pancreatitis. In the upper part, we see the risk for all patients and for all pancreatitis, and in the lower part for moderate to severe pancreatitis. So it is useful for the unselected group of patients. This study looked into the use of non-steroidal anti-inflammatory drugs pre-procedure and post-procedure, and as you can see, I don't know if I can point, that the rate was reduced significantly in those receiving the drug before, so this is what is recommended. It should be done rectally. This study was randomized study, looked at using non-steroidal anti-inflammatory drugs orally or intramuscularly, and you see that the benefit is greatest for rectal NSAIDs. Here, there's actually two other drugs discussed in prevention. One is somatostatin, and the other one is nitrate. So for somatostatin, if you use a long, that's the long infusion of somatostatin, there is a benefit of somatostatin. If you use only short infusion of bolus, that's not that obvious, and it does work also in high-risk patients. However, as you can see, the confidence intervals, the benefit is borderline. Similar result for nitrates given sublingually. This meta-analysis shows that there is a benefit for patients in terms of reduction of pancreatitis. We go to the aggressive hydration. In this study, there was a comparison between aggressive hydration protocols and standard hydration, and it seems that it's only the aggressive hydration that patients benefit from. So the confidence interval here and the risk reduction is quite high. It's about 40%. I think the last study on this topic looked at the added benefit of aggressive hydration to the use of NSAIDs, a large randomized study from the Netherlands, showing that actually there was no added benefit of aggressive hydration, which is very cumbersome to administer to our patients to the already given NSAIDs. This is just a look at the real practice. So this was like a survey of ERCPs performed in Italy, done a few years back, that apart from all the other data showed that only 73% of centers actually follow the recommendation and use NSAIDs for patients for prophylaxis. One slide on the future. We spoke about some risk factors for pancreatitis and stratifying our patients according to this risk. There is an increasing use of artificial intelligence to improve this stratification. This is one study showing this compared to the statistical methods that we use. Artificial intelligence actually did better in predicting the risk of pancreatitis based on risk factors. So this is a pre-last slide on the showing the algorithm from the ESG guideline that's available on this topic, recommending that any patient should get a rectal endomethacin or diclofenac prior to ERCP, and if the ERCP goes well and there's no difficult cannulation, then we don't do any further intervention. But if this is difficult cannulation, we move to, and with easy pancreatic stenting, we use pancreatic stenting. And we use the other two means, that means hydration or nitrates only in patients where there is a contraindication for NSAIDs, which is only very few patients. And back to the title that Manolo gave me, and that's the prevention of complications before LAMS. I think that what he wanted to suggest is that we have LAMS now that at least here, as we see for distal malignant stricture. Do we need to stop?
No, 3 minutes.
Okay. So it becomes obvious from this meta-analysis that they covered from this randomized trial, and also from this meta-analysis, and we have now more randomized studies that for distal malignant obstruction, choledochorduodenostomy can do very well. And equally well as ERCP when used as primary drainage. And in one respect it does better, and that is that it has a lower, obviously, risk of acute pancreatitis. So in conclusion, ERCP is a very risky procedure. We should avoid doing doing ERCP in patients where there is no good indication, and look for alternative methods. That's probably the best way to prevent complications. You should know the risk factors for these complications and manage your patients accordingly. In high-risk patients, antibiotics work well. We should improve our technique. I think I skipped that slide showing that patients with less experience have not only a lower chance of cannulating the papilla, but also a greater risk of complications. So becoming better will definitely, technically better, will improve our safety. And we have several pharmacological possibilities to prevent pancreatitis. And we can also consider EUS guided drainage to actually as a safer alternative in terms of pancreatitis than ERCP. Thank you for your attention.
Thank you, Thomas. We have time for a very short question.
Fortunately, we have very good possibilities for avoid some of the most frequent complications. For example, with bleeding, since 15 years ago, we have the fully covered metallic stents, and we can stop more or 99% of the bleeding during the procedure, no? And for this, and it's possible to, if it's a delay bleeding, it's possible to perform a second ERCP and to put a fully covered metallic stent. And in the case of pancreatitis after ERCP, I think several years ago, maybe 8 years ago, was published in gastrointestinal endoscopy a paper comparing lactate Ringer with indomethacin or diclofenac against only one of the products, and the results are fantastic with the combination of both, no? And another important thing, for example, comparing with the somatostatin, is this cost absolutely nothing, because I think the cost maybe, at least in Spain, is 20 euros, not more than the cost of using this combination, no? And I think, if it's not contraindicated, so at least we use always with our patients, no?
Okay, so there's, thank you. There's more studies showing that this is beneficial, the combination. However, the last study, which was the largest one that I showed actually no benefit of the combination. And also you need to remember that it's quite cumbersome. This requires to start before the procedure, then go during the procedure, then do a bolus after the procedure, then continue for 8 hours. So in many centers, I think the ERCP service is done that patients are already at home, 8 hours after the procedure. So there is some technical issues with this, I think.
Thank you very much. So we move to the next lecture.
So we proceed with Dr. Vanella Giuseppe, who is going to provide us with some nice tips and tricks to make gastroenterostomy safer and more efficient in patients with gastric outlet obstruction. Dr. Vanella has at least 30 or 40 publications on the topic, and we look forward.
Yeah, thank you. I'm honored to be here with you. And I'm also very thankful for the title of this presentation, because I strongly believe that to avoid complication of this procedure, actually the goal is to standardize the technique. So I will not go through literature data about use-guided gastroenterostomy versus alternatives, because this is the topic of my friend Michiel, and he will convince you that nowadays this can be the best approach for patients with malignant gastric obstruction. But I just want to highlight that nowadays we do have some prospective data. This is the paper published by our Spanish friends on gastrointestinal endoscopy, showing an amelioration of quality of life with an acceptable safety profile, 15% of adverse events. And this is our recently published single-center experience on 7 use-guided gastroenterostomies, but now we have performed more than 130 in our center, and again showing high technical and clinical success with a contained rate of adverse events below 15%. And we are starting also to see some randomized data on this procedure. Again, high technical and clinical success with an acceptable rate of adverse event below 15%. But usually when these studies are shown in congresses, the comment is, okay, these are the performances of very high volume institutions, but this is not generalizable to other places. So I asked myself what we did during the last years to try to improve safety of this procedure. by looking back to all videos of the procedure and by following all those patients day by day, month by month. So we end up with notes, and day by day our notes end up in some checklists. So I will try to share these tips and tricks with you, going through the steps of what we call the wireless simplified use-guided gastroenterostomy technique, or WEST technique. I was a bit concerned to share these tricks with you because you are such an experienced audience, and this, of course, is not the truth. It's what I am comfortable with, what we are comfortable with in Milan. But then I was a bit less concerned because I came across this abstract at UAG Week presented by Dr. Perez Miranza, showing that in the multicentric Spanish experience, when they tried to see what the technical steps were in their experience, they actually found that there were some established steps which were shared in different centers. And these steps, I am happy to see that are quite the same we also use in Milan. So let's go through this. These are general recommendations taken also from the ESG technical review on this topic. We usually do a single shot of antibiotic, but prolonged antibiotic in case of ascites. Of course, I must admit this is one of the procedures I use fluoroscopy the most. CO2, of course. We can discuss about airways protection, but we do that in Milan, general anesthesia for use-guided gastroenterostomy. You might want to use the saline instead of water due to the risk of hyponatremia. And then, of course, the problem with use-guided gastroenterostomy is that you have a mobile loop, and so given an antiperistaltic, such as scopolamine or glucagon, is good to stabilize the target. And then you should use at least a 15 millimeter electrocautery enhanced lamps, but there are data, retrospective data, showing that clinical success is better with 20 millimeter versus 15 millimeter lamps. Okay, let's go through the steps. So we usually advance an 8.5 French orojejunal tube through the trites, and we actually want our pigtail to be in the first jejunal loop. This is because the trites is usually the only fixed point in the jejunum, and we believe that the pigtail in the very first jejunal loop helps stabilizing the target. What's the aim of the orojejunal tube? Of course, you can inject as much water as you need, and not more. It stabilizes the loop, in our opinion. It can be used for identifying the target loop and also to confirm correct lamps placement, or conversely, to exclude significant enterotomy in case you experience a misdeployment. So this is what we want to see even before starting injection, and you can use, of course, fluoroscopy to try to find a best spot for the procedure. And then after identifying the orojejunal tube, we can start injection. So what we want to see is some fluid turbulence inside the loop, which is a sign, of course, of proximity to the orojejunal tube. And then, of course, we need to identify a target. So the best position, of course, is a loop which has an oblique course parallel to the direction of the operative channel of the endoscope. And then we should take some measurement. But the problem is not the diameter of the loop itself, but the operative space you have for advancing your lamps. So this should be at least 3 centimeters in the direction of the operative channel. And another very important measurement is the distance between the tip of the catheter and the lumen, which should be less than 5 millimeters. Of course, given all those points, it's clear and it's obvious now that this is not the best loop for one gastrojejunostomy, because you have a transverse direction, not enough dilation, and an excessive gastrojejunal distance. There can be even another loop between the stomach and the jejunum here. Then you can use fluoroscopy even to adjust the direction, because if you are in the trites, and clockwise rotation can point towards the jejunum, whereas anti-clockwise rotation points towards the duodenum usually. And then we are ready for advancing our lamps, a freehand lamps placement. And what we want to see here is the so-called boiling water effect, blush effect. We can call it whatever we want, but the important point is that we should see some sign of perturbation of the fluid inside the loop, and this is the sign of penetration of the small intestine. Then usually we lose our acoustic coupling with the tip of the catheter, but the important thing when advancing the catheter is that the jejunal loop stays there and doesn't push, away from the stomach. And then we do our LAMS release. So the release of the distal flange inside the jejunum, as in any other indication. And then what we want to see upon retraction of the flange is that the jejunal walls are surrounding the LAMS and the catheter tip is inside the fluid-filled loop. And then we go, of course, with intrachannel proximal flange release, and we push outside the flange inside the stomach. At this point, okay, we can see some blue coming because we use indigo carmine with our injection. But at this point, if you're not sure you are in, you can use contrast in your orojejunal tube. And if you see contrast coming inside the LAMS, you are in, and the LAMS is correctly placed. Then we usually go for dilation, but I will not go through this because I know this is a controversial point, but we do, in every case in Milan, a dilation up to 18 millimeter of our 20 millimeter LAMS. And the future, I don't know, but probably having something to fix even better the loop, but which goes through the channel, probably can help in reducing the complexity of this procedure. And then we have the dark side of the technique, of course. We have contraindications because in case you have a massive linitis plastica with a thickening of more than 2 centimeters of the gastric wall, of course, this is not a good indication for, this is a contraindication for iosgastric gastroenterostomy or massive ascites with loop swimming inside ascites or massive peritoneal carcinomatosis. Of course, these are no-go for iosgastric gastroenterostomy. And then we have adverse events. Bleeding can be frequent, but is usually self-limiting. You might want to do some small epinephrine injections sometimes, but it's not a very serious adverse event usually. The most serious adverse event is, of course, misdeployment, so I will go a bit through these. This is the largest available experience on this event, around 10% rate of misdeployment in this retrospective series. But surgery was needed just in 10% of these 10% cases, and it's also our experience that we required surgery in 1–2% of our experience. And usually misdeployment, of course, happen in the 31st phase of the learning curve. I just want you to show you this video. This was, of course, not a very nice target loop. But then when we advanced the LAMS, we saw some boiling effect. So we actually thought we were inside the jejunum. But then, upon LAMS release, we realized that we were not in. There were not typical signs that we were in. And also, upon LAMS release, there was no blue coming in the stomach. And as you can see in a moment, when we injected contrast through our orojejunal tube, we could not see contrast coming through the LAMS. So we realized that we were not inside the loop. So what we decided to do in this case was simply to remove the LAMS and to start again. Here you can see also the peritoneum through the LAMS. But that's an important point because having the orojejunal tube there actually helped us a lot because enterotomy or not, there was not a significant leak from the jejunum. Therefore, we were quite comfortable in starting back the procedure. So we found a better access point, even if the loop was not so fine dilated. But the second go was, as you can see, inside the loop. And then upon injection of the orogenital tube, you can see now contrast coming through the lumps, and so the patient was, had no adverse events. So we should also interpret the sign of correct or incorrect lumps placement. This is one case which was performed during our Euro-US course in Milan last year, which was rescued through nodes. I will not go through these because there will be a lecture on this technique. However, in this case, the loop was grasped through a double-channel scope, and a precut was used for lumps in lumps placement. But this is another case of a type 3 misdeployment. So you could see a correct use-guided gastroenterostomy, but then there was a complete intraperitoneal dislodgement of the lumps, and our colleagues from Palermo, from HISMET group, simply dilated the tract and went for a peritoneoscopy and retrieval of the migrated lumps. And finally, this is the type 4 misdeployment. So in those cases, the procedure was started by a fellow who was started injecting a lot of fluid, and then upon lumps release, we realized that we were not inside the correct target. So will see in a moment, upon release of the proximal flange in the stomach, we could not see that nice blue coming in the stomach, but some fecal material. And so in this case, of course, injection of contrast through the orogenital tube could not be aspirated into the stomach. And upon injection through the lumps, you will see now clearly depicted the colon by contrast. Yeah, that's it. But the important point here is that, as you can see now, there is some blue in the colon. So from this case, what we learned is not to over-inject and to control injection of the jejunum, because this is one important point to identify, not to get lost in your bowel. To sum up...
2 minutes, Giuseppe.
Yeah?
2 minutes.
Yeah, I'm just concluding. To sum up, type 1 misdeployment or even type 2 misdeployment, when you can confirm there is no enterotomy, you can simply remove the lumps and go for a redo use-guided gastroenterostomy. In case of type 3, nodes or surgery. In case of type 4, you can try to perform a correct use-guided gastroenterostomy and then go back in 2 or 4 weeks for delayed gastrocolonic fistula closure. An important thing is that you should have some friends in the hospital, some interventional radiologist and surgeon behind you, but probably it's better that they are close to you when deciding multidisciplinary management of these conditions and, hospital plans for misfortune. So in conclusion, ES-guided gastroenterostomy is safe and effective in experienced hands. Training in high-volume institutions is fundamental, and we should aim for standardization and reproducibility of this technique. The availability of a jejunal catheter makes a difference to avoid misfortunes and to solve them, and when and how to inject is part of the game, and it's fundamental to read endosonographic sign of correct or incorrect lumps placement. However, misdeployment is not equal to failure. In most cases, restarting the procedure is sufficient, and we should not forget that the surgeon is not an enemy, and a conversion to surgical bypass is not a failure, at least for the patient. So thank you for your attention.
Thank you very much. Very nice videos. We have time for a short comment or short question only. If not, what do you think about the combination of ascites and gastroenterostomosis? In the presence of ascites, what's your opinion? Paracentesis, previous paracentesis, sometimes? Or?
Yeah, in our experience also with Leuven and Amsterdam, actually we do have ascites in 20% of our patients, but the important point is that, of course, it is not a massive ascites, making that procedure cumbersome. And if we aim to the more fixed point around the triads, this is feasible, but we should also exclude that ascites is something, not related to a massive extension of the disease with massive peritoneal carcinomatosis, because, of course, for this patient, this procedure is not beneficial. Probably short survival would make enteral SEMS a better option for those patients.
Okay, thank you.
Thank you.
We must move to the next lecture.
Okay. It's a pleasure for me to introduce our friend Alberto Baptista from Venezuela, who is talking to talk about nodes endoscopy, when does it make sense as an AE management strategy.
Okay, after this lecture, we'll come back to the endoscopy room because they wanted to explain us a case, and then we'll go to the lunch.
Well, it's a real pleasure to be here, learning from friends in this fantastic course. So thank you very much for teaching us. When does it make sense, nodes to manage adverse events? Well, we're gonna talk in these adverse events specifically for GJ anastomosis, gallbladder drainage, and gastrohepatic access. Gastrohepatic anastomosis, and the age is also a procedure that should be included here. But when you need nodes, it's because something bad happened. So, oh, I'm sorry.
Parece el cable, ¿no? Parece el cable. Que salió de boca.
Lo probamos.
Sí, no, yo creo que no.
Okay. Thank you. So we're going to talk specifically about these topics, but something bad happened when you need to do nodes after one of these procedures, something that you wouldn't expect, or maybe that you was expecting, but you didn't realize in the moment. So what's next? Let's do nodes as soon as possible and as many times as possible. So we're talking about misdeployment and about displacement. Displacement is what happened this morning in the case of Uzma. That is a lamp that was perfectly placed, but when you are going to do reintervention, you move your stent. So it depends on how far or how long had been the stent in place, you're going to have some complications or not. There is not much data available about nodes in these cases, but I found this publication to be very useful and very important. Carlo Fabri and Andrea are included in this multi-center study. It's a retrospective multi-center. They propose a classification of stent misdeployment into 4 types that we already saw, and they separated and studied the severity of the complications. There were 467 cases, and 46 patients had stent misdeployment. It's very, very important that most of these events occurred during the first 13 cases of each operator. So keep in mind, you're going to pay a price for the learning curve. Most of the patients had a malignant gastric outlet obstruction, and the most common etiology was pancreatic cancer. Already Dr. Vanella showed this classification that is published in this study. Type 1, the proximal flare is in place, but no the distal, no the enterotomy, no hearting, or no, they didn't heart the small bowel. Type 2, proximal flare is in place, but you have an enterotomy. Type 3, you have distal flare in place, but not in the proximal flare, so there is a hole in the stomach. And type 4, as you saw, is a communication between stomach and colon. The type 1, fortunately, is the most common because maybe it's easier to resolve. This publication showed 4 patients that required intensive care unit and stayed a median of 2.5 days. Remember, what is going to kill these patients is the infection, the peritonitis. So it's very, very paramount to identify the complications immediately. If you solve them immediately, it will go as a mild complication. Okay. The severity was classified according to this publication, gastrointestinal endoscopy in 2010. Most of the events were mild, as we saw, but we had fatality. So we had mortality with these complications. So it's a very important issue. You should keep in mind that this is not an easy procedure, and you have to be warning about this. Here you can see the notes as a rescue in these complications, only 3 cases. So there's no much data about notes to solve these complications, but we do it every day. So I'm going to give you some advices, not evidence-based, but suffering-based, as everyone who has done notes to solve these complications. So to the question when it does make sense to use it as a strategy, we still don't know. We need more data. We have some publications, but so our case reports. That's what we do every day, but at case reports still. Let's see some images. This is a type 3 gastrointestinal anastomosis deployment. Here you can see the axis in the distal part, in the small bowel. These patients have a nice initial placement, but has started vomiting, and after 24 hours, he came with abdominal pain and peritonitis. So what we do, we suction all the fluids, but we have to drain the abdomen. So we do an endoscopic percutaneous peritoneostomy, the same way you do a gastrostomy, okay? You inflate the abdominal wall, you make a digital puncture. In this case, we're dilating this little tract, grasp it with a snare. The snare went out, and then once the snare out, we can hold a drainage tube. It would be a Jackson Pratt or any kind of drainage you want. So you can place this drain wherever you want. In this case, we did 2 drainage tubes, one to the pelvic area and one very close to the orifice of the perforation, of the free perforation. And then we decided to close. We did a rescue with a lamb in lambs. This is another case. This is a type 2 misdeployment also. Diagnosed late because the patient came late after 2 days. Same way, we did an access with the forceps, with the surgical forceps to the abdominal wall. Took the snare, and the snare went out, and then in back with the drain, so could place the drain whatever. There we found the orifice in the distal, in the small bowel. I'm happy, Andrea, you showed what Alejandro Fugasa and you are doing, because sometimes you can make the rescue inside the peritoneum, placing the lamps inside the endoscope. It's very nice research, okay? And you push it with a biopsy forceps. In this case, you can use a 3.2 endoscope channel. Lamps of 15 millimeters fits in, 2.8 fits 10 millimeter in axios, and the largest one, the 3.8, fits the 20 millimeter. So keep in mind, this is a very, very nice research, as we said. It's not tricky to place the stent inside the channel of the scopes. Okay, you just have to see well, to use your glasses, especially all the old guys like us. And then you can, as Usma did it this morning very nicely, you can push it under direct vision. Again, the axios, even the axios in axios, or removing the initial one and putting the other one. This is a video from Dr. Abdelhaif from Munich, Germany. This is also a perforation and mid-dislodgement. He did the same. He suctioned all the thing. There you see the axios in the small bowel. In this case, with a two-channel endoscope inside the peritoneum, because it has not a nice angle, they rescue this with a long esophageal stent. That stents from Taiwan that are TTS, the only TTS esophageal stents, are very useful. So anytime you are doing a gastroduodenal anastomosis or one of these drainages, you keep in mind to have an esophageal TTS stent, because sometimes you will need it for rescue. Okay, let's go ahead. What about gallbladder? The first gallbladder drainage were a nightmare for us, but we unfortunately had to go inside the peritoneal cavity to make some rescue, okay? Here you see, no bile coming, but a lot of bile now coming from the stomach to the peritoneal cavity, but we have a burning site in the wall of the gallbladder. So what we decided to do is what Dr. Vanellos showed before with the small bowel, but with the gallbladder, advancing a new lamps, hot lamps. This hot lamps was from Microtech, and you can save the cholecystogastrectomy with the lamp stent. What about the rescue notes in hepatic gastroanastomosis? This is a video from Dr. Back from Norway. The same thing. Everything was okay, but during deployment, something bad occurred. So the stent was not in the gastric size, just inside the liver. So what he decided to do is gain access, of course, not without price, as you will see. Okay, so you have to be prepared to do everything, to do coagulation, to use any other stent, you have to have all the resources that you could imagine, keep them with you, and also the surgeon, of course. In this case, fortunately, he could hold the stent, the biliary stent inside the peritoneal cavity and recover it. And then he placed a double pigtail stent for this saving maneuver. And finally, at type 4, a misdeployment of a of a gallbladder drainage, if you can call it type 4. Okay, this is a patient with a previous gastrectomy for cancer some years ago, and a disease of gallbladder gas stones, when a lot of pain. So we did this case with Carlos Robles. We found the gallbladder in the small bowel, so we decided to drain it. Okay, he's a very old man with a lot of cardiac complications. 4 weeks later, we came into the gallbladder to remove all the remnant stones, and we decided to remove the axios. When we went inside again, there is no small bowel, there is no gallbladder, it's the colon. So we have small bowel, colon, gallbladder. These patients had been well for 4 weeks, but what we decided to do was closing the posterior wall of the colon with an Apollo suture, and then the other side with Apollo suture, and this patient did it well. But that's what I was telling you. If you are dedicated to this, you have to have all the resources available, because you maybe will use all of them in just one case, or one of them in some cases. Okay, so in conclusion, does it make sense to use notes for management of adverse events in these cases? Much better if you don't need it, because you're not going to suffer. Keep in mind the learning curve. It's very frequent that most of the complications occur during the learning curve. Remember to follow the rules, Dr. Vanellos' checklist, which is paramount. Okay, if you do things step by step and don't forget any step, you will succeed most of the times. And don't take anything for granted. I mean, if you saw blue coming from the other side, it's not necessarily a success. You're not in the peritoneum, but you could be in the colon, for example. So you have to double check if you're in the right place before going out. So you use it anytime it's needed. Don't forget peritoneal drainage, especially if you diagnose these complications after 6 hours of TENS plating, because this patient is developing a peritonitis and could go with a sepsis. Remember to close the defect anytime it is possible to close the defect, and don't forget the original indication. So don't forget the surgeon. Keep good friendship with surgeon, as Dr. Vanella said before. He is always expecting you to fail, because they want to have surgery with these patients, but he is your friend, he is not your enemy. I fully agree. Thank you very much.
Thank you very much. Very impressive videos. Any questions from the audience?
Basic question. So very simple question. So you basically go through the hole you created with the perforation you created and dilate it, and then put a scope down?
If it's needed, yes. Dilate it and go inside.
And if you don't see it, do you make a hole?
No, you always see it.
Okay.
I think it's always possible to see. If you don't see it initially, just increase the flow of the CO2 and put a cap at the tip of the scope and look for it. You will find it.
¿Más comentarios? Comments?
Seguimos.
Are they ready in the room? No, espera, Berto. Maybe. One question, Alberto. Sometimes we might be aware that the surgery is not late for the patient. It's difficult because maybe we are trying to do the best, trying to avoid the surgery, but maybe the patient after 2 days, 24 hours is late for the patient. So
Yes. If you can drain that patient is not going to die. So if you are sure there is liquid, that there's content in the peritoneal cavity, if you cannot drain it, go for surgery. Okay, don't take it for granted. That's the point, because sepsis is going to develop very fast. These are...
By here, what you can see is that if you have a Whipple's operation, it can be with the pylorus still in place or without pylorus. And if there is pylorus, you will be able to reach the hepaticojejunostomy, likely using a colonoscope and sometimes even with a duodenoscope. So very important to know what happened to the patients. But you can also have patients who had Roux-en-Y hepaticojejunostomy, but not one hepaticojejunostomy, but 2 hepaticojejunostomies, like you can see in this case. And the other important aspect is about the position of the papilla. So the papilla in patients with Roux-en-Y gastric bypass or B2 will be practically inverted, and the cannulation will be different because the papilla is upside down. So if you're using a duodenoscope in these patients, of course, that will facilitate also the targeting of the orifice and sending the tip of the catheter or the wire towards the correct direction. That's why I must acknowledge already now that, for example, using H in patients who have Roux-en-Y gastric bypass makes sense because it will allow you to use your duodenoscope. Nonetheless, we are talking about many different anatomies, and in endoscopy there are many ways to skin the cat. And one of them is using device-assisted enteroscopy. I think any advanced endoscopy unit should have some sort of enteroscope or overtube assisted device. Here we show you the different ones. And one argument that I find during all the congresses is that, well, there are no devices for device-assisted enteroscopy, and I counter Act with showing these slides, one a little older from 2009, which you can take a picture and see that there are lots of companies that create extra long catheters, devices, wires, snares, cytology, brushers, pushers, injections, etc. And this has been updated with a ASGE sort of little guideline about what accessories can be used for extra long enteroscopes. But one beautiful thing about hepaticojejunostomy is that you can really get into it using forward viewing endoscopes like the enteroscope. As you can see with these examples where we're facing it directly and you can look at it. Now I'll present you some specific cases. Specifically, this is a patient with a Roux-en-Y hepaticojejunostomy, had a liver transplant for primary sclerosing cholangitis. That's why the Roux-en-Y was mandatory. And this patient had actually a short stenosis. So the argument here is to do something in phase, looking at the hepaticojejunostomy with your own eyes and deciding what to do. Yes, this is a short stenosis, this is a tight stenosis, and this is one that will respond to therapy with a balloon. And going directly to it with an enteroscope, for example, is a very good idea. Here we have a classification that we proposed several years ago about some hepaticojejunostomies, and you can see that there can be large orifices, small orifices, short stenosis, longer stenosis, or complicated strictures that have strictures inside on both branches of the bile duct. But this patient actually had a stenosis that was tiny and short, and you can see here that during device-assisted enteroscopy, you can go directly to the area and dilate and see what is happening during the dilation. Of course, you can do a percutaneous dilation or an endoscopic ultrasound-guided transhepatic dilation, but you will never see what happened to the dilation if you do it the other ways. So in this case, this is a pro of doing device-assisted enteroscopy dilation because you go, see, cannulate, and do your tests. Another pro of using, for example, device-assisted enteroscopy is using plastic stents. Actually, metal stents are beautiful, but plastic stents are practical. You can exchange, you can see if the stenosis will respond, and although there is an argument that you cannot use 10 French stents with these devices, you can use, for example, here 7 French stents or 5 French stents. And here we are placing a stent pushing with the other stents. Here is the wire, so we place the first stent and now take the wire out and place the next stent right next to it. So this is the 2 stents, one after the other technique. But we have encountered patients who need many stents. And of course, you cannot take a 10 or 11 French stent through the enteroscope. So we have used the following trick. This patient had a tight hepaticojejunostomy, but as you can see, the scope was very twisted, as can happen in many of these occasions. And if the scope is twisted, advancing a 7 French stent can be quite complicated. And what we decided to do to dilate this hepaticojejunostomy after it was balloon dilated, and we wanted to keep it open for it to remodel about the stents, is to place several small pancreatic stents into the bile duct. So we used 5 small 5 French stents. And even though they theoretically occlude really quick, as you have 5, they can remain open for many months to come. So this was a great solution in this case. Here we have a nice example of Japan, published in Endoscopy, about doing directed stone extraction using Dormia basket in a patient with Roux-en-Y gastric bypass. As mentioned before, in these situations, if we get to the papilla and we can do work, it will be fine. But this doesn't happen as often as I will show you with some studies. Here you can see that doing forward viewing endoscopy and performing a balloon angioplasty of the papilla and then extracting the stones was completely feasible. With this case, I also want to show you that if you cannot advance a 30 French 10 millimeter self-expanding metal stent through a colonoscope or through an enteroscope, because the channel is too tiny to advance those stents, then you can use the following trick. So this patient had a tight stenosis, Roux-en-Y, hepatojejunostomy, he had a tight stricture, and it was possible to arrive to the stricture, of course, with double balloon ERCP, but advancing the stent through the endoscope was not possible. Therefore, what we did in this case is we cannulated the common bile duct with wires. The wire was left inside of the bile duct and the entire enteroscope was removed while the overtube remained in place, communicating the outside world to the stricture. And of course, inside of the overtube, there was the wire that allowed us then to place a stent over the wire, remaining stable in the overtube that worked as a giant working channel. So what I just said in words, I have it here in video, so you understand what I'm meaning. So after dilation, there was a little rupture there. That's why we wanted to place a fully covered self-expanding metal stent. The endoscope was removed, the wire was left in place, the overtube is inside too. And now we're going to do an incision right next to the overtube so that we can advance the metal stent. Because if we would have advanced the metal stent from the outer part of the overtube, the proximal part, then the metal stent is not long enough. That's why we are doing an extra little cut there using the toolbox. So you see how long the overtube is, and now the stent is the wire is being held so that the stent, in this case a 40 millimeter 10 self-expanding metal stent, could be advanced into this, what I call a giant working channel. Fluoroscopically, one can see how the stent goes into the right direction. It's deployed in the dilated bile duct across the hepaticojejunostomy, and you can also endoscopically then, using a smaller endoscope or the same one, go back in and take a look at your stent and the hepaticojejunostomy. Very importantly, and combining with the lecture, as I mentioned before, from Dr. Chahal, is that when we are doing ERCP in altered anatomy, if there is hepaticojejunostomy, the success of device-assisted enteroscopy is much higher than if the papilla is intact, such as in Roux-en-Y gastric bypass. Therefore, there are other options. For example, using lap-assisted ERCP, laparoscopy-assisted ERCP, placing a big overtube into the stomach and then going through that overtube inside of the stomach and then going to the papilla. So percutaneously advancing your duodenoscope, which is quite nice for the endoscopist and for the patient as well, because it lasts less, but it's an operation. And we have had patients where we did this procedure, and unfortunately there was bleeding after the sphincterotomy, and we had to go back, but then you need to do another laparoscopy-assisted ERCP. Now there are studies showing that doing EUS guidance is probably better than doing device-assisted ERCP in patients who have Roux-en-Y gastric bypass. And finally, I want to show you what we were commenting before with Dr. Munoz about doing a rendezvous. Sometimes it's easier to get to the stenosis percutaneously, but in this case we did an ERCP, DBE, looked at the stricture, but we couldn't do any therapeutics. Therefore, we started to place all the devices percutaneously, so advance the wire and then advance the balloon to dilate, like dilated the hepaticojejunostomy, removed the drains, and from the outside ended up placing the plastic stents. But we have also placed stents into the bile duct from outside while having an endoscopic view of what is going on. So here we're dilating, but this is the balloon coming from the outside, so playing radiologist. And now how the stents are being placed after the percutaneous dilation.
One minute, possible.
Ya, terminamos ahorita. So, in summary, in finishing the lecture, the pros of device-assisted enteroscopy is the focused evaluation of your target, your papilla, your hepatic oxygenostomy. The patient will have physiological drainage of bile. The cons, it's tedious, it takes hours, and some accessories may not always be available. And lab-assisted ERCP, you can use duodenoscope, but there will be physiological drainage of bile. But the cons, it implies an operation, and if there are complications, you need to operate the patient again. Thank you.
Okay, time for a short, very short question because we are hungry.
Me too.
If not, we move, and later Manolo, don't worry about the cases because Manolo will come back and will explain us how, what happened with the patient and the other cases. So, any comments? No? So go for lunch.
Thank you.
Thank you.
Thank you. Thank you very much.
¿Cuál?
Was just going to cover a little bit of interventional pancreaticobiliary endoscopy. It's a lot of show and tell of some videos. And I'll just start by saying, you know, I think when we talk about GI for an advanced endoscopist, that, you know, takes center stage, and then all the other areas in GI are kind of in our periphery. But we do touch on a lot of those different areas and can offer procedural solutions to a lot of diseases. And for pancreaticobiliary endoscopy, you know, obviously our procedures center on ERCP, where we deal with the bile duct and the pancreas. Most of the time we're stenting, removing stones, sometimes we're ablating tumors. We can do cholangiopancreatoscopy, ampulectomies. And I will say in the last decade, there probably hasn't been as much innovation on the ERCP side as there has been on EUS, and obviously thanks to Boston for helping support this session. There's a lot of, I'll talk a lot about Axios and lumen-opposing metal stents, which have improved our capabilities with drainage. We can also access the pancreas and bile duct, do luminal interventions, and now ablation. So just with ERCP, you know, this was a case where a gentleman was told you have bile duct cancer at the hilum in the biliary tree, but then, you know, if you do cholangioscopy, you can see he actually just had a very large stone. So it was nice to give him some good news. It was a little bit bad news for me because the stone is huge and the distal duct is small, but, you know, we can use, oh, I don't have the EHL, but we can use electrohydraulic lithotripsy to fragment those stones. If patients have large ampullary polyps that are hopefully benign, especially we see a lot of polyposis syndromes in our institution, we can do ERCP and successfully remove these polyps and prevent the patient from having to go for an invasive Whipple surgery in most cases. And you'll see here, we're going to take off the polyp. And then we always worry about inducing pancreatitis. So afterwards, we always put in a pancreatic duct stent. And then we can just bring this patient back for surveillance. Most of the time when we're dealing with malignancies, especially pancreatic tumors, we see a lot of malignant biliary obstruction in our practice. And so nowadays, our standard of care is to put in a metal or a self-expandable metal stent. I don't know if this has a pointer. Does this have a pointer? Oh, it's all right. Oh. Okay. Pretty standard procedure for us. Although it's funny because we had Mike Mahoney from Boston Scientific come and spend some time in our unit, the CEO of Boston Scientific, And he was so impressed that we can put in a metal stent in the bile duct for decompression. But for us, you know, we do it every day. And so now, I think it's kind of dark. You're going to see the stent being deployed. And then we can also ablate tumors. In our practice for hilar cholangiocarcinomas, we use photodynamic therapy. The patient's given a sensitizing agent, Photofrin IV, 2 days before the procedure, and then you activate the drug with a low-powered laser that you can put through a cholangioscope. And then also there is a radiofrequency ablation probe. I tend to use this more for dealing with metal stent occlusion when you have some tissue ingrowth. The difference between the two ablation techniques, the PDT is a lot of setup. You have to know how to use a laser and the drug beforehand. But with the ablation catheter, it just connects to our standard Irby generators, goes over a guide wire. But you do have to make contact with the tissue to get good ablation. So then when we talk about therapeutic EUS, you know, now we can drain basically any fluid collection that's accessible by our scopes, whether it's in the chest, the liver, gallbladder, bile duct, pancreas, and even down in the pelvis. But everything kind of started with us draining pancreatic collections. And over the last, you know, couple decades actually, our techniques have evolved over time. In the beginning, we didn't have EUS, or actually I've always had it, but for those of you who might be older who did it, you just had to go blindly with a scope, hopefully saw a bulge, and then cut into it and hope you were in the right spot. And then once you had EUS guidance, you were able to avoid blood vessels. You could target collections that did not have an obvious bulge on the lumen side. And then now we have EUS guided cautery directed access, which lets us get into the collections pretty easily. So not only has our technique changed, but also the tools. We tried to use a lot of ERCP tools, plastic pigtail stents, and then metal biliary stents, again used at ERCP, and only, you know, in the last, it's been almost a decade now, we have had lumen opposing metal stents. And these are specifically for draining these collections because, again, the other stents were too long. You had no lumen apposition, risk of separation from the GI tract wall and the collection. The stents could migrate. You had to do multiple steps where you had to dilate, use X-ray, and every time you exchange a device, there's a chance you could have a complication, and it takes more time. But with the lumen opposing metal stents, they have a very short length and big flanges, so that it's great for bringing the collection wall and the GI tract wall together. We have all different sizes, actually, you know, up to 20 millimeters. So if you needed to, say with necrosis, you can put your scope in and debride very easily. It's super easy to deploy. I feel bad now, a lot of our trainees are only used to deploying these lumen opposing metal stents and aren't as familiar with the more complicated double pigtail placement, which sometimes we still have to do. But it's very easy to deploy and lower rates of migration. And this was, I think, the first Axios case I ever did with the cautery enhanced device back in 2014. Initially, I used to use a guide wire, but now we do most of these freehand. So you saw a puncture with a needle, a wire, and then the Axios going in to the, into the collection. And we'll kind of rinse and repeat on a lot of different drainage procedures, but you see the distal flange opening up, and then we'll pull back. And initially, we would look at it endoscopically on the proximal flange, but now we just deploy everything under EUS guidance. You don't need fluoroscopy, and you can just put it inside the EUS scope. So say if you had an emergency case in the ICU, you could do it bedside even. Some complications with LAMS that have been reported, you can get delayed bleeding, tissue overgrowth like you see in this picture, especially in the antrum, which is also the location where stents can get occluded by food. And obviously, you know, these are very short length stents, either 8 or 10 millimeters, so there is a chance you can misdeploy, and depending on what you're trying to go into, patients can get peritonitis and perforation. So for pancreaticobiliary access, You know, oftentimes we have a lot of patients who have altered surgical anatomy, Whipple's, bypasses, or they have malignancy that's blocking our path to the ampulla for biliary drainage, or say you just fail at ERCP cannulation. This is where EUS guided techniques can help get a successful procedure. And you know, the main things are you do need to have expertise in EUS and ERCP. We talked about that earlier. You really need good cross-sectional imaging ahead of time, and you do need time. These procedures, you know, when we show them in talks are always edited down to 1 minute, but oftentimes take a lot longer, and you really need to have good communication with whoever's gonna back you up if you don't succeed, and also just with your team, so you can manage complications. And Manolo published this diagram, again, it's been about a decade, but I think it's really nice just to show you all the different ways that you can use EUS guidance to gain access to the bile duct and the pancreas duct. The ideal for me is always trying to do a rendezvous where you can still put your stents or do your maneuvers through the papilla without having to create a transmural fistula tract. But you do have those options if you need, if rendezvous is unsuccessful and you still need to get access. And this is an example of a biliary rendezvous. The patient had polyposis syndrome, FAP, and had a big ampullary mass and jaundice, and I couldn't identify the biliary orifice. But under EUS guidance, you can see a very dilated bile duct, and we puncture it with a 19-gauge needle. And then under fluoroscopy, you can pass a guide wire. The success of any of your rendezvous procedures depends on kind of the angle of the scope when you do that first injection, and that usually you can tell if you're going to succeed or fail depending on the direction of that. So in this case, we were angled down towards the papilla, and I was able to get a cholangiogram, show the distal bile duct stricture, and get the wire into the small bowel, loop it up, come out with the EUS scope, and then you can either put the wire, you know, through your ERCP scope, or sometimes I'll just go next to it and cannulate, and then you can still perform your biliary stent placement like you normally would. This is an example of just direct transmural drainage through the GI tract wall into a dilated bile duct, and then you'll see a lumen-opposing metal stent being placed. In the past, we only had, the smallest stents we had in the US were 10 millimeters, so the bile duct had to be very huge. Now we do have 6 and 8 millimeter stents. This is an example of a patient, he had severe chronic pancreatitis, recurrent acute pancreatitis, and I never could cannulate through the papilla, so we ended up going EUS guided through the stomach, where you see a puncture with a 19-gauge needle, injection to get a pancreatogram, and there's a very tight stricture in the head of the pancreas, and I couldn't get a wire across that, so then I went the opposite direction with the wire towards the tail, and this is where the dilation techniques come into play. In the past, we only had needle knives in the US, but now we have cystotomes that can help you get into the duct. And then you do a small caliber dilation, and then we place a long single pigtail stent. Obviously, whenever you're making a new tract, though, risk for peritonitis, pancreatitis. And you'll see the stent being deployed. I'll talk a little bit more on Friday, but we can skip this, but EUS gallbladder drainage is another technique. In the US, Axios just got FDA approval for this indication, so it's gaining in popularity. But the things when we're trying to do, especially rendezvous, we don't have really good tools for rotating the wires. I told you everything's dependent on how the scope is angled, and we don't have one device that can do everything: puncture, rotate the wire, dilate, and deploy, especially if we're not using a lumen-opposing metal stent. And then if you're going, say, through the pancreas, it would be nice to have something that makes it easy to traverse the tissue to get into your desired duct. And then EUS-guided gastroenterostomy, again, another popular indication for the lumen-opposing metal stents. This was the first one we did, and we do see it obviously in cancer patients, but we do have a population of patients who have severe chronic pancreatitis like this one. The technique has evolved over the years. Now I use more of a freehand technique, but this was the first one we did. So we passed a guide wire, injected contrast, and then put a dilating balloon inside the small bowel lumen, and then punctured that, and then deployed our lumen opposing metal stent. But again, we have a lot of issues here. We don't have really good lumen apposition between the small bowel and the stomach. You know, in Asia, they have this double balloon system that kind of stabilizes the small bowel for puncture, but we don't have that in the US. So a lot of things are being looked at, whether it's magnets, T-tags, coils, anything to kind of pin that small bowel up against the stomach, because that's the main issue if you misdeploy your stent. Which has been reported in multiple studies, but there was one article in GIE last year that talked about the 4 different types of ways you can misdeploy a stent during an EUS-guided gastroenterostomy. Most of them can be managed endoscopically, but if you go into the colon or you have a free perforation into the peritoneum, that might require surgery. And then we also, with all these LAMs, you know, if we leave them in long enough, what are the long-term complications? This was a case I had where a patient 3 months after a successful EUSG gastroenterostomy came back with a perforation. So we don't have the answers to all these questions at this time. And then EUS-guided radiofrequency ablation is another technique that's kind of gaining popularity, especially in small neuroendocrine tumors like insulinomas, and also perhaps in cystic lesions. But complications that have been reported include pancreatic duct strictures and pancreatitis. So, you know, with interventional EUS ERCP, there's a significant range of applications, especially in the bile duct and the pancreas duct. But, you know, we continue to gather data, and especially, I think, in the field of therapeutic EUS, there's still a lot of room for improvement, and that's probably seen the biggest growth over the past decade. Eventually, you know, is EUS going to replace ERCP for biliary drainage if we have the right tools? Because you can avoid pancreatitis rates. And there's definitely room for device innovation, which then I'll just briefly talk about, you know, bringing new procedures or techniques into your unit. A lot of times, especially for women, I think that's an opportunity for you to get your voice heard. If you hear of a new technique or device and you want it in your unit, then I think you can make a name for yourself by talking to the key stakeholders in your hospital. You know, who's going to pay for it, how much is the equipment, what kind of training is involved, what's the reimbursement, and, you know, you can say that you're going to increase productivity in the unit, you're going to bring prestige to your hospital by offering these techniques. Similarly, you know, I wanted to do photodynamic therapy in our unit, so I observed cases at other hospitals, trained on the technique, laser training, found out the cost for all the equipment and the medications, worked with insurance groups to see the coverage, and then talked to my oncologist to refer me patients with unresectable hilar cholangiocarcinoma. And then we did some marketing to say, you know, we're the only unit that does this in Chicago. And going back to a lot of the things that Pilar already brought up in her talk, you know, if the woman is not in a leadership position in her unit, then we do have limited access to resources, industry collaborations, and even research funding. Oftentimes with women, you know, if a man is making all the decisions and you have to clear all your ideas through them, it can sometimes be very daunting. And, you know, sometimes if you don't get credit for that, you may think, why am I trying? And we often don't want to fail if we bring an idea to the forefront. But obviously there are a lot of solutions that you can seek input from your colleagues, like at this session today. There's a lot of opportunities for growth through societies and courses. And then we talked about pay equity and family-friendly work environments. But these same traits that you can start on a local level by just trying to bring a new technique or procedure or device into your unit are the same ones that you would use to, you know, be a leader of the unit. You get a new set of skills through endoscopy courses and again, all these networking events. You try to seek out allies of all genders. And, you know, in things that are new, you have an opportunity to make your name known. I can't go back in time and recreate ERCP, you know, from 40 years ago. So things like artificial intelligence, new therapeutic EUS things, new stents, new wires. I think if you make a point to try to bring these things to your unit, talk to industry, you're an early adopter of new technology, then these are all ways that you get your name out there. And then you try to take ownership of all these things. And just one small plug for Women in Endoscopy, my colleague and friend Amrita Sethi, you know, founded this. She's the president and I'm the vice president, but we really try to use our platform to just bring together women all over the world and just work on things like leadership, giving them opportunities for speaking at different courses, and just kind of presenting their ideas in a public forum. And I think with that, I'll stop. You know, there's a lot of opportunity for growth in pancreaticobiliary endoscopy. Any new technology you bring to your unit can highlight your own leadership skills. And, you know, any chance for innovation is an opportunity for growth, both for you and for your unit. Thank you.
Bueno, nada, yo voy a dar mi parte de un poco lo que me pidieron, que es cómo podemos, ¿no?, ayudar a la formación. Es una charla que va dirigida a hombres o mujeres, no tiene ninguna diferencia en que uno sea un hombre o una mujer a aprender, ¿no? Que para mí, ¿cuáles son las vías que nos pueden ayudar y que, por tanto, hemos de intentar responder para este aprendizaje? Es ¿por qué no lo hemos de aprender? ¿A quién y por quién? ¿Cómo lo hemos de hacer? ¿Dónde y cuándo? ¿No? Y un poco respondiendo a estas preguntas, pues intentaré ¿no?, resumir lo que es el aprendizaje, sobre todo muy centrado en ECO-CPRE, pero se puede aplicar a cualquier técnica endoscópica. ¿Por qué? Bueno, sabemos que hay una expansión, ¿no?, brutal de las técnicas terapéuticas y en concreto de la ecoterapéutica y la CPRE asociada, pero también de las técnicas de tunelización y disección. En el concreto, la econdoscopia necesita un aprendizaje porque al principio cuando ¿no?, empezamos a mirar por ecografía no entendemos nada y nos tenemos que habituar a estas imágenes. Hemos de reconocer aquello que es normal, la anatomía, para después también reconocer las patologías ¿no?, y el conocimiento en estas patologías no solo es ¿no?, por la visión que nos podemos acostumbrar, sino también necesitaremos una habilidad técnica para reconocerlas. Y evidentemente ahí están asociadas todas estas técnicas a complicaciones y por tanto pues es importante, ¿no?, tener una habilidad cognitiva y una habilidad técnica y por eso pues se tienen que aprender estas técnicas. Esto ya, si empezamos a mirar en la literatura y de forma reciente y por diferentes sociedades, ya aparecen muchos artículos referentes a ello, por tanto esto ya nos marca que realmente es importante. ¿A quién hemos de enseñar, ¿no?, cuáles son los trainees, ¿no? Bueno, realmente tiene que haber una motivación de aquel que quiere aprender y unas habilidades generales, pero sí que es verdad, y esto está escrito, que la diversidad en el talento, tanto sea por ser hombre o mujer como la etnia, pues aumenta la creatividad, o sea, es productivo y ayuda también a innovar y a resolver los problemas. Por tanto, hemos de abogar a esta diversidad. Hablando de esto, y por esto sacando, ¿no?, de la literatura en Estados Unidos, realmente en estos programas de Advanced Endoscopy Fellowships, ¿no?, en Estados Unidos únicamente el 14% son mujeres y 32% de estos programas no han tenido nunca una mujer. Y esto está relacionado así también las jefas de endoscopia son mujeres o no. También es importante saber qué número de vacantes va a haber, porque si formamos a muchos endoscopistas avanzados y después no van a poderlo aplicar, no tiene mucho sentido. También lo que decimos, depende de dónde van a trabajar, es importante, porque si no tienen radiología intervencionista o una cirugía biliopancreática detrás importante, hay técnicas que no se van a poder realizar. Y respecto a la ecoterapéutica, lo que hemos comentado al principio cuando estábamos con los problemas informáticos, aquellos que aprendan ecoterapéutica tienen que tener habilidad en econdoscopia diagnóstica básica y en CPRE. Aquí no quiero poneros ni en números los años que tienen que haber, porque es muy variable, pero esto es importante. ¿Y quién ha de enseñar? ¿Quién hace estos trainers? Pues la verdad es que, aunque aquí pone, más o menos si buscas en la literatura, que han de tener unos 3 años de experiencia aquellos que enseñan, también depende mucho del volumen que hagan estas personas en su día a día. Pero lo que para mí es más importante es que les guste enseñar y además sepan cómo, porque ¿cuántos nos hemos puesto a enseñar a nuestros niños a ir en bici y tú sabes muy bien la teórica y cómo se tiene que hacer, pero aplicarlo después a cómo transmitir esto es difícil? Y en esto es lo que os he comentado antes, pues solamente en esta encuesta previa que había de los Advanced Endoscopy Fellowships en Estados Unidos, solamente el 13% de las que son jefas de endoscopia son mujeres, y va relacionado también en que en estos sitios también hay más mujeres aprendiendo. Entonces, ¿cómo hemos de aprender? En este caso, ECO y CPRE, pues yo creo que más o menos aquí es resumiendo de que primero el que haga ecoterapéutica ha de aprender ecodiagnóstica, después la punción, y después en CPRE hay unas clasificaciones de los niveles de complejidad 1, 2, 3, 4, y un poquito es como tendríamos que ir aprendiendo las técnicas de CPRE. Y cuando ya pasamos a la ecoterapéutica, pues evidentemente hay una graduación en función de la dificultad. Se habría empezar primero por drenajes de colecciones, después drenaje de la vesícula biliar, porque es bastante similar a drenar una colección, después acceso biliar y pancreático. Yo aquí pondría el pancreático un poco por arriba del biliar, y después la creación de anastomosis por econdoscopia. Y esto un poquito, la forma como lo tendríamos que hacer sería primero con un aprendizaje teórico, porque es muy importante, y siempre cuando viene a aprender a alguien, siempre le digo, es muy importante que sepas la teórica, que es saber las indicaciones, las complicaciones de la técnica y los materiales que se necesitan. Después habríamos de pasar, teóricamente, un hands-on con modelos, ¿vale? Y después hands-on con pacientes. Y aquí os pongo el online support, que ya os explicaré un poco qué quiero decir con esto. Pero la verdad es que, sobre todo aquí, en Estados Unidos no lo sé, pero aquí lo hacemos completamente al revés, ¿sabes? Y muchas veces el modelo el hands-on en modelos no lo tenemos, o nadie de nosotros lo hemos utilizado. Si pasamos al hands-on en modelos, que es lo que se debería hacer en técnicas más avanzadas, hay una revisión, para los que estéis más interesados en endoscopia intervencionista, de los indios, de Bandir. Y la verdad es que es muy buena esta revisión, revisa un poquito todos los tipos que hay. Un poco resumen, hay los simuladores digitales o computerizados, los modelos ex vivo o también los simuladores mecánicos, y también los modelos in vivo. El problema de todo esto es el coste de todas estas tres ramas. En los modelos de simulación digital o computerizados, hay estos que pongo aquí. La desventaja es que, claro, son menos reales y el tacto no es el mismo que hacerlo con evidentemente pacientes. Sí que esto en los modelos ex vivo es mejor, y los modelos mecánicos, aquí tenéis todos los que hay actualmente disponibles. Son diferentes fotos de varios de ellos, pero algunos, la verdad, muy bien hechos y que realmente son muy reales y que ayudarían a utilizarlos antes que en pacientes. Es una herramienta coste efectiva, lo único que se ha de tener también dinero para tenerla, y además tienes que ir reemplazando el tejido que utilizas, y esto aumenta la preparación del tiempo y los costes, y puede ser una limitación. Y lo que más conocemos aquí es el modelo animal, el practicar con cerditos, que llamamos nosotros, y ir a los estabularios, que si ves las revisiones, todos dicen que esto éticamente no es lo correcto, pero bueno, sí que es verdad que a falta de lo otro, pues antes que hacerlo con un humano, pues hay algunas técnicas que se deberían hacer en modelo animal. Respecto a esto, nosotros, 2 centros, Hospital de Belviche y nosotros, hicimos un proyecto para la introducción de las técnicas de tunelización en nuestro centro y pues lo hicimos esto con modelo animal. Y, de hecho, este modelo de formación reglada que hicimos 2 centros lo presentamos ahora en la SET un poquito para, pues, si puede servir de ejemplo a otras unidades o otros médicos que quieran aprender esta técnica u otras de cómo lo realizamos. Cuando ya pasamos a pacientes, que sería el último paso en teoría, pues hemos de empezar poco a poco con procedimientos cada vez menos complejos. Y lo que sería ideal es poder estar en estancias en centros un mínimo de 12 meses y si es posible que sea de forma continuada, sin interrupciones. Y habríamos de valorar nuestra competencia, que esto no lo hacemos, al menos aquí en España, no sé en Estados Unidos, pero aquí no lo hacemos. Y la competencia se puede valorar de 2 formas, a través de las complicaciones que tenemos y a través de estas herramientas, que está el DOPS y el TSAT, que el DOPS pues, es directamente ir observando aquello que tú estás haciendo y alguien pues lo va registrando en un report. Y el TSAT ya es uno que ya es más específico, hecho tanto para ECO como para CPRE. Y yo creo que es de vital importancia ya desarrollar e implementar estos programas de entrenamiento aquí en Europa, que no los tenemos. Y no sé si nos podemos guiar un poco, que ellas nos expliquen cómo son este Advanced Endoscopy Fellowship que hay en Estados Unidos y a lo mejor copiar algunas cosas de otros países que lo están haciendo mejor que nosotros. Yo no me atrevo a poner, veréis mucho en la literatura sobre el número de procedimientos que se han de hacer, que si 300 CPREs, que si 250 ecos, punción. Para mí esto es muy variable, depende mucho también de la persona que aprende y no me gusta poner número de procedimientos. Y bueno, esto se salió publicado el año pasado, es como un retrato de cómo estamos actualmente en Europa respecto al aprendizaje ECO y CPRE a través de una encuesta y lo que se ve es que evidentemente los programas de aprendizaje son muy variables y que falta en muchos centros y en muchos países pues realmente un programa de training. Se requiere que los que aprendan puedan tener un currículum específico y que preferiblemente sea después, evidentemente, de acabar la residencia. Y también centralizar en Europa sitios donde se pueda ir a aprender tanto con pacientes como también con modelos. Y para eso, pues esto necesitamos que entre también los diferentes centros pues establezca un programa específico de alta cualidad y que sea uniforme. Para ello hay una cosa imprescindible y es que nos ayuden tanto las sociedades como las instituciones a aquellas personas que queremos enseñar en aquellos centros donde se quiere hacer y en los departamentos de endoscopia, porque sin esto pues no tenemos ni tiempo ni dinero para poderlo hacer de una forma correcta. Para mí, cosas prácticas que yo al menos creo que son muy importantes y que siempre se lo digo a aquellas personas que aprenden conmigo, observar, aunque os parezca que no, observando se aprende mucho. Observar, ves a veces lo que le puede pasar a uno y qué hace esa persona y es muy importante el observar, no es perder el tiempo para nada. Es muy importante cuando se aprende a hacer eco y CPRE, primero saber entrar el tubo, o sea, no querer ya canular una papila si no sabes entrar un duodenoscopio. Y en el caso, por ejemplo, de una papila, empezar con papilas que no sean nativas, empezar sacando prótesis o empezar entrando balones en papilas que ya tengan papilotomías previas. Y el tema del soporte online que os he comentado, creo que cada vez, y además con las nuevas tecnologías, lo podremos utilizar más. Y, por ejemplo, liderado por el grupo del doctor Joan Gornals en Belviche, a raíz de que ellos tuvieron complicaciones introduciendo la gastroenteroanastomosis, pensaron que a lo mejor hacer un estudio que nos ayudara a los otros centros a cómo introducir esta técnica con un soporte no online, pues podría ayudar a la introducción de esta técnica en estos centros. De momento hay 7 centros participantes, pero sé que se van a unir más del resto de España. Y la hipótesis es esto, del estudio, que la introducción de una forma acompañada de esta técnica pues disminuirá las fallidas técnicas y sobre todo las complicaciones. Esto es justo de septiembre, más o menos, ya hay 102 pacientes incluidos. Yo os puedo hablar de los míos 21 que he hecho en Tarrasa y de los 21 que he hecho toco fusta, que se dice en catalán, que es toco madera. De momento no hemos tenido ninguna complicación, hay sitio técnico en todos y sin ninguna complicación. Y esto ha sido gracias a la ayuda pues, de otra persona que de forma online te va diciendo cómo realizar esta técnica. ¿Y dónde hemos de aprender? Pues evidentemente en centros donde haya alto volumen y de complejidad, pero esto es para aprender la técnica. Después, para consolidarla, sí que es verdad que se aconseja a lo mejor ir a un centro con menos volumen porque tiene menos complejidad y podemos consolidar aquello que hemos aprendido en centros de alto volumen. Importante que hayan personas que sepan enseñar y que les guste, y yo creo que con el tiempo también que hayan certificaciones de que realmente ese centro está capacitado para enseñar. Las recomendaciones que hace la ESG de que habría también de tener este centro es que además pues el que va a aprender pueda estar en los comités multidisciplinares, además que haya cirugía hepatobiliopancreática e intervencionismo radiológico, y que además también esta persona se involucre en la investigación y en las innovaciones que vayan habiendo del centro. Yo el que hayan simuladores de ECO y CPRE, ya lo veis que el agreement aquí no era del 100%, esto claro, en muchos centros no se tiene y podría ser una limitación, pero yo creo que las otras tres cosas son básicas. También a nivel internacional de Europa, sabemos que ahora la ESG ofrece estos fellowship grants para poder ir a centros y aprender. Está un primer módulo que es para observar con expertos y un segundo módulo que ya es para ya estar con un advanced training con estos expertos. A nivel local tenemos pocas cosas, pero bueno, tenemos cursos nacionales, tanto hecho por Enrique Vázquez Sequeiros como por Joan Joan Gornals y Modesto Varas, sobre todo de condoscopia, que hay una parte online y una parte de presencia. Y también hay másters de endoscopia así más generalizada, que son tanto de la SED como el máster que hace el clínico. Y una cosa que creo que también es importante, y en esto la industria nos puede ayudar y que ya realmente es un ejemplo con Boston, es que ellos hacen cursos hands-on para poder liberar y enseñar a liberar las axios. Y esto, por ejemplo, pues es en un curso que hicimos en Belviche para enseñar a gente cómo liberar estas prótesis. ¿Y cuándo hemos de aprender? Pues bueno, cuando tengamos tiempo y recursos. Cuando tenemos una experiencia sólida, establecida en endoscopia, gastro y colonoscopia. Necesitamos plasticidad cerebral y esto quiere decir que para mí la edad es un factor limitante. Hay algunas técnicas que no se pueden aprender cuando tengamos cierta edad. No pongo un número, pero vaya, es importante tenerlo en cuenta y sobre todo si vamos a tener continuidad. No tiene ningún sentido aprender si después no lo vamos a aplicar. Como mensajes para llevarnos a casa un poquito de todo eso, es que hay una expansión evidente de la endoscopia terapéutica y por eso necesitamos técnicas de un programa de aprendizaje, necesitamos habilidades técnicas y cognitivas para sobre todo también evitar complicaciones. Es muy importante saber a quién enseñamos y por quién se enseña. Aquí sí que es importante el tema también del sexo. En el caso de la ecoterapéutica, pues necesita primero CPRE y econdoscopia y después ir avanzando, como os he comentado, en colecciones, drenaje de la vesícula, biliar pancreático y creación de anastomosis. Para mí es difícil establecer un número exacto de procedimientos porque es muy variable en las técnicas. En teoría habríamos de tener un conocimiento teórico, pasar a un hands-on con modelos y después un hands-on con pacientes, más este soporte online que creo que irá cada vez a más. Cuando vamos a un centro habríamos de estar idealmente un añito y que es evidente que en Europa hay una falta de este aprendizaje y de tener realmente un programa bien de aprendizaje y necesitamos esto, establecer programas de alta calidad con certificaciones y para eso pues necesitamos que tanto las sociedades científicas como las instituciones nos ayuden. Y no me quería ir sin dar las gracias a aquellos que a mí me han enseñado. Al principio de todo, ya cuando era residente, me fui a Los Ángeles con el doctor Loctío. Después también el doctor Seoane y el doctor Barranco, que me enseñaron econdoscopia, como la doctora Ángel Ginés. el doctor Jorge Espinós, que me enseñó todo lo que sé en CPR y le estoy muy agradecida. Como no, al doctor Joan Gornals, que aparte de que me ha enseñado, ¿no?, muchas técnicas, es mi marido. Y yo creo que Manolo también, ¿no?, es un referente para todos en el aprendizaje en estas técnicas. Y ya está. Muchas gracias. Sí.
Bueno, pues muchas gracias por seguir aquí, no haberos escapado. Y bueno, pues un turno así de preguntas. Si alguien quiere preguntar alguna cosa, pues es el momento.
Yo una pregunta rápida, si puede ser. I try in English y en español. Desde dentro, desde el equipo, inside the team, do you think we can do something to change the situation? Algo para ayudar a cambiar la situación, que no haya una brecha en este sentido, desde dentro del equipo.
Respecto al género.
Sí, con comportamiento, claro. No puede ser que luego rascando, ¿no?, haya un 37% de diferencia de salario por el mismo trabajo.
Pues sí, no solo siempre es por el mismo salario, ¿no? Muchas veces, no por el mismo trabajo, quiero decir, muchas veces en nuestro tipo de trabajo en un hospital público, evidentemente la hora que me pagan a mí es lo mismo que te pagan a ti, pero es verdad que probablemente a lo mejor yo hago o otras mujeres hacen menos horas porque cuidan a sus niños, hacen menos guardias porque cuidan a sus padres, pueden publicar menos porque están muy cansadas, porque se han estado levantando por la noche. O sea, evidentemente la carga familiar es muy importante y a lo mejor los jefes o los compañeros pues tienen que saber eso. A lo mejor me puedes pedir trabajar por objetivos, no me puedes pedir que para mañana haga tal cosa, pero sí que en este mes haga esto. Eso puede ser una forma de ayudar, ¿no? Las mujeres a lo mejor tenemos que trabajar en otros tiempos, en otros momentos. Eso desde el punto de vista de los compañeros. Evidentemente, desde el punto de vista de la casa, pues hay que pedir a nuestras parejas compartir la responsabilidad. Y eso es lo que se puede hacer, creo yo.
Okay.
Pero aprovecha que hay más mujeres que te pueden...
Sí, no sé, vamos, que...
Yo lo que creo es que una cosa que ha dicho Pilar y que, a ver, cuando yo empecé íbamos a los congresos, éramos 4 mujeres. Ahora cada vez en todos los congresos de endoscopia y en todos los eventos cada vez hay más mujer. Yo creo que habrá, es inevitable, yo creo que el crecimiento y que la mujer entre, ¿no?, en la endoscopia y esté visible, es que será evidente, pero porque cada vez habrá más referentes mujeres, habrá más mujeres, como pasa en el fútbol, ¿no? Ahora vemos, ¿no?, la expansión que hay en el fútbol femenino y es porque, bueno, cada vez hay más mujeres que hacen fútbol. Cuando era chiquitina no se hacía fútbol, ¿no?, las chicas, pues yo creo que esto pasará lo mismo. Y, hombre, yo creo que lo que también ha dicho Pilar, ni a mí me gusta que me pongan en un sitio porque sea mujer, ni yo elegiré a alguien porque sea mujer, elegiré a alguien porque es buena, sea mujer o sea hombre, ¿no? Pero bueno, creo que cada vez habiendo más referentes, pues también el papel de la mujer.
You know, sometimes you try to do something or you think is correct my behavior, or sometimes it's not correct for be equals or to raise the equality or something. No, I don't know. I want to know if I can change something inside my behavior or something.
I mean, I think if we work together, I would tell you what to change, so that would be easy. But you know, I think half the solution is that you're thinking about this issue because you want to be equal with your female colleagues. So I think that change in mentality hopefully will continue throughout, you know, the field. And I did not speak Spanish, but I'm assuming what you both said earlier, to change the environment in the unit, more women speak up, and then if there's more female chiefs, then, you know, we're very attuned to these issues and try to change how we present ourselves and how the team reacts to us. But I think more women are getting into these roles, so that is going to change the perception, along with men getting used to that. So I think also Manolo told us we have to wrap up now, but we can continue this conversation at the dinner at 9 o'clock.
Sounds good.
So thank you.
Thank you so much.
Was just going to cover a little bit of interventional pancreaticobiliary endoscopy. It's a lot of show and tell of some videos. And I'll just start by saying, you know, I think when we talk about GI for an advanced endoscopist, that, you know, takes center stage, and then all the other areas in GI are kind of in our periphery. But we do touch on a lot of those different areas and can offer procedural solutions to a lot of diseases. And for pancreaticobiliary endoscopy, you know, obviously our procedures center on ERCP, where we deal with the bile duct and the pancreas. Most of the time we're stenting, removing stones, sometimes we're ablating tumors. We can do cholangiopancreatoscopy, ampulectomies. And I will say in the last decade, there probably hasn't been as much innovation on the ERCP side as there has been on EUS, and obviously thanks to Boston for helping support this session. There's a lot of, I'll talk a lot about Axios and lumen-opposing metal stents, which have improved our capabilities with drainage. We can also access the pancreas and bile duct, do luminal interventions, and now ablation. So just with ERCP, you know, this was a case where a gentleman was told you have bile duct cancer at the hilum in the biliary tree, but then, you know, if you do cholangioscopy, you can see he actually just had a very large stone. So it was nice to give him some good news. It was a little bit bad news for me because the stone is huge and the distal duct is small, but, you know, we can use, I don't have the EHL, but we can use electrohydraulic lithotripsy to fragment those stones. If patients have large ampullary polyps that are hopefully benign, especially we see a lot of polyposis syndromes in our institution, we can do ERCP and successfully remove these polyps and prevent the patient from having to go for an invasive Whipple surgery in most cases. And you'll see here, we're going to take off the polyp. And then we always worry about inducing pancreatitis. So afterwards, we always put in a pancreatic duct stent. And then we can just bring this patient back for surveillance. Most of the time when we're dealing with malignancies, especially pancreatic tumors, we see a lot of malignant biliary obstruction in our practice. And so nowadays, our standard of care is to put in a metal or a self-expandable metal stent. I don't know if this has a pointer. Does this have a pointer? Oh, that's all right. Oh. Okay. Pretty standard procedure for us. Although it's funny because we had Mike Mahoney from Boston Scientific come and spend some time in our unit, the CEO of Boston Scientific, and he was so impressed that we can put in a metal stent in the bile duct for decompression. But for us, you know, we do it every day. And so now, I think it's kind of dark. You're going to see the stent being deployed. And then we can also ablate tumors. In our practice for hilar cholangiocarcinomas, we use photodynamic therapy. The patient's given a sensitizing agent, Photofrin IV, 2 days before the procedure, and then you activate the drug with a low-powered laser that you can put through a cholangioscope. And then also there is a radiofrequency ablation probe. I tend to use this more for dealing with metal stent occlusion when you have some tissue ingrowth. The difference between the two ablation techniques, the PDT is a lot of setup. You have to know how to use a laser. and the drug beforehand. But with the ablation catheter, it just connects to our standard Irby generators, goes over a guide wire. But you do have to make contact with the tissue to get good ablation. So then when we talk about therapeutic EUS, now we can drain basically any fluid collection that's accessible by our scopes, whether it's in the chest, the liver, gallbladder, bile duct, pancreas, and even down in the pelvis. But everything kind of started with us draining pancreatic collections. And over the last, couple decades, actually, our techniques have evolved over time. In the beginning, we didn't have EUS, or actually, I've always had it, but for those of you who might be older who did it, you just had to go blindly with a scope, hopefully saw a bulge, and then cut into it and hope you were in the right spot. And then once you had EUS guidance, you were able to avoid blood vessels. You could target collections that did not have an obvious bulge on the lumen side. And then now we have EUS-guided cautery-directed access, which lets us get into the collections pretty easily. So not only has our technique changed, but also the tools. We tried to use a lot of ERCP tools, plastic pigtail stents, and then metal biliary stents, again used at ERCP, and only, in the last, it's been almost a decade now, we have had lumen-opposing metal stents. And these are specifically for draining these collections because, again, the other stents were too long. You had no lumen apposition, risk of separation from the GI tract wall and the collection. The stents could migrate. You had to do multiple steps where you had to dilate, use X-ray, and every time you exchange a device, there's a chance you could have a complication, and it takes more time. But with the lumen-opposing metal stents, they have a very short length and big flanges, so that it's great for bringing the collection wall and the GI tract wall together. We have all different sizes, actually, up to 20 millimeters. So if you needed to, say with necrosis, you can put your scope in and debride very easily. It's super easy to deploy. I feel bad now, a lot of our trainees are only used to deploying these lumen-opposing metal stents and aren't as familiar with the more complicated double pigtail placement, which sometimes we still have to do. But it's very easy to deploy and lower rates of migration. And this was, I think, the first Axios case I ever did with the cautery-enhanced device back in 2014. Initially, I used to use a guide wire, but now we do most of these freehand. So you saw a puncture with a needle, a wire, and then the Axios going in to into the collection. And we'll kind of rinse and repeat on a lot of different drainage procedures, but you see the distal flange opening up, and then we'll pull back. And initially, we would look at it endoscopically on the proximal flange, but now we just deploy everything under EUS guidance. You don't need fluoroscopy, and you can just put it inside the EUS scope. So say if you had an emergency case in the ICU, you could do it bedside even. Some complications with LAMs that have been reported, you can get delayed bleeding, tissue overgrowth like you see in this picture, especially in the antrum, which is also the location where stents can get occluded by food. And obviously, these are very short length stents, either 8 or 10 millimeters, so there is a chance you can misdeploy, and depending on what you're trying to go into, patients can get peritonitis and perforation. So for pancreaticobiliary access, oftentimes we have a lot of patients who have altered surgical anatomy, Whipple's, bypasses, or they have malignancy that's blocking our path to the ampulla for biliary drainage, or say you just fail at ERCP cannulation. This is where EUS guided techniques can help get a successful procedure. And the main things are you do need to have expertise in EUS and ERCP. We talked about that earlier. You really need good cross-sectional imaging ahead of time, and you do need time. These procedures, when we show them in talks, are always edited down to 1 minute, but oftentimes take a lot longer, and you really need to have good communication with whoever's going to back you up if you don't succeed, and also just with your team so you can manage complications. And Manolo published this diagram, again, it's been about a decade, but I think it's really nice just to show you all the different ways that you can use EUS guidance to gain access to the bile duct. the ideal for me is always trying to do a rendezvous where you can still put your stents or do your maneuvers, mural fistula tract.
Good afternoon, everyone. So welcome to the final step of this amazing course. And the first speaker will be Michael Brunswick from Leuven, Belgium. He's going to talk about this controversy. What is better? Is better the gastrojejural anastomosis, laparoscopic bypass, or stents? Images, thank you.
Thank you for the introduction. So it's not a very sexy subject like you had or Giuseppe, but I think it's important to know what these comparisons are like, and not so much what is better, but what are the pros and cons. So these are my disclosures. So in an ideal world, gastric outlet management should actually greatly improve quality of life, facilitate oncological therapy at the cost of minimal morbidity. And as a originally a Dutchman, I like to keep the cost low as well. So that we do not have to place multiple duodenal stents like here on the right side. So for laparoscopic gastroenterostomy, we know that this has excellent long-term efficacy, but it's also associated with high morbidity rates and also even mortality. And we can see it here on the left. There was a patient with pancreatic cancer that explicitly requested a laparoscopic gastroenterostomy to be done. And he suffered from another gastric outlet obstruction, benign gastric outlet obstruction, due to torsion of the anastomosis. So this illustrates that not only does the science suggest that it maybe isn't an optimal approach, but in real life, our surgeons are even a little bit hesitant to perform these procedures because it's associated with secondary gastroparesis, some local complications such as bleeding and leakage, and a subsequent postponement of oncological therapy. So just to say that there was a clear room for improvement for the management of gastric outlet obstruction. So for enteral stenting, I think this is one of the most well-known studies by Jörning, the SUSTEN trial from 2009. I think there were 2 other randomized studies that were published just a little early, but I think this is the most well-known. And 39 patients were randomized to undergo surgical gastroionostomy and stent placement, and I think this is the most interesting table that is in the article. What we can see here is that the Goose-adjusted survival in the beginning is quite good for enteral stenting, but then these patients lose their efficacy over time. And for a surgical gastroenterostomy, these patients have a hard time getting the proper oral intake in the beginning, but then you see these curves crossing again. And if we take a look at secondary outcomes, we can see that hospital stay and treatment costs are significantly lower for enteral stenting. And which is also nice to see is that feeding costs and also the need for tube feeding is significantly lower in the enteral stenting group. So I think with these and other studies that have been performed, we can conclude that the enteral stenting is the less invasive technique and improves short-term intake and quality of life, and thus also reduce hospital stay and healthcare costs. But what about the efficacy and the facilitating of oncological therapy? And what we see here is a recurrent gastric outlet obstruction in a patient with metastatic breast cancer, so a lobular breast cancer that extended towards the stomach. And in total, 4 duodenal stents were placed in the last years. So a stent in stent in stent in stent. And this was the time that she was referred to me. And what you see in these patients is that oncological therapy is one thing, but these patients are being readmitted for recurrent gastric outlet obstruction. So we needed something more efficient. So we performed a US-guided gastroenterostomy, and I'm not going to show you the whole video because we've seen so many more nice procedures here during this session and event. We placed the nasobiliary catheter and then placed a 20mm LAMS. You see it opening here. And this patient did well for a total of 4 years, and she was never readmitted again for gastric outlet obstruction. But what I did do was do a yearly check of the hot axials and then replacement if necessary. She underwent 2 hot axials replacements, but as you can see, the hot axials was still open. This was more to prevent stent embedment and ingrowth. And I was a couple of weeks ago, I was informed that she unfortunately died, but because of disease progression and not because of malnutrition or recurrent gastric outlet obstruction. So it's a sign that we're doing something right here, and it would be nice to see this in the future for EUS-guided biliary drainage as well, that we don't see patients dying of secondary biliary cirrhosis, but more to disease progression as a sign that we're doing something good endoscopically. So how does EUS-GE compare to duodenal stenting? And this is a study that we performed with the LAMS guys, the Leuven, Amsterdam, Milan study group. We included 214 patients, did a propensity score matching using disease stage, age, and so on, and compare EUS with duodenal stenting. And what you see, even at, after performing the procedure, is that almost a quarter of patients even had clinical failure. And then over time, what we see is that a quarter of patients also suffered clinical failure after initial success. So we can actually say that almost half of patients, it's more like a flip of the coin for duodenal stenting. And one of the major comments you always get about EUS is that, yeah, but it's not safe, you get mal-deployments. But what we see here is that overall adverse events weren't higher. There was even a numerical lower number of adverse events. So if we take a look at the time to gastric outlet recurrence analysis, we can clearly appreciate that there's a significant difference between EUS and duodenal stenting over time. And I think you can see this small notch over here. If I remember correctly, this was a recurrent obstruction of a lens, which was treated endoscopically by food disinfection. So Manolo was one of the first to publish his series comparing it to laparoscopic gastroenterostomy in 2007, together with other colleagues. Several techniques were included, and this was definitely in the beginning times of USGE with different techniques, even extraction balloons that were punctured, and so on and so on, but also some nasobiliary catheters that were already in use. And what they saw was that technical success was more or less similar, although there was a difference, a non-significant difference in favor of laparoscopic gastroenterostomy, but that clinical success was similar, but EUS led to fewer adverse events and also a lower procedural cost. Of course, we had to do the same with the LAMS group, and we included 126 patients. This was done in 2021, and what we saw was that the clinical and technical success was similar compared to surgery, but that EUS led to fewer overall and severe adverse events, as well as shorter hospital stay and shorter median time to oral intake. And this is exactly what you want in those patients that need to undergo oncological therapy. You want them to be able to eat quickly and be out of the hospital quite quickly. So one of the major comments an editor made from endoscopy was, okay, that's all fine and very nice that you published your retrospective series now, but we want to see prospective work. And I can say that we and other colleagues also here in the room have done their job. These are two prospective series that have been published in GIE lately, so the Spanish group and Italian group. And both groups included a standardized approach to EUS gastroenterostomy using the nasobiliary catheter method, or WEST. And what we see is that clinical success is very high and that adverse events are around 10 to 15%. It's even more nice to see that we're now also getting the RCTs in, and this is the study led by Anthony Teo from Hong Kong. He presented his data on the DDW this year, and EPAS was compared to duodenal stenting. I think, Rusty, you participated as well. And patients were randomized, 48 patients to EPAS, and duodenal stenting 49 patients. And what you see is that the 6-month patency rate is much higher in the EUS group. And there were no differences in secondary outcomes, and adverse events were actually almost identical. So we're also working ourselves on getting those randomized studies going, and we're currently actively including in our eating trial together with all these colleagues, many of which are here in the room as well. And we're working hard on getting that randomized controlled trial done. We also know that the Dutch group, including also Roy, are working on a same approach with the Enduro study. If we compare, this is done by just Dutch centers, and the primary outcome is a little bit different. They use time to soft solids as a combined endpoint together with recurrent gastric outlet obstruction, and the sample size was around 96 patients. So it will be really exciting to see those two studies being published. So ladies and gentlemen, I try to be short today. I think we can conclude that whilst we are looking for those surgical comparisons, randomized comparisons, we can say that EUS outperforms duodenal stenting with a surgical range efficacy, with the similar complication rates, yet different safety profile, and that we're continuously improving our approach, thanks to also the nice steps that Giuseppe already showed us. But although it's really sexy to put in a LAMS for everything, I think we do have to keep in mind that if EUS-GE is unfeasible, there's always still enteral stenting. So the most important thing is that the patient is able to to go home and can eat well. If this is done by enteral stenting, this is fine. And also for patients with benign gastric outlet obstruction and good performance status, we should still consider surgery because of the good long-term efficacy. So I thank you all, and I must say that every one of you made this a great experience, my first Value Live experience. So thank you all, and I hope to see you next year.
Thank you, Michel. I'm sure you will be invited next year. Is this your first time? I'm sure you did
Perfect.
very well. Let me ask you something. What is your personal preference in those cases that we have seen in this course, those patients with an advanced cancer and ascites? What is your approach?
The risks are high, but the benefits are high as well. And I think ascites shouldn't be regarded as a strict contraindication, but if you see that the small bowel is swimming in ascites, you can do a paracentesis beforehand, but you really have to think about is, am I helping the patient or are we taking a necessary risk here? So if there are a lot of downstream peritoneal metastases and expected survival is quite low, I think you have to discuss this with the patient. And a good conversation is often cheaper than doing an unwanted complication.
Would you consider surgery for one of those patients?
That will be difficult to get that sold to the surgeons. And I think their complication rates are also quite high. So still, I think something that is never discussed, those really patients with really extensive disease stage, sometimes one of the more elegant approaches is also to place a venting pack so that they can go home. It's never talked about, but this is still an option in those really sick patients with lots of disease manifestations.
So I will be controversial in this question. Surgeons will not operate those patients.
Exactly.
And the gastroduodenal anastomosis, but EUS, could force those patients to go to surgery. What patients would you choose, taking that in mind, to do J anastomosis by EUS? Your ideal patient in which you will consider to do an endoscopic EUS-guided anastomosis?
I think every patient with a malignant gastric outlet obstruction is a potential candidate, even if there's a little bit of ascites, as long as it doesn't interfere with the trajectory. I think almost everyone is a good candidation, as long as it's not a potential surgical candidate or it's due to a lymphoma or something. No.
Okay. Any questions for the audience?
I have one question for you. So I think after the US-guided gastrojejunostomy, in some cases, we have seen a gastroparesis. Is that related to the time before doing the procedure, or is that related to the limb that we directed to? Directed to A limb, to E limb, does it affect gastroparesis after the USGJ?
To be honest, that's still a question we have as well. So what about Lamb's direction? Should we do it isoperistaltic or anti-peristaltic? Does that have effect? What I do think is that an early US-guided gastroenterostomy is better than a late one. So if you already have a decompensated stomach that is already dysfunctional for a long time, I think those are not ideal patients. And also patients with invasion of the gastric wall, you can already expect that some motility stuff is going on as well already.
Because in an era of duodenal stent, I don't think that we have seen this problem much, but in era of the US-guided GJ, I think I have seen some. But even though in your information is comparable in terms of dysfunctional, but I think the reality.
And there are other problems and issues with the duodenal stent as well. If you make it a little bit too long in the stomach, then you get this sieving effect, and then everything clogs up again. So it has its pros and cons.
Michelle, thank you very much. Next presentation will be by Dr. Pravleen Kahel, who's going to talk us about transgastric ERCP in a modified anatomy, Roux-en-Y gastric bypass, the H procedure.
Perfect. All right. Good afternoon, everyone. Thank you so much. I would like to thank Manolo for giving me this opportunity. So the task at hand is edge procedure. These are my disclosures. So I'll start off with a case. This is a 61-year-old man who came to my clinic for evaluation of intermittent right upper quadrant pain. nausea, vomiting, and he had a significant past medical and surgical history, as you can see. He had a past history of Roux-en-Y gastric bypass, which was done 7 years prior for obesity. He had complications with bile perforation, which required resection. He had a short gut syndrome, urothelial cancer, which required surgery, multiple other medical problems like rheumatoid arthritis and chronic kidney disease. And this is the CT scan of the patient. So this is a non-contrast scan, but right away on the axial, you start seeing a little bit of an intrahepatic biliary dilation. And soon you'll see common bile duct with the choledocholithiasis. There were about 1 to 2 centimeter stones in the common bile duct, and then you see a couple large stones in the gallbladder, with the largest one measuring 3 centimeters in size. Similarly, this is the coronal scan, which just goes over the same information. You see a little bit better, little bit distended gallbladder, large stone sitting there, dilated common bile duct, and you see the stone at the bottom of the bile duct, couple of them. So, question maybe to my esteemed colleagues here and to the people in the audience, what would you recommend as the best next step in the management? As they say, when in Rome, when in Valladolid, what would you do? All right, so we'll talk about what happened to the patient, but moving on to the presentation. So when you are somebody, we heard some of the options here, wonderful talks earlier. Somebody who has Roux-en-Y gastric bypass and you need to intervene in their pancreas and bile duct, you have multiple options. Earlier we heard Dr. Monkey-Muller talk about the balloon-assisted endoscopy, ERCP, and we heard about the laparoscopy-assisted ERCP, and of course you have option of proceeding with EUS-directed ERCP. We saw a case earlier. And then don't forget about what I call as the sweet serendipity, where in about 5 to 7% of the patients, they can have a persistent gastrogastric fistula. So if you have a patient referred to you for EUS-ERCP, the patient has a previous gastric bypass, I think it's probably good to just insert a standard upper scope first. You may be surprised, in about 5% of the patients you found a fistula, you can utilize that tract for the procedure. Now, what's the data? When you talk about these different options, how does EDGE compare with balloon versus laparoscopy-assisted ERCP? Multiple papers out there, studies listed. Technical success when it comes to EDGE and laparoscopy-assisted ERCP is quite comparable. A little bit superior than balloon, which again is not a surprise. Dr. Monkey-Muller presented the data that is about successful in about 70 to 75% of the patient. Adverse events quite comparable, but look at the cost effectiveness. EUS-guided ERCP is more cost effective than balloon and laparoscopy-assisted ERCP. And that is despite taking into account the cost of LAMS. Why? Because it boils down to the length of hospital stay. On an average, people who undergo EUS-directed ERCP, they are in the hospital for about 1.3 days. But when you look at patients who undergo laparoscopy-assisted ERCP, they are in the hospital from 1.4 to up to 3.9, almost 4 days in the hospital. Not to mention they have percutaneous drain that they walk around with for about 4 to 6 weeks on an average before that's pulled out. So what does the guidelines tell us? Well, when you look at the ESG guidelines published last year, they do say, well, EDGE, in people who have Roux-en-Y gastric bypass, you can perform EDGE in an expert center after multidisciplinary discussion, people who are involved in the care, instead of laparoscopy-assisted ERCP. I think this was just a video. We just watched the procedure live. I do all my EDGEs two-step, which means that I do the first part, I place the lamps. I preferably try to go through Roux-en-Y, and I mean, there is a few of us sitting here who do this kind of a procedure, and I'm sure you'll hear different opinions. And everybody has their own technique on how they go about doing this. Some may preferentially go to the pouch. I preferentially go through the Roux-en-Y. Why? Because I find the fistula closure is much more predictable. And again, this is, you see the remnant stomach, sand dollar sign, beautifully described by Todd Barron. You see the needle going in, we distend the stomach. I place the lamps and I bring the patient back anywhere 3 to 4 weeks after the fact, and then we go on to do what needs to be done, pull the lamps out. So what's the data when it comes to EDGE. I think when we talk about EDGE, the three burning questions that are posed is one-step versus two-step. What's the data out there? What about the persistent fistula? Should the surgeons be concerned, well, the patient is going to gain weight, you are reversing the bypass, and talk about the adverse event, and how does 15 versus 20 millimeter lamps going from the pouch versus the jejunal rim has any impact on these three main questions. Well, what's the data on one step? This was the largest and still is the largest single step, one session EDGE that is out there. Multi-center retrospective study, 128 patients. What did it show? Migration dislodgement of lamps can happen in up to close to 10% of these patients. In this study, they found that the patients who had 20 millimeter lamp, so if you are doing a single session, if they went with the 20 millimeter lamps and they sutured it, secured it, the risk of dislodgement was less. It's never zero. So keep in mind that number. If you're going with single session in about 1 in 10 patients, it is going to dislodge. And then there's this small series that's out there which looked at the modified version. So they did it two-step. So they compared the single session, and then they brought the patient back 2 to 4 days later instead of the usual 3 to 4 weeks. So it's small series, 11 patients in the single session, 10 in the shortened interval, 2 to 4 days. But again, look at the number. The data is quite stark. The stent migration in the single session, almost half of them migrated. So in this particular series, they used 20 millimeter lamps. None of them were secure. So half of them migrated during the procedure. But even if you wait at least 2 days, the migration risk goes down, which was only 1 out of 10 migrated. So something to keep in mind. If you think the patient needs a little bit more urgently, probably still safer to wait a couple days instead of doing in the same session. If you're doing same session, 20 millimeter, and try to secure it. What about the persistent fistula? This is a busy slide. Again, there are over about 330 patients on this slide from multiple studies, including the largest one from Kashab. We were part of that paper. And they looked at this question, what about the persistent fistula? They found the persistent fistula at about 6 to 8 weeks follow-up in up to 12% of the patient. But those 12% who had persistent fistula, they were able to close that with variety of methods, by APC burning the tract, by suturing it, or by using an over-the-scope clip. So even though patients had 10% persistent fistula, they were able to close it. Did it lead to any weight gain? The answer from these 330 patients is no. There was no significant weight gain, although there were recent couple retrospective studies that published that show that patient can gain up to about 5 to 7% of weight. So if you have this concern that patient may have persistent fistula, what are the factors that are associated with it? Several studies, they point out that if you leave the lamps in longer, more than 35 days, another study showed if you leave it more than 55 days, the chances the fistula will stay are higher if the patient has underlying diabetes or if you're using 20 millimeter lamps. So on one hand, 20 millimeter lamps prevent dislodgement, but on the other hand, it may lead to persistent fistula. So keep that in mind. If you're doing the procedure and if it's a two-stage, try to bring the patient back within 4 weeks, finish the procedure, and try to remove the lamps off. And finally, another factor associated with this lack of primary closure method with mucosal denudation. So I always really burn the tract with APC, and that has been shown to promote the fistula closure. So if you're not using that, chances the fistula will stay open are a little bit higher. Studies also show factors that are not associated with persistent fistula is if you're going from pouch or GJ, they didn't find any difference. Again, anecdotally, I find that roux, they close better, but if you're going through the pouch and you're closer to the staple or suture line, that's more of an ischemic zone, the fistula tend to stay open. Or if you go from the blind limb, that's where the fistula will stay open. So I try to avoid those scenarios. All of us, we heard about the adverse events. Again, this procedure is fraught with the possibility of adverse event. Main one is the perforation, which can lead to peritonitis. Bleeding is another risk, and all the complications that can occur from the migration of lambs. We saw this beautiful presentation about the NOTES salvage procedure by Dr. Baptista. So I was trying to go back to the video. Sorry, this is just. So when you do a lot of these, you encounter really unique scenarios. So this was one of the earlier cases. I think I did this in 2017 or so. And you notice we went through the blind limb. And this patient had a delayed migration of lambs. So I brought the patient back 3-4 weeks later, and there's no lambs. But in its place, you see a little bit of a tiny pinpoint hole, which suggested that's where the lambs was. And the reason I say this delayed is because this was still communicating with the remnant stomach. So I was able to utilize the tract with a wire, balloon dilated, put in a fully covered through the scope stent, and then was able to do the procedure. So again, the point being, be prepared to handle unexpected situations like this. Make sure your toolkit is fully stocked with the through the scope fully covered metal stents in case you need to salvage the situation. Another not so uncommon scenario that I've encountered is, and that can happen especially if the patient has a bigger pouch, you know, not all pouches are same and not all Roux-en-Y's are same, is this candy cane phenomenon, hockey sticking off the scope. And if you went to the Roux, I've noticed this happening, and I reported this use of an overtube. You can put in overtube, it nicely drives down. It's a 52 centimeter long overtube. It drives down right to the hub of the lamps, and now you have a straighter conduit and you can go on to do the procedure. There's a newer device out there that is for the colonoscopy. I haven't used that, but I can imagine that probably can be utilized for the same candy cane phenomenon in case you encounter the situation. So to summarize, ladies and gentlemen, EDGE, it carries a high technical and clinical success rate. Consider single session EDGE for urgent indications only. I think if you are going single session, go 20 millimeter, try to secure it. I think one thing I would like to point is, if there's a patient who needs urgent emergent biliary decompression, it's absolutely okay to get the patient PTC first. And then you can bring the patient back to remove the stones, take the gallbladder stones out, whatever you need to do. And that's an absolutely reasonable option. Persistent fistula, if you leave the stent in longer, especially more than a month, and if you are using 20 millimeter lamps, if you're taking the lamps out, try to use the mucosal denudation method that promotes the fistula closure more predictably. Right now, we don't have standardized tools and techniques. I showed you several variations of this, and we don't have a lot of prospective data, and it's currently not FDA approved, the lamps for this particular indication. So back to our patient, as I said, when we are in Valladolid, you do what is all EUS guided. This patient, I did EUS guided jejunal gastrostomy. Again, we did the two-step procedure, placed a 15 millimeter lamps. We brought the patient back, did the ERCP, removed the CBD stones out, did the gallbladder drainage. So this is, we are going through the first lamp, which was in the Roux limb. And through the direct cholecystoscopy, we did EHL of the large gallbladder stones, removed it. We removed both the lamps at the end of the session. And patient has been doing well. It's been a couple years, and he actually emigrated to Portugal and is living his life. So that's a large stone we removed with EHL. So that's all I have. Thank you so much, ladies and gentlemen.
Pralim, excellent presentation.
Thank you.
Gastric bypass has been practiced all over the world extensively in the last 25, 30 years. And now we're seeing some patients that need a reversal. So it's a medium, half of an edge. But now we want the fistula to keep open. What will be your approach to this? Because experts' approach, despite evidence, it is lovely. We're not going to tell anyone. Just tell us what you think.
So where you want the fistula to stay open,
Yeah.
leave the lamps in longer. So there are patients actually who we have done, we put the lamps in intentionally. Some we have actually done an resection next to it to widen the fistula, to practically reverse the lamps. Some we have gone on to do, depending upon where you are creating the fistula, how close you are to the staple suture line, more of a fistulotomy as well, along with the lumen-opposing metal stent and tendon. So in just handful of the cases where they are becoming, quite malnourished, they need the reversal, but they are not a surgical candidate.
Do you think those patients maybe will need a G-point? Because many of these patients had a cut.
Yes. So for reversal, that's what I meant. We've done the deep, I meant dissection, not resection, and the fistulotomy to widen the fistula that we had created with the lamps.
In those cases, would you be focused on doing a gastrogastric, or you can choose
Gastrogastric.
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 And is your preference, as I heard, that your preference is when
From
you're
the
doing
limb.
H from the limb?
Yes, I go from the rule limb intentionally.
That's very interesting. That's interesting. That's disruptive. That's different, and that's a very good tip. Preguntas?
Excellent lecture. Congratulations.
Thank you.
So actually, I have question in the opposite. If the fistula is closed, and then patients require ERCP again, how difficult that you will have to redo the GJ or JJ again?
Yeah, good question. So if I anticipate, I've done procedures where you feel like patient with pancreas divisum, patients with chronic pancreatitis, etc., where they may need. So I leave 7 French double pigtail stent across the fistula tract in them. And then again, it's just a matter of taking it out, balloon dilating it to this, and do the procedure. Yeah.
But if you don't leave, do you think it would be more difficult?
No, I think
or
then it's just like, putting a peg tube, right? If patient, they had a previous peg, you try to avoid the same peg site because you don't know how it's going to go. If I didn't leave any stent in, then I'll just treat it as a new edge procedure.
Can I have a question? So, thank you for a very excellent lecture. And I understand some controversy about strategy. So, please give your institution the strategy, the single or second step H, or also when you remove the lamps in your institution.
Oh, yes, okay. So at our institution, I think I'm predominantly doing majority of the edges. I do 2-step.
2 steps.
I've done 1 step, but in only those patients where the indication is just, simple EGD to look at the remnant stomach for bleeding or ulcers, where I'm not using a bigger scope, EUS, ERCP, the risk of dislodgement is much less. And I try to secure it with either over the scope clip, things like that, even for those patients. And then I try to take the lamps out within a month. My goal is always, I bring them patient back. If I need 1 hour, 2 hours, 3 hours, I block enough time for the procedure, so I get it done and remove the lamps out in a month.
Is there any patient to longer placement of the lamps, the patient condition? The regularly is a month, but some patients require the longer time to
Yes.
create a
So what are the challenges? So have I left it longer where patient need more than 1 procedure? Yes. I mean, sometimes I notice patients, they complain more of biliogastric reflux, they complain more of nausea, they're not tuned into that. So yes, those are some of the challenges and symptoms patients may have because of indwelling time.
Okay. When you do 1 step, what's your preference for fixation?
Oh, everything that I can do. So
okay,
suture it, clip, yeah. Suture it and clip on a Vesco clip it.
Great. Thank you very much.
Thank you.
It's been a pleasure. It's my pleasure to invite Dr. Rustic Kunda, who doesn't need any presentation. He's a benefactor of modern endoscopy all over the world. We all know him very well, and we appreciate him to come to teach us once again.
Thank you, Alberto, for a very kind introduction. For some mysterious reason, I've got this political/diplomatic presentation as the title of this, rather than scientific. So if I speak 15 minutes and say nothing like politicians do, so pardon me for that. But we had like a bunch of, you know, world-class speakers throughout these couple of days. So we have heard a lot of things about different topics and techniques in interventional endoscopic ultrasound and interventional HPB endoscopy. I have a bunch of slides. I will skip through some of them because you have heard certain figures, numbers, research results, and I will focus on that. What Manolo asked me to talk about is about building that joint surgical and endoscopic trust and building these strategies. I really do not know if I'm such a big diplomat, but the matter of fact is that I have been asked by colleagues in Italy, Spain, France, Switzerland, Germany, also in the United States and other countries, even in Southeast Asia, to kind of like promote this mutual communication in the field of interventional HPB endoscopy, and particularly with the boost of interventional EUS. I have a lot of conflicts of interest which are listed. We know that interventional endoscopic ultrasound has been around for quite a while, and we date some procedures as long as 30 years ago. They have been done in relatively small volumes, or they've been anecdotal, but with relative high risk of adverse events reported. But even then, they didn't created so much discussion as now, as we see, and you have heard from Michiel Brunswijk. You will hear also from Ryan Lowe that we have and other speakers you heard already, that we have procedures with relatively low adverse events, even lower than surgical procedures or duodenal stenting or interventional radiology, but still it creates much bigger discussions in between GI, interventional radiologists, intensivists, oncologists, and other specialties. So what is very important is that with HPV interventional EUS and interventional HPV endoscopy in this last particularly 13 years, we are creating a completely new field which is redefined and reinventing HPV surgery and endoscopy. We have seen and demonstrated over these couple of days how highly beneficial it is in cases of surgically altered anatomy, where otherwise standard endoscopic or even surgical or radiological approach would be challenging or yielding high risk of adverse events, or even could be completely impossible. Some of these techniques, as you have again seen over the last couple of days, present completely new approach, and they are pushing envelope or cutting the edge of the field. They require strictly, and I always promote, to use multidisciplinary approach, especially if you are starting and if you are engaging these procedures, not only in between surgeons and GIs, but involve your oncologists, intensivists, interventional radiologists. Everybody should be on board to understand not only what you are doing, but how you are doing, how you are dealing with adverse events or unplanned procedural events. Procedures shouldn't be seen essentially as a competing with the other surgical or radiological techniques, but rather complementing, and try to find within your institutions algorithms which patients go there based on different variables, and try to identify. And I will speak a little bit about it in regard every indication and major procedure we have seen. Many of these procedures can be performed also fluoroless, and many of these maybe in the future will replace the surgical or radiological procedures. But what Michiel said, you know, now we are coming into the age where we need to come with the scientific proof, with the randomized controlled trials, prospective trials, and prove this, that they can really replace. When you do these procedures, do your proper statistics, register your procedures, look at the proper classifications and count of your adverse events. Regardless if you are using lexicon or by SGE, or you are using novel classification coming from the Netherlands called EGRI classification, or even how surgeons are classifying their complications. And what is most important, and what we have seen even, we see perpetually during these conferences and these live demonstrations, distinguish what is the adverse events and what is unplanned procedural event, where we basically create pneumoperitoneum when we are doing peritoneoscopy. All of these events where we intentionally access the third space, which would be seen decades ago as a major complication. But now if you deal with it and if you properly manage it, you don't have to be worried, and it doesn't affect and it doesn't fall in those categories as defined by a lexicon or EGRI classification as an adverse event. So it's very important to distinguish in your documentation, in your count of your procedure, or register of your procedures, what it really is, and especially spread this agenda in between surgeons, radiologists, so they know that if there is a free air, if there is a carbon dioxide in the peritoneum, this doesn't essentially mean there is perforation, but it's just a residuum after your procedure. Very popular term we are hearing every single day, that we are shifting the paradigm, and that's really the truth, because you have seen again almost with every single procedure that we are pushing that envelope a little bit farther on. And Alberto Largi, used this to demonstrate, how we shifted paradigm in peripancreatic fluid collections, starting with a simple gastroscopies without any ultrasound, just looking for the bulging, in the stomach, and blind punctures. It's really not only about SEMS, but we have to acknowledge that, about LEMS, but we have to acknowledge that by the introduction of LEMS, it came like the major boost, a major, let's say, revolutionizing in terms of volumes and indications and creativity in the field. It really boosted it. Later on, we getting new, and we're hoping for more and more new devices. The concept is novel and creates really not stenting, but it's really anastomosing device. In HPB endoscopy, because this is the major topic of this conference, we have really various approaches which we are applying, and then we need to understand our protocols when we are applying and when we are using this. In case of failed ERCPs, we are using EUS-guided hepatogastrostomies or EUS-guided colodochodonostomies. And altogether with your surgeons, you need to come in the understanding, where do we stand, what do we do, what do we perform, when this particle anastomosis is more appropriate or less appropriate. And very important, what I would like to say as the bottom line is that many things we are doing in interventional endoscopic ultrasound is more by convention, that we started in that starting point, that this is for inoperable patients, non-surgical candidates, and so on. But there is no evidence for that. We just started there, and we can now, and we are already started like a randomized control trials, looking also for patients who are operable. We have data from Italy, we have data from our own center when we are applying this also in operable patients, and it doesn't preclude safe lipo pancreatectomy, safe gastric surgery, safe liver transplantation. So you can apply also these extraluminal and third space endoscopy also in surgical candidates. So don't be afraid to challenge, but with close cooperation, also your multidisciplinary team and with these procedures. I will skip over certain data because you have heard them over the last days, but basically showing, where the benefit of every single procedure and even question mark stand for. With EUS-guided colostomy is very comfortable. It's painless procedure for patients. It can be done in sedation. It's very short. Doesn't create any pancreatitis. What is very important, it is very efficient procedure, but you need to be sure that there is no gastric artery obstruction, which affects then function of the colodochodonal stem. As I'm saying, when you are registering, keep track from the procedure one. What is your outcome in terms of clinical success, in terms of technical success, and particularly what are your adverse events, as we always do, at least for the first 5 years, even if you are not publishing it and you are not aiming for the scientific outcomes. This is another trial we did, another randomized control trial with Anthony Theo, looking about colodochodonostomy. We know the data from other centers arguing about this. But it's very important to find the place where colodochodonostomy is fitting better than hepatic gastrostomy, and what is also opinion of your surgeon, eventually even transplant, hepatology specialist, and how we are dealing with particular situation. We are using interventional biliary endoscopy, interventional biliary pancreatic endoscopy in terms of interventional EUS also frequently to deal nowadays with the complications of pancreatic and biliary surgery. I had myself recently dehiscence of 3 biliary anastomosis and 1 pancreatic anastomosis in one single patient. So basically all anastomosis because of bleeding were gone. And you can still safely manage it with endoscopy, but you really need to be vigilant. You need to have all the team, on standby. Is it something which needs additional drainage? Will we do it with additional surgical revision and so on? And obviously we are developing new tools to provide safer and better drainages. In theory, the comparison of cholelocholenostomy beyond presence or absence of gastrogallbladder obstruction is rather similar, and the choice of procedures should be perhaps focused where the stricture is. So again, you need to discuss with your radiologist unless you are able to really determine by yourself with your surgeon what is the most appropriate. We developed algorithm which is really based on the locational stricture, presence of surgically or non-surgically altered anatomy and accessibility of papilla, and using different approach in terms of choledochordanostomy, hepaticogastrostomy, or even other different approaches like antegrade and bridging from left to right liver lobe. The similar thing is with the gallbladder cases. You had another excellent presentation during this event, so I will not go into all the details. But obviously there have been already randomized controlled trials. Now is ongoing DREC2 trial, and it's prepared also DREC3 trial, also coming from Hong Kong, where we are cooperating, showing really safety in all these procedures in non-surgical candidates. Never forget what I said in the beginning, that these procedures are complementary rather than competing. You still have, and we have discussed it multiple times also today, that there is still place for PTGBD, there is place for transpapillary drainage of gallbladder, and there are also other things, other ways how to drain gallbladder than LAMS, despite that we strongly advocate for LAMS in this case. We have seen beautiful demonstration by Sensei Isayama earlier today of gallbladder drainage, but it's not always, as simple. You have these difficult gallbladders. So even we also address other issues where we are trying to push a little bit envelope and look in those patients who are operable or they are younger and they need stents for longer time. We presented it on DDW or ESG days or also other events, looking at more proactive approach rather than keeping these stents as a permanently indwelling, because they are not approved and even designed as a permanently indwelling. So what we are doing, we are in 6 weeks, we are performing direct peral cholecystoscopy, and we are verifying if there is any presence of remnant stones or if stones are completely gone. In almost over 76%, they are spontaneously already all of them gone. In more than 23%, you need to seek for some help and perform electrohydraulic lithotripsy or other form of lithotripsy and clean the gallbladder and try to remove the LAMS. The rationale is to basically remove the LAMS, not to keep it as a permanent drainage, especially in those patients who have longer survival. But again, this should be addressed not with the retrospective data, but we are looking and we have already prepared a randomized control trial addressing this issue. What is very important that after applying this strategy with median follow-ups of 777 days, we have only recurrent cholecystitis in less than 3% of patients. The similar issue and discussion is how is it with cholecystectomy? I've got this question very often from all around the world with these patients. And again, we took 81 consecutive cases where we really applied EUS guided goblet drainage in operable patients. After the cooling down of inflammation, we performed cholecystectomy. We analyzed all different variables of handling fistula, closing fistula, or spontaneous closure. We looked at the cholecystectomy, which was how it was technically feasible with median operation time of 44 minutes. We observed only 3.7% of adverse events. So if you look at the data, how it is in literature, in PTGBD, it's even more favorable. And we even before published in 2018 another small, though retrospective data, showing that cholecystectomy following EUS-guided goblet drainage is actually faster than following PTGBD. So again, it's controversial, but it's doable. And what is very important that LEMS creates very nice anastomosis, which is not fibrotic and can be very easily peeled out and either sutured over with a V-lock, either through robotic or laparoscopic surgery, or you can just staple it as in this case. So it's again looking where are the options? Should we stick with the convention for inoperable and patient with limited life expectancy, and should we offer this to wider amount of people? I certainly believe that we should explore it, though I do not believe that this is something which would replace eventually cholecystectomy. Again, there was a wide discussion about EUS-guided GEA. Attempt to do EPAS, where majorly we perform West procedure throughout these couple of days. But it's very important to understand there are options, and your surgeons or your radiologists, your intensivists, they all need to know how this is done, what might be the risk, and what is the outcome, where is the anastomosis placed, how does this transport eventually affect the operational field, because if you have like a blindsided surgeon, they would have even trouble to look where the anastomosis is, how it affects field. Now, if I have a patient who is even operable candidate for duodenal-pancreatectomy, for much favorable in terms of adverse events in comparison to enteral stenting and surgery. Obviously, as a retrospective, it has some limitations. Learn, and you have seen today very nice demonstration with Sensei Ogura how to deal with this difficult when it comes, when it falls into procedural unplanned event, or are we dealing with adverse event when we have seen the patient with the ascites, with a punctured bowel, and how to deal with it. Very last topic, best for the last, Ryan Lowe will talk about the access on anastomosis. And it's something which is rapidly evolving. Now I see 2 to 3 patients every week where you have surgical altered anatomy and you have stricture in anastomosis after hepaticojejunostomy or different other anatomical variants after biliopancreatic surgery or HPB surgery. So the aim is that you are creating temporary access anastomosis to come to the biliary limb and just simply use this bypass, the temporary or permanent, to access this. There have been published some data, small retrospective, but we also reported this collaborative study with Valladolid and my center, and now we are revisiting data and publishing even more, doubled in the amount of patients. Create protocols for your patients, within institution, how you are dealing, when we are talking about how to deal with gastric bypass patients. We really look not only about the edge, but we also look if patient has a present gallbladder in the gallbladder stones, how big stones are, how many they are. Is it a big stone? Because not everything is really suitable for edge, or you really need to do also cholecystectomy. So it's easy to perform also laparoscopic assisted ERCP still this way, and look about the cost efficiency of the whole process. So that's another example. It was already pointed out, and ESG guidelines and technical review also refers to the resolution of adverse events. So I also highly recommend. In terms of pancreas, learn from your surgeons that there are around 11 different variations of surgical procedures, how you reconstruct, how you operate your pancreas. So don't deal and understand the anatomy, because it also affects your approach. And I will skip this, and just the last considerations. You know, again, bottom line of this diplomatic speech should be really look at what is adverse event and what is unplanned procedural events, make everybody aware of it, classify properly your adverse events where they fall, learn about your boundaries and limitations, institutional, do you have all the specialties on site, and also equipment-wise, do you have everything on site, or are you lacking some instruments or tools to deal with certain situations? So think ahead, several steps even ahead. Do not essentially reinvent what is already invented, and really collaborate across the specialties. So do not actually shift back or reverse shifting of paradigm. Multidisciplinary approach is mandatory. It's not just only meeting couple of times a week and have some kind of multidisciplinary discussion, but it should be perpetual 24/7 conversation. Again, these techniques are complementing rather than competing. Learn mutually what you do and what you want to do, create and communicate your ideal algorithms, which may be different from institution to institution, because only that leads to success. In Scandinavia, it's rather non-competing, and we work seamlessly across specialties as one team, radiologists, surgeons, GIs. But in many countries, this is also a matter of competition, matter of income, matter of creating your budgeting, and so on and so on. So EUS guided interventional EUS is not only for non-surgical candidates, but we are trying to explore field further and revisit those currently proclaimed conventions. Stay curious and strive in development in this, and stay in best communication across your specialty. But it goes beyond the surgery, and GI involves also other specialties I mentioned as an oncologist, intensivist, interventional radiologist, and others. Thank you for your attention.
As expected, Rusty, Magister presentation, thank you very much. I got a question for you. Despite data, do you expect gallbladder EUS drainage could replace elective surgery in patients asymptomatic with gallstones?
Yeah, I do believe that in that case, yes, we need to explore it. We need to look at the data, but I believe there is a way, but we need to really step forward. And initial data suggests that the recurrence rate is minimal, but really we are talking about asymptomatic, so it really requires wider consensus. But I do believe that might be the way. But I do not believe that we have a tool in hand which will replace cholecystectomy, not at all.
Okay. Well, we got a paradigm that is 150 years ago. You enter the School of Medicine, and next day you learn gallbladder must be removed.
Yeah, but I think that era is over, and many things, students are coming out of the medical schools, and even those which came out of medical schools 10 years ago, they didn't hear anything what we are doing here. The progress in our field is so remarkable. We are living exceptionally exciting time, and I certainly believe that it's even more coming. We know that we are standing at the gate of flexible robotic surgery. We know the project from Southeast Asia, we know the project from Italy, we know the project from the United States, which will even widen our possibilities and, let's say, cross boundaries within gastrosurgical field. Should we call it some fancy name, whatever, but doesn't matter. But we know that we have these tools at hand, and they are functional. We know that, we have seen them, we tried them already. And I think that it's something which will push us ahead.
Any other questions?
Yeah, I have a question. So ERCP is 55 years old, and it's very mature, and there's a lot of skilled therapeutic endoscopists who do very good ERCP, biliary stenting, duodenal stenting. Can you comment on what you think the learning curve, what it would take for, I mean, you're super experts here in interventional EOS, but I mean, for the average good therapeutic endoscopist to get to that level of being comfortable with CDS and...
Yes, it's excellent question because that's really, I do believe, and it's also very important to take home message from this course. You know, like interventional endoscopies in the field of HPB needs to command both ERCP and EUS. But we also know that skills in EUS and understanding of EUS anatomy, if we are not even talking about interventional EUS, is very high, and there is very good accessibility for training for EUS almost worldwide. There is not major, at least in developed countries, there is no problem to access to this training. Whereas for ERCP, it's much more challenging. The number of cases which are more centralized is, let's say, decreasing. Cases are more and more challenging or require even combined approach. Actually, majority of our cases we see now are some kind of a combination of EUS and ERCP. You know, simple, you know, case tones, they stay even ahead of, away from referral centers. So I do not think that it's much challenge in EUS training as such, you know, at least understanding the anatomy and commanding the principles of EUS. But the interventional HPB endoscopy, including ERCP, that's more challenging. I think that almost calls for some kind of subspecialty because not everybody can be trained properly. And we've seen it already for many years that instead of volume-based training, we really need to stick with competence-based training because nobody is able to reach those old volumes of hundreds of procedures. Not with that current demand and especially evolving field. But it's really important that we continue. We see all that benefit. I'm a HPB surgeon, so for me it's a first-hand tool to help myself have patient ready, best way for the surgery, but also deal with when something goes south.
Okay, wonderful lecture. So, and I want to hear the surgeon's perspective about cholecystectomy. So, USGBD is now indicated for the palliative cases and also a candidate for the perioperative. But maybe more sophisticated procedure about USGBD, some following the trans-lams lithotomy. So, in the future, can this procedure, instead of the cholecystectomy, how do you think about it?
I think we cannot completely eliminate cholecystectomy. Cholecystectomy will be always present. I'm not on that side. We know that patients are coming in a different stage of cholecystitis. I would even think that maybe it's a time now to revisit, Tokyo guidelines and look again it, because we have new tools at hand, and we know that's an excellent tool to guide us. But what we also know that the application and sticking with the guidelines much more differs from country to country, and in some countries even from region to region, because there is an institutional difference how we do it, and we cannot neglect how big impact it has this new evolution and even coming to before this we used to do transcystic drainage, but we really talk about it right now. It's a still good tool to use it. So we need to a little bit revisit, really who is going and at what point of surgery. You still, in European centers, there is a huge discrepancy. What is the cooling period and when cholecystectomy should be performed? So that sticking up with the guidelines, it's still not there. I don't know if I'm daring too much, but I do believe that we have so many tools now at hand that we need to go beyond this and really look what to do with operable patients who may really benefit from this and avoid cholecystectomy. but not completely. I'm afraid not.
Okay.
Thank you very much, Dr. Kunda. Fantastic presentation. Dr. Ryan is the next player. He has the commitment to close the event. He had a lot of work yesterday. He will talk about transjejunal ERCP in patients with previous surgery and anastomosis from biliary tract and small bowel.
Sí, claro. Sí.
So thank you again to the Congress for the invitation. This is certainly an amazing course. So my goal today in the next 10 to 15 minutes is to talk about EUS-guided transenteric ERCP in patients with post-surgical anatomy. My disclosures. So over this time, we're going to talk about the approach to ED in patients with surgically altered anatomy. We're also going to talk about specific procedural techniques and considerations prior to doing these procedures. Finally, we'll finish with available outcomes. I will admit there is not a whole lot of high-quality data on this particular subject, and we'll talk some more about why that is. So as you've all seen over the last 48 hours, the role of therapeutic EUS is incredible. It evolves at a rapid rate, and it's become an immensely powerful tool for us to take care of patients with GI and hepatopancreatic biliary disease in a less invasive way. EUS-guided transenteric ERCP, as it stands in 2023, is creating an enteroenteric anastomosis to permit ERCP in patients with, generally speaking, non-Roux-en-Y gastric bypass anatomy. As Dr. Chahal had mentioned, EDGE remains kind of the mainstay of EUS-guided therapy for patients with gastric bypass. These procedures, as you all have seen, require an advanced EUS skill set and are technically challenging to perform. So what we're talking about in most sense is performing an enteroenteral anastomosis using the schematic, I believe from the Mohan Kashab paper, in a patient with liver transplant with Roux-en-Y hepatocogegenostomy. That's kind of the base case of where procedures like this began and then have now continued to evolve from there. So you can use the duodenal bulb to access an adjacent limb of bowel. You can also use other small bowel locations. People have described using EUS-guided duodenogegenostomy in the setting of pancreatic tail cancer that obliterates the fourth portion of the duodenum. There's a variety of procedures that kind of fit in this box. I tend to look at these procedures as a technical approach most mirrors EUS-guided gastroenterostomy in terms of visualization, at least how I perform them, I think how most of us perform them. And as I stated, there's really limited data on these procedures, and the data that we have is very heterogeneous in terms of what people 5 years ago feel like fits in this category and kind of what we think fits in these categories today. Outside of a few studies, it's limited to case reports and small case series. So what patients really are we talking about? Surgical anatomy you may encounter when you're considering these procedures include patients with Whipple anatomy or Billroth 2. Obviously, all of us are seeing less and less Billroth 2 patients, but there's still a few out there. Non-gastric bypass Roux-en-Y anatomy, such as a subtotal gastrectomy or liver transplant with a Roux-en-Y hepatocogegenostomy. And I included Roux-en-Y gastric bypass, but only in the setting of patients who had a prior sleeve gastrectomy. There's a portion of patients that we see in the US who go for a laparoscopic vertical sleeve gastrectomy first and then are subsequently converted to a Roux-en-Y after that. I will tell you that EDGE in those patients is extraordinarily challenging. You have a very small target to work with, and trying to create an anastomosis that allows you enough room to pass a duodenoscope or an echoendoscope through the pylorus is exceptionally challenging. So in those cases, doing an enteral anastomosis may be an option. And then the other group of patients that I think we all see are the patients who show up and all you know is that they've had multiple surgical procedures that involve revising their GI tract. So if you're able to identify at least partially what their anatomy is or kind of where things stand with them, enteral anastomosis can be another powerful option for them as well. So what I had mentioned previously, in earlier studies, some of the small case series included drainage of obstructed afferent limb after a Whipple procedure. I'm not sure that that fits in the paradigm in 2023. You know, technically that's still a gastrojejunectomy, but it's kind of its own thing. I don't think it's an EDI procedure, but these procedures can be used to not only perform pancreaticobiliary interventions, but also any luminal interventions in an adjacent limb or draining an obstructed limb adjacent to wherever you can get your US scope. So we'll kind of work through a case here, which I think is a good kind of description, just to kind of set the stage. This is a patient who had total gastrectomy for gastric cancer with an esophagojejunostomy. Subsequently developed a retroperitoneal process that was very difficult to prove that it was recurrent cancer, despite all of us thinking that for a long time. That obliterated her distal bile duct, created a tremendous stricture, also created stricturing of her ureters. So she has, start to play the video here, she has bilateral nephrostomy tubes and a percutaneous biliary drain at this point. I was able to pass the echoendoscope down beyond the anastomosis in an amazing fashion, probably 20 centimeters beyond the anastomosis, maybe 30. What I saw was what I think is the ligament detritus, very close to the biliary drain, and we were able to create an anastomosis there that we subsequently did go through the same day. This is a 15 millimeter Axios that we dilated, actually over dilated to allow scope passage. As we've had discussions about using a 15 or a 20, we used a 15 here because we knew our subsequent procedures were going to be done with a gastroscope and not with an echoendoscope or ERCP scope. One thing I'd like to highlight on this case is utilizing the biliary drain. So in many of these patients, they may end up with a biliary drain when they come to you. That's an important tool that you can utilize to distend the bowel, to give yourself a target. You can also do it in a similar fashion that we do gastrojejunectomy with the nasobiliary drain to kind of artificially inflate your target, or a direct puncture with a 19 gauge needle. An infusion works as well. But I would, the comment I had made earlier about using the biliary drain, I think you do have to be careful infusing through a catheter that still has side holes in the liver. You can create a bile leak, certainly some bile inside the liver capsule. So we always switch to a Cook Maclock drain that only has side holes on the pigtail, and then pass it deep in the small bowel when we're using this approach. So now that you have your anastomosis, the question becomes the timing of your intervention. You can go through it right away. That has some potentially uncertain risks as you're talking about small bowel to small bowel anastomosis. You can use a stent fix or other clipping mechanisms to try and hold your stent in place. Oftentimes, these anastomoses may be out of reach of a gastroscope for creation of, or to be able to suture it in place, or it may be difficult to reach that with the double channel gastroscope for endoscopic suturing. So if you're going to go through it in stage one, in a single stage, then balloon dilation to 20 millimeters, and just recognizing that there's some risk with doing so, maybe leaving a safety wire as you withdraw the scope. And then the patient will subsequently need a follow-up intervention to remove the lumen-opposing stent or keep it patent for subsequent biliary or pancreas interventions. Alternatively, similar to edge procedures, these can be delayed into 2 stages where the lambs can naturally dilate. Procedure can be performed 2 to 4 weeks later. I think there's a huge variation in what people feel comfortable doing in terms of going through a lumen-opposing metal stent, immediate versus waiting a couple weeks. We really don't have a lot of data to suggest how long it takes for that track to kind of be mature and be stable enough to put tension on the anastomosis or the stent. And again, similar, the lambs can be removed and the hole either left open or closed in the future. So going back to this patient, once I put the gastroscope through the lumen-opposing metal stent, I was staring at the biliary drain, but there's a stricture in the way, a significant stricture that precluded me to get close to the anastomosis. And I didn't really feel compelled to push it in this patient. I knew that the percutaneous tract was solid. So what we ended up doing was removing the drain over a wire and just percutaneously placing a biliary stent into the small bowel. Now, the concern we had was if we just left the patient alone, she would be a setup for recurrent cholangitis because it wouldn't drain downstream from where we just placed this biliary stent. So then we subsequently elected to place a duodenal stent that took us back to our lumen-opposing metal stent. This was a 22 millimeter by 6 centimeter uncovered stent, given that the patient had recurrent gastric cancer. And go back. And that's kind of how it was left. As you can see, there's a lot going on with the other nephrostomy tubes, but this was done maybe a month ago and the patient continues to do well, has not been back to the hospital since, previously had recurrent cholangitis. So when we look at data that's available, again, not a whole lot. This is a study from Johns Hopkins, 18 patients, and kind of the most important takeaways are EUS technical success of 100% and technical success of ERCP of nearly 95%. And I think that hits home that these patients can be managed non-operatively and without biliary drains. These procedures are technically doable, but not without risk. As you can see here, maybe speaking to the perceived risk of the procedure, only 4 patients were done in a single session. An additional study out of Italy, again with a relatively heterogeneous population, showed a very high success rate in reaching the biliary anastomosis, performing successful ERCP, and having a good clinical outcome. Not without a 12% risk of long-term adverse events, minimal short-term adverse events or procedural adverse events, and I think this just, again, speaks to the idea that we're making significant headway into what we can offer. So I promised Ramon a short talk, so that's what he gets. So in conclusion, EUS-guided luminal anastomosis creation, incredibly invaluable in our patients with surgically altered anatomy without availability for conventional procedures. ED requires careful preparation and some risk tolerance if you're going to take on these cases. Patients should certainly be counseled for risks, benefits, alternatives, all those things, and have extensive discussion before the procedure. The use of lambs in this remains off-label. That's something they need to be aware of, but I still think it's the right thing to do for patients in dire straits. And I would advise extreme caution in performing single-stage procedures. Just be aware what potentially could happen and be prepared should those things happen. So with that, I will take any questions.
Thank you, Ryan. Excellent presentation. I want to know if you guys have some experience with your new stents, biodegradable. I know you, Andrea, you guys have that experience with the biodegradable stents. Okay. If you have a good biodegradable stent, would you still prefer doing this transjejunal, or you will go gastric hepatic?
To me, I would generally prefer to go gastrohepatic in any way that I can.
Okay.
So I think that if that's an option, a good option, that's preferential. I think the benefit of gastrohepatic access is just the repeatability of being able to go through that tract for as long as you want to keep it open. In this particular instance, there's no real downside for the patient I described of placing LAMS long term, because she's likely not going to live all that long, unfortunately. So you just leave it in, and whatever you need to do in the future. You know, our big goal, I think, with these procedures, at least mine, is to have as few patients that have percutaneous drains as possible. I think one of the biggest things that we take for granted is the assumption that placing a percutaneous drain is not all that big of an intervention. I think for patients, it's an incredibly big intervention, and patients, you know, hate it. It's poor quality of life in a group of patients who have very little life left to live. So that's kind of been my personal mission, is to minimize the number of percutaneous drains that go into patients.
Okay, what is the longest patency of an Axios, a LAMS that you have placed?
I can think of at least one patient where it still looked intact and had not delaminated after 18 months. But I have to say that after, I probably take a look around a year to make sure that it's still intact and not overgrown and doesn't need to be intervened upon. I know some people have recommended when you do you know, anastomotic procedures, replacing it once a year or every 8 months, or different protocols that are out there. I think that you have to at least look and make sure that it's still intact and not grown in. But that's a question I bet if you ask the room, there's probably 20 different answers out there.
Okay.
Right, ma'am. Ryan, very excellent lecture. Congratulations. So the EDE is kind of like a little bit complicated, extremely careful, went into small bowel with a side view echo endoscope. So in your practice, would you try balloon assisted first and then EN fail, then you come to the EDE, or you just go directly to EDE?
No, we don't. So I guess I would tell you in my practice, and I think many people's practice, patients like that are relatively not common. The other thing I would say is that particular patient, what I did not tell you is we had tried to get to her bile duct so many ways to try and get a diagnosis for recurrent cancer. We tried to go with a pediatric colonoscope. We tried to go with an enteroscope. We actually had IR leave us a wire to try and do a IR-GI rendezvous. Could not get there. We put a percutaneous drain in, did percutaneous cholangioscopy to biopsy the stricture. So that kind of speaks to the lengths that I think generally we should be going before doing big interventions that carry a reasonable amount of risk.
Any other question? Ryan, thank you very much. Best way to close the event. The boss is here. Andrea, how have you done with those biodegradable stents? Have you used it widely?
Microphone.
Well, I'm pretty happy, although we still need to go ahead to find a new shape, a new way of treatment. Definitely the costs are still too high, at least in our country. We don't have the reimbursement, but the idea of not having the need to come back to the patients to remove the stent, to change, could be really interesting, especially when we have to face fragile patients and stuff like that. So I hope that in the future also LAMS could be done like this. You like this? I saw from your face, and hopefully something will arrive that will help us, especially in the benign condition, which I think is the new frontier for the biliopancreatic endoscopy. Yes, actually, maybe the main indication is prophylactic stent for post-ERCP pancreatitis that you can place and just leave it without any thinking about removal. Or
How long do they last?
Depending, you have 3 lasting time. The short one, that is 2 weeks. The medium one, that is 3 weeks, and the long one, that is 3 months. So you have plenty of choice. Okay? Thank you.
Next course, you will choose. You will choose one of those. Show one of those.
Thank you, everyone. The survivors, you've made it until here. Muchas gracias a todos los que habéis estado, aunque veo mayoría de gente que no habla español. O no sé qué tendrán los viernes para nosotros. There's a lot of people to thank. First you, then industry, patients, the hospital, the fellows. But I'm going to cut to the chase and give you the follow-up. We've tried to illustrate with lectures what we've shown or demonstrated with live cases and try to make it as parallel as possible. So as for the outcome of the cases of yesterday in session 1, there was an intradiverticular papilla with common bile duct stone that Dr. Law did a rendezvous, so-called classical rendezvous. He attempted first parallel cannulation, and then sphincterotomy could not be completed because the patient had some coagulopathy, and we saw hemophilia during puncture of the bile duct. Nonetheless, a patient was drained with a plastic stent and no adverse events. This procedure needs to be completed at a follow-up session in a week or two. Then there was a gastric, Roux-en-Y gastric bypass patient. It was single section edge was performed, but Dr. Chahal, procedure went relatively uneventful, and even if the stent remained in the pouch after the ERCP was completed, patients started having pain in the afternoon, evening. We tried to bridge the gap. The axios proximal flange had migrated into the peritoneum. We bridged that with tubular esophageal colonic SEMS, but eventually she failed to improve, and in the early morning she was taken to the OR, and that's the only severe complications that we had in the 20 or so procedures. Patient is in the post-op ICU recovering. She had bile peritonitis. Then a patient with bile duct stones after Roux-en-Y hepaticogastrostomy was done by Dr. Ogura with a long, fully covered 8 millimeter and 12 centimeter stent. So drainage was successful, no adverse events. That day, same day, we had a pancreatic adenocarcinoma type 3, Mutignani type 3 stricture. So those are typically very challenging. It was very labor intensive, but eventually it was successful and no adverse events with gastroenterostomy. We had another patient initially scheduled for double bypass. Gastrojejunostomy was quick and simple, but then hepaticogastrostomy could not be performed because the intrahepatic bile duct was not dilated. There was some puncture, some extravasation of contrast. We tried ERCP retrograde through the LAMS. We've reached the papilla. We were stabilizing a gastroscope with double wire, but we couldn't get deep cannulation, and the patient was at a 2-stage session today, successfully stented through a duodenal SEMS by Dr. Moon. Bleeding was in, even if the patient didn't require any transfusion, and the drop in hemoglobin was 1.5. from 12, from 9.5, I believe, or 10.5s. So, session 3, we had a patient that was referred to us with complete esophageal disconnection. Eventually, the disconnection was not complete, and just stenting and demonstration of retrograde access through the gastrostomy was done by Dr. Gornals. Then we had a patient with a complete bile duct injury at the hilum with a prior hepaticogastrostomy. This was scheduled for magnetic anastomosis with Dr. Lee. Eventually, rendezvous through cholangioscopy with Dr. Reimann was done, and the duct was reconnected at a 7 French plastic stent placed through and through from the papilla across the transection into the left hepatic and into the stomach. And this patient scheduled for a stent upgrade within 3 to 4 weeks. Patient is completely asymptomatic despite retroperitoneoscopy, which is a NOTES procedure because we were outside of the lumen. And then a 94-year-old lady with cholangitis, cholecystitis, was initially scheduled for gallbladder drainage in ERCP, but just ERCP was done, thinking that the stones were the only reason for her symptoms and that she didn't require prophylactic gallbladder drainage. Today, we finished that patient, Dr. Moon, the one I mentioned that couldn't be completed yesterday. And then we had another patient with cholangitis where antegrade drainage was done and gallbladder drainage. This time, Dr. Isayama was given more precise instructions about the gallbladder. Was not given a free range, so it was drained through the jejunum. And these patients are perfectly well, no pain, no fever, no symptoms. Then Dr. Siddiqui and Anderloni demonstrated the ED approach to gallbladder drainage through an indwelling prior existing LAMS, and very nicely also showed us how to reposition or displaced dislodged LAMS in a mature fistula. Patient is doing well. She's been sent home. And then, okay, who is this? Oh, this is the challenging case. Do we have the slides, Antonio? What is it? Okay, please show me. Oh, this is the 2 cases that I apologize to you and to the operators couldn't be shown till the end. So, ¿tienes un vídeo? ¿De cuál? Sí. So the case, please go ahead. There's only 2 cases that couldn't be shown. So it's a patient with a left hepatectomy for hydatid disease and indwelling external biliary drain and Roux-en-Y. So Dr. Ogura, there was no access to the intrahepatic bile duct. We couldn't advance the LAMS, the Axios catheter. Okay. We eventually chose. Sí, vamos a ver. It's too quick. No, you see, this was an eventful. The patient is feeling well, but what were the issues? It was a very interesting discussion. Okay. ¿Cómo se para esto? Ya. A ver, no, ayúdame un poco, porque esto de los Mac no me... Ahí está.
Sí, no, con el espaciador. Y con el espacio enciendes y paras.
Para ahí.
Para aquí.
So we are in the stomach or proximal jejunum. This is the afferent limb. This is the percutaneous catheter. We're putting fluid to distend this proximal jejunum. It was punctured with a 19-gauge needle, and O25 wire was in through the axios. So the thing is, the O25 wire had been placed into the afferent limb through an axios catheter. That necessarily means that the small bowel was pierced with a 10 French hot axios catheter. So there was a lot of discussion how to salvage this, because the axios catheter would not go deep into the bowel, So it was not deployed. We left a wire, and with a cystotome using no cautery, a 6 French, it was advanced deep into this limb. Contrast opacification was performed to ensure that we were not in the peritoneum, and then instead of using an Axios, which is very stiff, we use a Spaxus, which is more flexible, over the wire, and which is longer. You can push a Spaxus longer. So, and it was a brilliant salvage. You see, here you see the, and through the PERC drain we put some methylene blue to confirm, with contrast, to confirm there was no leakage. This is enterography with a stone extraction balloon, antegrade through the lamps, and there was no leakage on fluoro, and we saw all the methylene blue. So the patient still has the PERC drain. It needs to be internalized. Páralo aquí, Ramón, por favor. La última esa está muy bien.
Vale.
And so the idea, the plan is to call la última de rayos. Esa es. So this is injecting through the PERC drain, and no leakage, tight anastomosis. Problem is the only Spaxus we had was an 8 millimeters. So this is just to salvage the perforation, create a mature fistula, and we'll probably, there are several ways. The patient is scheduled for a follow-up endoscopy on Monday. Next Monday we'll probably put a baby scope through here, grab a wire from the PERC drain, and put a self-expandable metal stent. Patient has had no symptoms. And the last case is a patient with a Whipple, cholangitis, and she had the Whipple 23 years old, 19 years ago, and it was colonoscopy-based ERCP through a very long limb. Was tried by Dr. Van Ruch and Dr. Espinel and Rodrigo Soto. They reached the duodenal stamp, couldn't find the anastomosis. So right now, they left a nasobiliary drain in the duodenal stamp, long one, and we just did ED, putting fluid through the nasobiliary drain, finding the duodenal stamp. A 20 millimeter Axios was placed, and we went through with a gastroscope, saw the plastic tube that was coming and will be exchanged later. So it's too short to tell whether these patients will have any symptoms, but this is it. So some failures, one major complication, one minor, and some patients still to be followed up. So this is the summary. And again, muchas gracias a todos por estar aquí. Y nos vemos.
Gracias, Manolo, por permitirme cerrar esta quinta edición del curso del Valladolid. La verdad es que voy a ser muy breve, porque veo unas caras de cansados justificadas totalmente. Agradecer a todos los ponentes, a todos los internacionales, los casos tan espléndidos, vuestras presentaciones espléndidas también. Y, como no, agradecer a Manolo y a todo su equipo de la unidad el magnífico trabajo realizado en estos 2 días. Decir que desde la SED vamos a seguir apoyando indudablemente este curso, mientras a Manolo le queden fuerzas y ganas de seguir organizándolo, que no es tarea fácil. Y nos vemos, see you in the next Valladolid, in 2025, I hope. Okay?